Thank you. Okay. Good morning. Welcome to the third meeting of the Joint Interim Standing Committee on Health and Human Services on March 31st today. Secretary, will you please call roll?
Senator Danyate.
Here.
Senator Lang. Senator Titus.
Here.
Assemblymember Edgeworth. Assemblymember Goulding.
Here.
Assemblymember Hibbets. Assemblymember Nadim. Chair Brown-May.
Thank you. I am here. If you would please mark Assemblymember Hibbets present when he arrives, I would appreciate that. Thank you. Okay, welcome to this meeting. Before we begin, I have a number of housekeeping announcements. So first, as a reminder, please silence your electronic devices, cell phones, laptops throughout the meeting. Additionally, any presenters on Zoom, if we have come in throughout the day, to leave cameras off and microphones muted until the agenda item is called, and then we will direct questions directly to you. Agenda items today may be taken in a different order than listed, and two or more agenda items may be combined for consideration, and an item may be removed from this agenda, and discussion of an item on the agenda may be delayed at any time. The committee's meeting materials can be found on the Nevada Legislature's website. You can also sign up for electronic notifications related to the activity of this committee. If you wish to testify in person, please sign in at the table by the door and then leave a business card. And then when testifying in person, turn on the microphone to speak and off to listen. There are others that are listening, so it's important that we use our microphones today. With that, we will now move on to public comment. Public comment will be limited to 2 minutes. If you would like to make public comment, please come forward at this time. Staff will time each speaker during public comment to ensure that everyone has a fair opportunity to speak. In addition to testifying in person, members of the public may also provide public comment in various other ways, all of which are listed on the agenda. If you'd like to call in to provide testimony by telephone, please dial 888-475-4499, and then when prompted to provide the meeting ID, enter 876-3092-0944, and then press the pound sign when prompted to provide your participant ID. We will start with public comment for those here in our physical locations, and then move to, so we'll start here in Southern Nevada, move up to Carson City, and then go to the telephone line. So we'll go ahead and start here in Las Vegas. You may begin when you're ready.
Good morning, and thank you, Chair and the committee. I'm Nancy Bowen, CEO of the Nevada Primary Care Association. We represent the state's federally qualified health centers, or known as FQHCs. Our members provide high-quality, comprehensive care in patient-directed clinics that are open to all Nevadans, regardless of insurance status. In many of our clinics, comprehensive care includes clinical pharmacy services that allow pharmacists to manage chronic disease and other providers to serve more patients. This model, however, requires subsidies from other programs. And if the legislature were to pass the clinical pharmacy legislation proposed in item 10, our pharmacists would be able to be reimbursed. A key program that allows our health centers to provide services like clinical pharmacy is the 340B drug discount program. This program allows our members to receive discounted drugs due to their safety net status and earn revenue when they are billed at normal rates to private insurers. This clinical revenue stream has been essential to FQHC's ability to provide comprehensive services to all patients and to make care affordable to uninsured Nevadans. We urge this committee to expand clinical pharmacy and to protect 340B in federally qualified health centers. Thank you.
Good morning, Chair Brown-May and members of the committee. My name is Lee McAllister, McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics, representing 290 pediatricians and medical students dedicated to the health of all children. Regarding agenda item 6 today, we are relieved that the March 16th injunction vacated the January 2026 federal immunization schedule. This restores science-based standards and ensures Nevada families keep insurance coverage for life-saving vaccines. For agenda item 7 today, the Nevada AAP strongly supports a comprehensive ban on all flavored tobacco products. Flavors are starter kits to hook our kids. E-cigarettes are not safe medical tools and should not be sold with candy-like marketing. And finally, on agenda item 8, gun violence is the leading cause of death for children. We urge the committee to promote the gold standard for secure storage to address the tragic reality of the impulsive young mind. We are ready to work with you on these solutions. I have expanded upon these points in my written testimony submitted by email. Thank you for your commitment to our state's children.
Thank you. Is there anyone else here in Las Vegas who would like to offer public testimony at this time, public comment? Is there anyone in Carson City? I don't see anyone. AVH, is there anyone on the telephone line who would like to offer public comment at this time?
To provide public comment, please press *9 now to take your place in the queue. Caller, you are unmuted.
Good morning. Okay, hi, good morning, Chair Brown, May, and members of the committee. My name is Marlene Huron, and I am a student at the University of Nevada, Reno School of Public Health, who served as an undercover buyer for Dr. Pearson's study related to implementation of Nevada's tobacco ID scanning law. My comment relates to item 7 on your agenda. Through my experience, I observed that when clerks scan IDs, underage sales are much less likely to occur. However, many clerks do not consistently use electronic verification and often seem unsure how to properly determine a customer's age. For example, during one visit at a gas station, the clerk asked for my ID but did not scan it. Instead, he looked at my birth year, repeated 2005 several times, and then handed it back and approved the sale without properly verifying my age. I was 20 at the time. In another instance at a vape shop, there was a police car outside, and the clerk told me he normally would not check IDs if law enforcement was not present. He appeared unsure on how to determine my age. Asked me multiple times if I was 21. He used a calculator on his phone and even searched online to confirm his calculation. This shows confusion and lack of training in age verification. These experiences highlighted the need for increased education and enforcement of Nevada's ID scanning law to ensure consistent compliance. Additionally, including under 21 until date on Nevada's IDs would help clerks more easily identify whether someone is of legal age, especially in situations where electronic verification is not used properly. Thank you for taking the time to consider this issue and for hearing my testimony.
Chair, we have no additional callers for public comment.
Thank you, AVH. Okay, we'll close public comment at this time and move on to the next agenda item, which is approval of the minutes for the meeting of January 6, 2026. Members, I will entertain a motion to approve the minutes of the committee. Motion by Senator Lang, second by Senator Danyate. Is there any discussion on this motion? Seeing none, all those in favor say aye. Aye. Any opposed? Motion carries. Thank you. Okay, the next item on our agenda is the presentation of policy proposals for consideration by the committee. So moving on to agenda item number 4, we'll hear from 3 different policy proposals for consideration. Before we begin this process, I want to announce that the committee has posted the solicitation of recommendations to the committee webpage. And so anyone who has recommendations they would like for this committee to consider, please complete the form. All stakeholders are encouraged to fill out the public form and send your recommendations as soon as possible to this committee for consideration. So with that said, we will move on to the first item and hear about the Lucas chest compression device. And we will welcome our presenters to the table. If you will please state and spell your name for the record to make sure that our meeting minutes are clear, and then you may begin your presentation when you're ready. Thank you.
Good morning, Chair and members of the committee. Appreciate being here this morning. For the record, my name is Ryan Beeman. I'm representing the professional firefighters of Nevada. Thank you for the opportunity to speak briefly on our EMS training officer, Carmen will walk through the data and operational overview. But I just wanted to frame a couple things before she did. Since 2022, the Clark County Fire Department has deployed the mechanical CPR device. For our department, it's called the Lucas device, across our system, and what we've seen is clear improvement in both patient outcomes and responder safety. The purpose of today's presentation is to share what that looks like in practice and why this technology matters, not just for the urban departments, but especially our rural agencies facing long transport times and limited staffing. Before Rebecca begins, I just want to frame the conversation with a few key points. The statewide need, many rural agencies operate with 2 to 3 crews when they respond, which makes it sustain high quality manual CPR extremely difficult. Transport times can be 30 minutes or longer, and fatigue directly impacts CPR quality. The CPR device removes the variability and ensures every patient receives the same standard of care regardless where they live. Performing CPR in a moving ambulance is one of the high-risk activities for EMS personnel. With the CPR device, responders can remain seated, reducing injuries and workers' compensation claims. Over 1,500 deployments in the past 2 years, ROSC rates have increased from 15 to 18% before deployment, and now we're seeing anywhere between 30 and 35% today. This improvement is directly tied to uninterrupted guidelines of the compressions. This is scalable. This proven technology that supports the committee's work around equitable access to emergency care. I'll now turn it over to Rebecca with the presentation.
Thank you and good morning. My name is Rebecca Carmody, last name spelled C-A-R-M-O-D-Y, and we're here to talk to you today about the potential for purchasing devices that take over the role of manual compressions. Sudden cardiac arrest survival depends on delivering immediate, high-quality CPR, and in those situations, if manual compressions, we are entirely reliant on staffing and how many people are available to provide those high-quality compressions. In the urban areas, those timeframes can last anywhere between 20 to 45 minutes. In the rurals in Nevada, those can last anywhere from 45 to an hour and a half. In order to provide those compressions, we would have to address staffing shortages, training issues, purchasing issues. All of those matter in terms of whether we can deliver quality CPR throughout those time frames to all the people in Nevada who suffer out of hospital cardiac arrest. The need in rural Nevada is great. Most of our units are only staffed with 2 to 3 people. And if you can imagine the tasks that have to happen during a cardiac arrest resuscitation with compressions, ventilations, radio traffic, medications, those are almost impossible for 2 people to do alone and still have that person survive that cardiac event. The rescuer fatigue that happens inside a resuscitation is significant. These manual compression devices take over and allow for mechanics to work and these machines to take over that role, giving us a force multiplier. They can act in as an extra set of hands, allowing providers to do something else that increases survivability. We know there is proven impact when we institute these devices because they can deliver consistent, compliant compressions in a time when a human being simply can't. Imagine rolling a patient down a hallway on a stretcher, coming down a staircase, sitting upright in a chair because we have to move them from their home in that position. A human being cannot provide chest compressions in those areas when a mechanical compression device can. And so that patient receives quality, consistent compressions even in situations where we simply can't. These are widely adopted across EMS systems nationwide, and the fire departments in Southern Nevada are seeing great success with them. We also recognize that you can't use only fiscal issues to determine whether or not you have something that saves a person's life. Those are hard things to calculate. What is the cost in order to promote or save more people's lives? But we can see that with cost force multipliers, where we can reduce staffing and add these compression devices on, there is a return on investment. That agencies who use these see more efficiencies, they reduce workplace injuries and then associated workers' comp claims. Imagine kneeling on a concrete floor for 45 minutes and providing compressions over a long period of time, and what that does to a responder over time, the back injuries, the knee injuries. Compressions manually are so taxing and exhausting that we rotate out people every 2 minutes. We can only allow them to do it for 2 minutes before they become exhausted. Where a mechanical compression device can provide consistent compressions with the same rate, the same depth, and the same quality over much longer periods of time than a human being can. So having these devices improves operational efficiencies, especially for under-resourced departments, and supports standardized care delivery across all the urban and rural systems. We know that we want equitable healthcare access for both our urban and our rural citizens, and these kinds of devices make a level playing field when it comes to out-of-hospital cardiac arrest resuscitation. So we respectfully recommend that if there is targeted state or grant funding to equip rural fire departments with mechanical CPR devices, that this would be a strategic investment in proven technology that will enhance survivability. We would love to see the same survivability rates that we see along the Strip corridor. National averages are about 10% survivability rates. The Clark County Fire Department, in partnership with all of our tourist corridor partners, has increased that survivability rate to 50 to 70%. We would love to see the rural agencies have that same level of success by giving them the technology that can put that into their hands. Investing in mechanical CPR devices is an investment in lives saved, responders protected, and communities strengthened. So we see this technology as ensuring that rural agencies can deliver the same standard care as metropolitan systems do, and we look forward to helping them in training if they were to receive these devices. And thank you for your time.
Madam Chair, Ryan Beeman for the record, representing the professional firefighters. That is kind of our presentation, but we're open for any type of questions.
Thank you for the presentation. Thank you for being here today. Members, do you have any questions?
Madam Chair.
Go ahead. One moment, Senator, Assemblymember Hibbets.
Thank you, Madam Chair, and thank you for being here today. Since you brought it up, what is the cost of one of these devices?
There are multiple manufacturers, and they range anywhere. Oh, I'm sorry, Rebecca Carmody answering your question. They range anywhere from $7,000 to $12,000 per device, depending on the manufacturer.
Senator Titus.
Thank you, Madam Chair. So thank you for that presentation. I personally have done CPR from Smith Valley to Garnerville entirely, maybe a 30-minute drive, and personally have done CPR on patients from Yarrington all the way into Reno, about an hour drive. So I understand the fatigue and I understand what you're asking for, and I appreciate all of that. What I'm questioning is you before us here today with this, and wondering if you've applied under the Rural Healthcare Transformation Act. Have you put in any request for funds through that process?
For the record, Ryan Beeman representing the professional firefighters. To answer your question, Senator, no, a lot of our departments have not. We've been very fortunate with the funding here down in Southern Nevada to be able to purchase those through our departments. We do have some of our rural agencies. Clark County does represent about 12 rural departments, and we've been able to purchase those just through Clark County, but no.
And if I follow up, Madam Chair, if I might, are you representing Clark County, or are you representing all firefighters looking for all agencies for these funds? Because I think there's a need. I mean, the machines are wonderful. When we see them show up in Yarrington and they have those devices, we all take a deep breath, because it relieves that, and they're very efficient. Everything you said is accurate. I'm just wondering about process and who you're representing, what the real ask is, what have you done so far, so that we can help you make this happen.
Yes, for the record, again, Ryan Beeman, represent the professional firefighters. We are representing everybody. We just using our data from Clark County to show the committee, because a lot of individuals have never even heard about mechanical CPR devices prior to the presentation. It's an ask for all our agencies throughout the state. So we're just using Clark County as the example because we had that data to be able to provide to the committee.
One more question, if I might, Madam Chair, real quick. The training for these devices, the amount of hours that are needed, addressing that, yes, I know that the Assembly member asked about the cost, but are you looking at just application for these devices? Or are you looking at also the training? How do you use these devices? Is it something that you ask your members to do annually, like CPR training? So what does that look like?
Thank you, Madam Chair, for the question. This is Rebecca Carmody. The initial training has a little bit more of a investment to it. Many of the manufacturers are willing to come out and train staff on those devices initially. That's part of the purchase price. We require recertification training every year. We want to make sure that anyone who has not used the device within a certain time frame applies it, uses it, and stays proficient in it. So those costs are recurring, but we incorporate them into our CPR training, our advanced cardiac life support training, and our pediatric advanced life support training.
Great, thank you. And thank you, Madam Chair, for the questions.
Thank you, Senator. Members, any other questions? Thank you. I just have one before we wrap. Can you go back over the percentage of survivability that has increased that Clark County saw? I didn't actually catch that through the presentation.
Yes, ma'am. This is Rebecca Carmody. According to the CARES data, which is a national database that we send all of our cardiac arrest resuscitation data to, nationwide, survival rates are about 10% overall, 1 in 10. There's an Utstein survival rate, which is a shockable rhythm on arrival. People with Utstein criteria are at about 30%. The latest data from 2024, if a person suffers cardiac arrest on the Strip corridor in Las Vegas, their survivability rates vary between 50% and 70%. And we attribute that to one, the training of our partners, security, visibility, AED usage, rapid transport, rapid response times with stations strategically placed all along the Strip corridor, and all of our partnerships combined with good resuscitation skills, including mechanical CPR devices that were deployed the year prior.
Thank you. Thanks for the data. Thank you for being here and for the presentation. We appreciate you.
For the record, Ryan Beam, representing professional firefighters. Thank you, Madam Chair, and thank you to the committee for your time this morning. Thank you.
Thanks so much. Okay, we have our first presentation concluded. We will now move on to the second, automated medication administration, and we will welcome our presenter to the table. If you'll please introduce yourself, say and spell your name for the record, and you may begin when you're ready.
Madam Chair. Okay, if I begin?
Please, go right ahead.
For the record, my name is Justin Amoyal. My last name is spelled A-M-O-Y-A-L. Good morning, Madam Chair and committee members. My name is Justin Amoyal. Thank you for the opportunity to speak before you today. I want to begin by grounding our discussion in an ecosystem-wide problem affecting individuals with intellectual and/or developmental disabilities, IDD, their families, their care teams, and the great state of Nevada. I'm sorry about that, everybody. When most think about medication management, we think, how hard can it be to just give somebody a medication? I'd like to point your attention to the screen. Medications have an entire life cycle that must be managed to achieve optimal outcomes. especially for high-risk, high-need populations where medication compliance directly impacts the quality of life. In the interest of time, I'm going to focus on the most complex yet solvable components of the problem: medication administration and documentation. Today in community homes, medication is managed through manual, error-prone processes and environments like the image you see up on the screen. This is the standard for medication access, storage, and prep in our industry. The person in the closet is not a nurse. They're a direct support professional who have only taken a few hours of medication administration training, not someone with years of experience navigating complex clinical situations. They use file cabinets for storage, manual keys for access, binders, and outdated disconnected technologies in an attempt to track everything that matters for these people's lives. DSPs are expected to do more in these settings with these broken tools than most nurses are allowed to do in hospitals. As displayed, a single medication can require nearly 40 disconnected steps manually to compliantly administer and document. Imagine knowing your loved one's medications were being managed this way. Errors are inevitable, even while amazing DSPs and providers who employ them are doing everything they can to stop them. Every professional needs the right tools, and it's time DSPs and providers get theirs. Now I'd like to bring your attention back to the slides. This is what connected, compliant medication management looks like: a secure, user-friendly platform that replaces the manual process entirely. Every step, from pharmacy dispensing to administration to compliant documentation, is reminded, guided, and tracked with software in real time. Data sharing is finally possible across entire states and multiple agencies. Organizations using our platform achieve about a 48% reduction in medication errors, a 39% increase in compliance, and a 69% improvement in audit-ready documentation. Modernizing medication management means safer care for some of the most high-need individuals in Nevada and fewer avoidable costs to the Medicaid system at large. As mentioned, in these environments, these individuals are responsible for administering medications. Those individuals are often DSPs, not nurses. These are the real heroes without capes. They make quality of life possible for individuals with IDD across the country for nearly minimum wage and never get the credit that they deserve. The IDD population is growing and aging. Medication regimens are getting increasingly more complex, and the team members are expected to just continue to figure it out. Without tailored tools, this process can require 40 error-prone steps that are completed manually by a DSP every single shift, every single day for multiple people in a home. To make matters worse, we're not talking about Advil because somebody has a headache. These medications are critical, must be administered on time and as prescribed. Despite the high stakes and complexity of medication management, this is the standard today. These issues lead to avoidable emergency department visits, hospitalizations, serious health complications, and an inability to improve people's lives through data-driven decisions, both for providers and the state. It's hard not to ask, why is this the standard? I believe that there's a lack of awareness to the problem and that there's a lack of awareness to the fact that there are solutions that can solve it. Solving this problem pays for itself more than 10 times over when considering the excessive costs states incur from these hospitalizations and worsening conditions. My hope is to collaborate with great states like Nevada and leaders like those on this committee who are ready to solve it. At this point, you all are probably wondering, who is this guy and why is he talking to us about medication management? Well, I began my career as a research and development engineer working with Lockheed Martin. I then supported the United States Marine Corps, the Navy, and other federal agencies, inventing solutions to stop errors and optimize processes. In 2019, my life changed forever when I lost my brother Ben to an overdose after he spent nearly a year in an excellent residential program. I could not understand how something like this could happen despite so many dedicated people supporting him. That experience led me to study how medications are actually managed in these settings, which led to my company, Interim, being selected by the National Science Foundation to conduct extensive interviews across the country with providers, pharmacists, care teams, and families to learn more. The theme was consistent everywhere. The people delivering care are dedicated, but the systems supporting them are outdated and inadequate. Through that research in the years since, one thing became very clear. Medication administration for people living in residential settings, especially those with IDD, has seen virtually no innovation. While the world celebrates breakthroughs in fintech and AI and all these other industries, technology rarely reaches the care teams on the front lines responsible for medication safety and care in home and community-based settings. That gap is what led us to build Interim. Interim was built with and for the home and community-based ecosystem. We take a person-centered approach to making medication management and regulatory compliance finally possible in these environments. Working with doctorate level researchers specializing in medical economics and epidemiology, we developed an economic model that's grounded in national research claims data and Nevada population data. Our analysis examined approximately 3,200 Nevadans currently receiving services through the IDD waiver and about 874 individuals currently on the wait list. Research consistently shows individuals with IDD experience significantly higher hospitalizations and emergency department utilization than the broader Medicaid population. Medication management and non-adherence are major contributors to those events. Hospital admissions alone conservatively cost between $12 and $20K or more, and frequently lead to repeat emergency visits or rehospitalizations. Based on our conservative assumptions, our model estimates that avoidable medical costs related to medication mismanagement could exceed over $185 million over the next 4 years for this population in Nevada. If Nevada were to deploy modern medication management technology similar to what is currently being implemented in Massachusetts, our analysis projects that more than $60 million in potential savings is possible over that same period. The workforce impact is also significant, and we all know about the national caregiver crisis going on right now. By automating documentation, sequencing, and compliance workflows, our platform can save about 1.2 hours per day for each DSP administering medications or nurses. When considering Nevada staffing ratios ranging from 1 to 2 to 1 to 4 in 24/7 residential settings, this can result in over 23,000 hours. That's 958 days of care time that can be brought back to actually delivering care. Time riddled with medication errors. With this national caregiver workforce crisis, this time needs to be redirected to caregiving. We're already seeing the impact of this approach in other states. The Commonwealth of Massachusetts recently provided this committee with a letter describing its work with Improve as it modernizes medication management across multiple human service systems. These include programs supporting people with IDD, serious mental illness, individuals in state conservatorship, and adults with disabilities. In less than 6 months, 176 organizations have already engaged with our platform, not because they had to. We specifically asked to not mandate our solution. We want providers to move forward because they're excited. These 176 are excited and engaging with our platform because there finally is a solution available to solve their greatest problem. Nationally, we've delivered industry-first provider-level outcomes. One example we shared with this committee is a case study with the Charles Lee Center in South Carolina, where 23,643 medication administrations were completed in December of 2025 across 18 residential settings with 0 medication errors. Outcomes like that should be the standard across the country. Right now, somewhere in Nevada, a DSP is preparing dozens of medications for a parent or an individual who may be self-administering those to themselves. They are trying to determine what medications to give, in what order, and how to document that process, and of course, how to ensure nothing goes wrong. These are the people that inspire us to build Improve. Thank you for your time today and the opportunity to speak with you. Madam Chair, I will now open up for questions.
Thank you. Thank you for the presentation. Members, are there any questions? Assemblymember Nadeem.
Thank you so much, Madam Chair. Thank you for the presentation. So my question is that IDD medication management, is that a device, it's an app, it's a program, what it is actually and how much it costs?
Madam Chair, thanks for welcoming that question. Thank you for asking. It's a combination of software and a device. The device is optional, but basically the way that it works is the software will connect with all the pharmacies in the state. It will then have unique roles for each person in this ecosystem. That includes the direct support professionals, the individual themselves, the parents, the managers, and of course the state who is conducting surveys on this information. The software will then remind, guide, and track all of the medication-specific workflows. The hardware or the device, like you asked, will only provide access to the right medications at the right time for the right people. What's unique about our device is that it works with the pharmacies that support people in this population. It works with single-dose blister cards, multi-dose blister cards, single-dose strip packs, and multi-dose strip packs, as well as the other medication packaging systems. The software and the devices vary in cost based on the number of people we would be supporting. So I would be very excited to have a conversation following this where I can share actual cost data. I would need to know more about the exact need. Also, just to add to that, we don't just hand off the software and the devices to the state. We participate in every single part of the process. We help with outreach to all the providers across the state, training and implementation, and of course, long-term supports for those individuals once the software and devices are implemented. And that's another reason why I need to talk more with you to give you an accurate cost.
Thank you. I want to follow up on Assembly Bill 78, which was passed during the 2023 session that worked with the state division on the deployment of medication administration and training for direct support professionals. Can you just talk a little bit about how did you come to be here today to do this presentation? And is it specific to your company or is it about a solution for direct support professionals?
Thank you, Madam Chair. I really appreciate that question. I'll just start off by saying this is not specific to my company at all. I'm here to educate and bring awareness to this problem. The way that I got here today is I'm just doing everything I can to bring awareness to this problem, educate, and try to advocate for the people that don't have voices like I do that could be sitting here in front of this microphone.
Thank you. Our next question is from Assemblymember Goulding.
Thank you, Chair. Thank you for the presentation. I guess I'm looking for some clarification on what your ask is. Are you recommending that we make a policy change? Are you making a request for funding? Can you clarify what it is that your ask is today?
Thank you, Madam Chair and Assembly Member. My ask today is to take this testimony into consideration as you think about how you deploy funding to people with IDD, the providers throughout the state, as well as the state departments responsible for surveying these workflows within the various home and community-based settings across the country. What I'm asking for today is to take that into consideration and work with experts that can help guide the state to understand how these jobs are actually done on the ground floor, and work with us to help you understand what is truly needed to solve these problems. I'm not here to request funding. I'm not here to have Nevada purchase my solution. I'm here to chart the path across the country to solving this problem so that families don't have to experience what mine went through.
Thank you. Okay, members, any other questions? Okay, thank you so much for being here today. Thank you for the presentation. We will now move on to the third presentation this morning, regulation of medical spas. We will welcome our presenter. Thank you for being here. Please state and spell your name for the record. You may begin when you're ready.
Good morning, Madam Chair. Dave Weiss, Executive Secretary of the Board of Pharmacy. Thank you for the time today. Good morning, all members. I've been asked to bring awareness to an issue related to Medi-Spas. I'm here on behalf of several medical boards, DPBH and the Health Authority, and probably more importantly, the residents of Nevada that send complaints related to the Medi-Spas to us. So what is a Medi-Spa? It's currently undefined in NRS. In practice, it is a catch-all term that includes an individual or business providing the public cosmetic, weight loss, anti-aging modalities. They can be located in established business or they can be in somebody's home. The public wants and should have access to these services provided by Medi-Spas. Over the past several years, the Board of Pharmacy has seen an increase in complaints from the public related to Medi-Spas. These complaints range from financial misconduct to illnesses that have led to hospitalization. The state does not have a tracking or a reporting system to identify issues with Medi-Spas, so it's kind of disjointed at this particular point. Every state is dealing with the issue, In many ways, Nevada is ahead of other states. You have already have rules and the foundation for a path forward. You already have a definition of who can possess drugs, who can administer drugs, where they can be administered. We see very little issues with doctors or APRNs that are in a standard practice that are doing this type of work. The drugs are, good drugs and they're doing good care. I think where we see the issues, sadly, are from businesses and individuals that are unlicensed and run by unstaffed or untrained personnel. The types of things we see are counterfeit medications that have entered the drug stream, bloodborne cross-contaminations related to misuse of how the drugs are administered, improper storage of the medication, untrained staff providing the procedures, and many other dangerous activities. What we would like you to consider is defining in law what a Medi-Spa is with some basic standards. That way the public can go to a Medi-Spa and have trust that the care will be provided in a safe manner. As I said before, the public wants and should have access to these services. They just deserve to have them delivered in a safe manner. I have shortened my presentation for your time, and I can answer any questions.
Thank you for your presentation. Thank you for being here. Members, questions? Senator Lang.
Thank you so much. So a couple sessions ago, I was able to pass legislation for Medi-Spas, and it was through the Department of Cosmetology. And so have you worked with cosmetology? Because we did like what constitutes a Medi-Spa. And so I think that I'm curious if your departments have worked together because one of the problems that we faced is the reason we have these unlicensed people around is we don't have enough auditors to go out and to enforce what is current statute for what constitutes a Medi-Spa. And so in order to do what you ask, I mean, I think it's a double-pronged problem, but I'm just wondering if you have communicated with the Cosmetology Board.
Dave Weiss for the record, absolutely great question. We do a lot of different activities with the Cosmetology Board. I think that what was done years ago, I commend it, and like I said in my presentation, I think the foundation is there. I just think we need to tie it up and try to make it a little bit more universal. Because when you're talking about the Cosmetic Board, they would have jurisdiction over tattoo removals and other things that are related to their practice act, but drugs they don't necessarily do. So we'll see a cosmetician that may be licensed and it has entered into the practice of medicine because they're doing the drug. So I think your point is my same point, which is we've done some things, but I think this is the time for us to attempt to fix it. I do think we can do it in small increments. I don't think, and we don't want to stop it. People want it. So we do a lot with the Cosmetology Board. And I've talked to them about this issue. When I said other medical boards, they would be one of them.
Senator Donyate.
Thank you so much, Madam Chair. I have a question kind of mixed with a commentary. This is interesting. Of course, there's been the proliferation of med spas going across this country and of course in our state. It's my understanding that, so it sounds like the issue that is happening is it's not really the provider that's in primary care providing the ancillary services. It's more so other individuals that are stepping outside of their scope of practice or their ability to do certain procedures. So it's the estheticians and so forth that are causing the issues. I'm just trying to understand who exactly is responsible for more of the complaints that you're receiving, because then I guess the follow-up to that would be, do you not already have the power and statute to go after them? And if not, what would be the appropriate entity to license and oversee them?
Yeah, thank you for the question. I think, again, I have a lot of experience with this. I think that's why they asked me, Dave Weiss, for the record. If you're talking about, a plastic surgeon We don't have issues with them, and they're doing these types of things. We're talking about unlicensed people, or people, they're mostly unlicensed, not even people that are bridging from one license type to another. These are completely unlicensed people that are getting counterfeit drugs and presenting themselves as a safe place to get the medication. So I could speak for an hour. I welcome after this, Senator, to talk to you about it and can fill you in on it. But it's a wide ranging. I don't know. You guys are the policy setters. So we're bringing the issue to you, and how you decide to address it. We want to support that and educate you about that. So that's what I'm here today to do. And it's fascinating. It is unfortunately a whack-a-mole. So we can take an action, we can do unlicensed, we can get a fine for them that goes to the general fund, but they pop back up right after we hit them.
And Madam Chair, just to clarify my question, I guess I'm trying to understand what the appropriate, let's say this has gone out of control. We are seeing tattoo removals in people's homes without the cleanliness standards that other practitioners would provide it if we did this in accurate medical settings. We need to restore that and move that back, right? Let's say we all come to that same conclusion. Then I guess the question that I would have is, who is the appropriate entity that we would do for the licensure of that? Is the decision then to say any of these procedures, whether it's as soon as you're working as an esthetician or et cetera, you have to work under the designation of a physician or APRN or et cetera? Is that the appropriate recommendation to go through the Board of Medical Examiners, or is it that the facilities have to get licensed through HCQ? So I'm just trying to understand what's the recommendation that you all have had as discussions as to who's going to take it on to be the investigatory / the entity that's providing the punitive measures for non-compliance.
It's a good question. Dave Weiss for the record to try to answer it more directly. I think the pharmacy board plays a role because there's drugs, but I don't think the license has to be housed at the pharmacy board. I think maybe the health authority, but they're not here to speak about it today, but we're talking to them. So I think we're at the beginning stages of that and want you to provide direction to what you would think. I think we have ideas. I think we can all work together. I think we're already working together. I just think the problem's bigger than the statutes that we have right now to enforce. And I'm not saying a license needs to happen. That might make sense. I think standards need to happen for sure.
Thank you. Assemblymember Edgeworth.
Thank you, Chair. As a licensed physician, I know that I'm required to report any procedures that I'm doing in my office. So, and I don't think that a lot of the problems are happening from licensed physicians where there's cleanliness standards and storage standards. So my question is, on these medi-spas that aren't run by physicians or APNs, are there periodic inspections? Is it only complaint driven? And then my other little question would be, who would the public literally report this to if they see some sort of a problem with this?
Thank you, Dave Weiss for the record. I think that for the answer for the public, we get a lot of complaints. I can tell you that this is the largest category of complaint that we get, and 4 years ago I got little to no complaints. So I think this is a resource issue for everybody that's providing regulations in the staff, because it's insatiable and there's a lot of problems. Can you repeat your first question for me again?
I'm sorry, that was my fault for doing a combo question. My question is, the question about who we report this to, I don't know that the general public thinks Board of Pharmacy to report a problem with lip injections. I don't know that they would think that, but that's good information to know. My other question is, on these medi-spas, are people being periodically inspected, or is it mostly complaint driven on these inspections?
Thank you, Dave Weiss for the record. Mostly complaint driven, and then it relates to possession, which is in Chapter 454, which you've given the board authority over that. And then we always go out with other boards. This is after the fact. This is not, we're not in a place where we can educate people, and they're, and again, to the doctor's standpoint, unfortunately, I think there are devious people out there that utilize the doctor's license to gain access to the medication, and the doctor doesn't even know what's going on in the place, or thought that it was okay to kind of sell their license to the people, and it is, it's extremely dangerous.
Thank you. Thank you, Chair.
Thank you. Members, any other questions?
Madam Chair.
Senator Titus.
Thank you. I just have to say that nothing makes me crazier than being asked to pass more laws when we're not enforcing the laws that are already on the books. It is already against the law to have these substances and advertise in a way that you're not legitimate to have. So my question is the current enforcement piece. I think Senator Lang mentioned that, you know, she had put through a bill in the past through the cosmetology board. And you mentioned, I believe, that, you know, you don't have enough people to do these inspections, et cetera. So I don't see how passing additional laws is going to actually solve the problem. As you mentioned, it's kind of a whack-a-ball kind of thing where you pass a law, it's illegal, something else will pop up. My concern is it's against the law to do what you're saying. Why don't we focus on where's the problem that you can't enforce what you're doing already? Is it a staffing issue? Do you go, when you get a complaint, actually go with the other boards? Where is the disconnect here that we're asked to pass more laws because we can't enforce the laws we already have?
Mr. Wiest, before you reply, I think I might have a phone a friend for you. I do believe that there is someone from the Nevada Health Authority that is currently up in the audience in Carson City that may be able to offer additional insight to this and to answer the senator's question.
Thank you. That's Allie, Dave, please, for the record.
It is. Yes, it is. Thank you so much.
Thank you, Madam Chair, committee members. Allison Jenko-Herzig, Chief of Staff to the Nevada Health Authority. Currently, healthcare quality and compliance does not have authority to regulate medical spas. We would need legislative authority and staffing to do so. We are more than happy to work with the Board of Pharmacy, Board of Medical Examiners, Division of Public and Behavioral Health, any of the parties that are have current authority to review these medical spas, but at this time we do not have the authority to do so.
So follow up, if I might, Madam Chair. So thank you for being here, number one, to answer that question. So is the medical spa designation then, that's not, you have no regulatory authority over quote unquote a medical spa, if they call them that?
Allison Jenko-Herzig, for the record. Yes, Senator, that's correct.
So it's a subset that you regulatory, like if they are, APRN is in there. I know several that work for medical spas or own their own medical spas. That's where the license comes in by whoever the provider is in those buildings, not the overall designation as a medical spa.
Allison Jenko-Herzig, yes, that's correct.
So currently it sounds like there's multiple things. The pharmacy board is involved because of medication. The cosmetology is involved because of certain actions, eyebrows, eyelashes, etc., lip injections. And then the nursing board or the Board of Medical Examiners. So there's 4 or 5 different boards, and there's no one authority over these, correct?
Allison Jenko-Herzig, yes, that's correct.
All right, great. Thank you. Thank you, Madam Chair, for the questions.
Thank you. Members, any other questions? Okay, Senator.
Thank you, Madam Chair. I just have more of a comment. Just for, I think it would be interesting for you to work with some of the lawmakers on this committee. We can probably try to figure out some level of solution, whether it's through HCQC, et cetera. I think the greater issue I'm trying to, I kind of understand what you're mentioning. It's not just an issue of folks violating the law of prescribing items that they shouldn't be prescribing out of their scope of practice. It's also an issue of salons being set up where 1099 contractors are using the facility. And so it's a greater macroscopic issue that's involving multiple agencies. And so what I'm hearing that you're asking for us to review is to at least designate one entity that's going to be responsible so that we eliminate the issue. And so point being is I think we should have more offline discussions. And I think this is something that we should be addressing, especially from a consumer protection issue.
I appreciate Dave Weeds for the record. I think this is several agencies already working together, coming to you to ask for your assistance in how you want to do a policy.
Thank you, Mr. Wiest, for being here. Thank you for the presentation. I don't see any additional questions, so thank you so much for that part of our presentation. Okay, that members moves us to the next item on the agenda, item 5, update on public health systems and services in Nevada, including the impact of federal policy and organizational changes and the use of state funding. I will welcome our presenters forward from the Department of Public and Behavioral Health. We have Andrea Rivers, Julia Peak, Stacy Montooth, Megan Kamlasi, and various others. And they are starting in Carson City. You may begin when you're ready.
Good morning, Madam Chair, members of the committee. Thank you for allowing us the time to highlight the work of our public health community during the biennium this morning. For the record, my name is Andrea Rivers, R-I-V-E-R-S, and I serve as the administrator of the Division of Public and Behavioral Health within the Department of Human Services. I'm joined today at the table by one of our deputy administrators, Julia Peak, and many of our other colleagues are in the audience in Carson City and Las Vegas. We always like to start our presentations by grounding ourselves and our community on who we are and what we do. Public health can be so broad and ambiguous at times, but at the end of the day, we strive to allow Nevadans and visitors to our state to live a healthier, happier, longer, and safer life. Today for our agenda, next slide. There we go. Today our agenda, we plan to summarize activities in 3 main areas today. The state of our public health system in Nevada, how the changes of our federal government are impacting that system, and details on the state general fund for public health going to our districts and counties. I will now turn the presentation over to Julia Peak to start us off.
Good morning. Thank you. Julia Peak for the record, and I serve as one of the deputy administrators over Community Health Service for the Division of Public and Behavioral Health. I will start off globally and then dive in more locally on what we're doing. I wanted to highlight, though, how Nevada ranks against several other states. A caveat here is that, as you guys know, public health and other data is often delayed at least a year or more. So some of the information that I'm presenting for you today is a little bit delayed. Going on to some public health rankings, I've talked about this report in front of this body in the past. And so there's public health rankings. This one I linked out to. Nevada had several key things noted: an increase in unemployment, an increase in drug use, a decrease in smoking for adults, and a decrease in population. Sorry, I think I sipped aside, sorry. So according to the America Healthcare Rankings, we did rank 42nd overall. Depending on what you're looking at, sometimes we rank better or rank worse, and I'll talk about that in a little bit as well. This report did pull out some of our strengths and weaknesses. I presented the next slide already, so I will skip through that. I did want to never pass on the opportunity to thank you all for your investment now in 2 bienniums, $15 million in 2 bienniums of state general funds. That is a massive increase to our budget. It's not noted here when I talk about public health funding, and so I just want to call that out. We're still noted as 50th nationally. There's just a delay in the data. We've provided the updated data, so as you see that, I don't know that we'll go up much from 50th, but that investment is still incredibly amazing for our state, and we'll talk about that in a little bit. Okay, so this is a new report that I actually like better than the one we've been using for many years that I prior referenced in the last slide. So this one I think really talks more to social determinants of health that is really the bailiwick of public health. And so this one was noted by the American Public Health Association as one that we can look at to actually drive meaningful change in our communities. So we ranked 34th overall, which is better than the last slide. And several of the social determinants of health that were highlighted include education, healthcare. I really liked looking at the fiscal stability one because that looks specifically at how our government programs, which is what we do, support the quality of life for our residents. 38th for opportunity. There's a total of 8 categories. Again, I linked that out. I think it's worth looking at. This one is the first of its kind of this report, and so hopefully annually they'll update it and we will be able to dive in there. Okay, foundational public health services. So what services are provided by us? Very little is noted in statute for Nevada as to what the state and local health departments provide. So much of what we do is looking at national standards. We've talked about this in the past. So the Public Health Accreditation Board is our standard in public health. It outlines foundational public health services and what we should be offering at the local and state levels. So I've listed some here. You've heard some presentations in this committee: maternal and child health, chronic disease and injury prevention you'll hear a little bit about today. A lot of what the public knows is our work in communicable disease control. But there's a variety of foundational public health services and also foundational areas to make sure that when accredited, we're offering that full scope of services. And so Carson City Health and Human Services was actually one of the beta sites who originally tested this accreditation standard for FAB, is what we call it. They continue to be accredited, and that's not easy. The reaccreditation, honestly, is probably harder than the accreditation. Northern Nevada Public Health is also accredited, as is Southern Nevada Health District. We are excited to say that we're just awaiting our site visit now. We've spent the last 3 years knees deep in trying to become an accredited health department at the state. As you know, Central Nevada Health District is our newest health district, and they'll start on this when they're able, but they're still getting their feet under them, and this is no easy task. So we're excited to hopefully say at our next meeting that we have been accredited over the next year. So I thought it important as well to just ground the different levels of public health, because you're hearing a lot about it in the news, and it's really important that every level of public health functions in a healthy way and functions together really well. And so we all offer a variety of services within this structure. A lot of it that is shared is around disease surveillance and prevention. And so you've been hearing a lot at the federal level, at our level, about data modernization. It's just really ensuring that that data is actionable. And that requires all of us, local, state, and federal, to be working together to get that data up and to make it actionable. As we work through the different levels, the state in Nevada is a hybrid. And so DPBH provides services in some of our frontier counties as the local health department. We are their health authority. So we have services out in those communities, like community health nursing is out. We do offer services in the community for prevention, intervention. We work a lot with the coalitions to do that. And then we function at the state level. So we're looking at policy development. We're looking at resource stewardship. So that's both getting funds in from the federal government, getting funds in from the state, and using those in a responsible way to ensure that we can do local public health well. We do have legal authority, so there's a great deal of legal authority under our chief medical officer. Within NRS 439, it articulates some of our responsibility. Again, not a ton of that is put in statute, but it speaks to what we do through our Board of Health, through our chief medical officer, and then at the local level. A lot of our work is partner engagement, though. So at the local level, they really work much more closely with the community. And that said, when things happen within the community, their response can be quite large. And you'll hear about that in a later presentation when we talk about vaccine preventable diseases. And some of these like outbreak investigations that we see can be massive with the staff that's already tapped. And it's felt so much more at the local level. Okay, public health governance, the next slide. As I mentioned earlier, we're largely governed by NRS 439. We are one of only 2 states that's considered largely decentralized, and that just basically means that we're a hybrid at the state. Many states function fully decentralized, so they have a local representative public health agency within each of their counties or regions. We don't have that, so the state offers a variety of services locally in those frontier counties I mentioned. We do have 3 health districts. Already spoke about them a little bit. Our newest is the Central Nevada Health District. And then we have counties within 439, they're allowed to ask for delegation of services. So they, for example, could say, we want to offer nursing services on behalf of our community locally. We don't want the state to do it, so we're going to go ahead and get delegation. There's a process for that. Carson City Health and Human Services, as I mentioned, the longest standing accredited public health agency in the state. They're not a health district, but certainly function as one, and they support some other counties through delegated authority from us. Unfortunately, there's been no further movement on frontier rural counties that want to come together to develop a regional health district. We're hoping that that does move forward, but nothing this interim so far. A great highlight is that the Nevada Department of Native American Affairs, you'll hear about this later, is working on the formation of Nevada's Tribal Health Authority Council, and that was established under SB 312. So departmental and divisional changes, as you guys are well aware, so we had the formation of the Health Authority. For DPBH, that primarily involved having our healthcare quality and compliance unit transitioned over to the Health Authority. In addition, this interim, we're doing a study in partnership with the Health Authority to assess public and behavioral health services and departmental alignment. So right now we've provided an inventory of all our programs to the Health Authority, and then we're going to start working through how each of those is funded, and then eventually that report will be turned over to you all for your consideration. We also, within last session, we had movement of our environmental health programs, and some went to the Department of Ag and some went to the Nevada Health Authority. But for the most part, DPBH has remained consistent in the services we offer outside of those couple things. Huge successes I just want to highlight in our work around academic health departments and workforce. You all have heard about this at IFC as well. Best I've seen it, truly. We have such an opportunity now to go from academic to practice, to make the folks within our practice community upskilled through additional education within our university system. So a huge thank you goes to you all for supporting that. We have 2 incredible schools of public health, and you'll hear about some of that later in a presentation. And you'll also hear from one of my professors, Dr. Clemenceau. I just want to call her out because we don't get to say thank you a lot. She was my undergraduate professor, and she's going to be presenting as well on the YRBS. So huge asset that we have in our faculty and our research community and universities. So again, thank you to them. Okay, funding changes. So we were well aware, as are you, that the ARPA and COVID-related funds are ending. We did such phenomenal work over the years with that infusion of funds. Public health has been underfunded for such a long period of time that really helped us get to where we need in a number of areas: data modernization, staff upskilling, recruitment, all of those things. But we knew it was ending, so that's nothing that we thought would continue in perpetuity. The hardest thing for us, I think, right now as we look at being a fiduciary agent to funds is the unanticipated changes in federal grants. And one of the challenges with that is that, like the COVID funds, we don't have the ability to have an off-ramp. We don't know that it's coming. We've had a few examples recently. For example, we get notification, typically we hear it in the news first, unfortunately, that the federal government has chose to eliminate some grants, and often eliminated as of yesterday. And so we have to scramble so incredibly much to figure out how that looks. And then often there's reinstatement of that funding almost immediately. I'll give you an example of how this looks because I think it's helpful to understand how we're living in public health. Saturday morning, making pancakes for my kids and my phone starts going off. They eliminated one of our really large grants yesterday. And so Saturday morning, trying to figure out what staff need to be laid off, what contractors aren't coming in on Monday. And with us, we're a classified system, and so folks have bumping rights. And this is not an easy task to eliminate a grant yesterday. And so our local partners calling them, hey, we're not going to pay you come Monday, and just that ripple effect. And so all day Saturday, we're scrambling to try to implement the direction that we've gotten from the CDC, only the next morning to have it, thankfully, pulled back and given back to us. They decided that wasn't a good move and that they'll give us the grant back. So at the end of the day, great outcome. We were able to keep those funds, but that's really, really challenging to run a government agency. So just having that within our lives right now in public health has been really challenging. Also, the litigation. So we have the COVID funding was eliminated yesterday. And so then there's the litigation where you potentially can spend, but the funds are in litigation. That's a really sticky situation for the state to be in. And that's been happening a lot. I'll talk about that in a little bit as well. Highlight the new Rural Health Transformation Grant that Medicaid is overseeing, I think is massive opportunity to improve public health in our rural communities. So I just want to call that out as a huge win from CMS, and Medicaid is doing an excellent job working with our partners to figure out what that looks like. As the health authority in many of those frontier counties, tons of opportunity to do really amazing things across the board, from healthcare to public health to prevention to health outcomes. So thank you to our federal partners for that opportunity. So my last slide is just to cover a few more changes that we're trying to implement effectively with direction from our federal government. So there's been a lot of changes in policy and executive orders. We often get those and need to implement immediately. And like any document like this, sometimes it's really hard to understand how it was intended. And so we're trying to interpret it in real time and execute it in our programs. For example, none of your grants can be used for X. And so we'll have to go through all our grants to make sure we don't have a deliverable with that noted, or it could potentially not be reimbursed. So huge challenges in just the execution of that, because we want to make sure that we don't put any of our federal funds at risk. So do we understand this accurately? A change there that's really hard as well is as they make changes at the federal level, those were our go-tos, our subject matter experts on the funding. So when we say, are we interpreting this correctly, that person might not be able to answer or simply might not be there. There's programs closed now, so we don't actually know who to talk to about implementing effectively. We lost our regional offices. We had a longstanding relationship with our regional office in San Francisco, so we were able to call them and they would troubleshoot with our federal partners to get us answers. That's not there anymore. So we do feel like we're sometimes just out on a limb trying to do the best we can to ensure that we're overseeing those federal funds and programs appropriately. Also, the Department of Government Efficiency, DOGE, that created challenges and delays. We're already understaffed and totally understand the transparency and intent of that, but the back and forth with DOGE to ensure that we're articulating the scope of the reimbursement correctly in alignment with the executive order, that's just a lot of work for us to do in order to get reimbursed for the awards. Not as bad now, but that was very painful for a period of time. Again, structural changes at the federal government has been difficult. CDC had a lot of restructuring, and that directly impacted our programs. Funding volatility, as I mentioned, is probably the most painful part of our jobs right now. Hard to recruit staff in federally funded programs when we don't entirely know that that will continue. One example, so we've had Title X for years, that's our family planning grant. Nothing from our federal partners on whether we were getting at that or not, and it would have ended today. And so they gave us a couple days notice. We'll fund you again. You have a couple days to do your application. That was every state and our local partners as well. It's really hard to run a program if we don't know the funding's going to be there, and that does provide direct support to our community. Litigation, policy, and funding has been really tough to navigate how the judicial branch is helping us or not helping us or delaying the process. That's been really difficult to watch. And then the priority has been direct services to our community. We don't want to start a program that we'll have to stop later, and if we don't have an understanding of those federal funds and the delivery to Nevadans, we can't communicate that. And if we don't have an off-ramp, again, with the COVID funds, we knew things would be ending. If it ended yesterday and people had an appointment Monday, that's really, really difficult for our community partners. So we're just trying to navigate this. Again, we have to have federal, state, and local working really effectively, or the system does not function well. To that, though, you have made major investments, and I'll turn it over to Andrea. Without what you guys have done in the state general fund investments, we'd be in a much worse place.
Thank you, Julia. For the record, Andrea Rivers. The public health community is so thankful for the investments, as noted throughout this presentation and by Ms. Peak, that have been made to our system over the last several years. The chronic underfunding of the public health system nationwide was highlighted during the COVID-19 response, and in Nevada. Both the governor's office and the legislature has responded with substantial investments, and to that we're grateful. These investments include ARPA funds to build physical infrastructure throughout the state. There was a new tuberculosis clinic opened for Northern Nevada Public Health, the new state public health laboratory at the University of Nevada, Reno, the remodel of a building at the University of Nevada, Las Vegas to house the Nevada Office of Minority Health and Equity. The coalition, the faculty who work in this area, everyone is grateful for the great investment in public health and allied workforce. We've provided reports that highlight the great successes of these ARPA workforce investments. Though these projects are time ending, the public health landscape in Nevada will forever be changed for the better. This body also provided $15 million in general fund through SB 118 2 sessions ago in 2023 and approved another $15 million requested within the governor's budget to allow this investment to continue as base funds last session in 2025. This funding is passed through on a per capita investment to each county and district to meet the most critical public health priorities locally. Within Senate Bill 118, the funds were distributed on a per capita basis to the districts and counties. This bill appropriated the funding to address public health needs within the jurisdiction and allowed a planning year. Of the public health needs and priorities for investment with the 13 subawardees, there were 33 distinct priorities noted. Of those, the most common priorities across the state were substance use prevention and treatment and access to health care for special populations. It's of note there were no funding through SB 118 for tribes, and there was one award issued to Nye and Esmeralda. Again, thank you both to the governor and to the legislature for allowing the $15 million biennial investment in public health to continue in 2025. Though the dollar amount remains the same, as a public health community, we decided to align these funds with our FAB foundational public health services. As Julia noted earlier, FAB is where we're headed with accreditation, as well as the accreditation held by many of our county and local health authority partners. Therefore, the topic area in this slide does not exactly align with those of SB 118. With this funding, there were 25 priorities chosen between the partners, with most common topics being assessment and surveillance and access and linkage to healthcare. Please note that these funds also supported the development of the Nevada's Tribal Health Authority Council as established in Senate Bill 312 last session. As noted, SB 118 allowed a planning year. So the funds were officially available to spend starting July 1st, 2024 and conclude on June 30th, 2026. There are various levels of spend noted for the SB 118 funds, as you will see here in this slide. There are a variety of reasons for this, but one is that the funds are being used for capital investment and improvement. So there will be large expenses towards the end of the project period. This is similar to what we have seen with capital investments for ARPA money. To highlight this, Southern Nevada Health District, while demonstrating 32% has been expended to date, the majority of the remainder of Southern Nevada Health District's SB 118 allocation supports the Southern Nevada Public Health Laboratory expansion. These funds are already allocated and will be fully expended as the project progresses ahead of the June 30th deadline. At this time, all counties are anticipating to fully expend their awards. Any unspent funds will be returned to the general funds. Moving over to the state public health fund distribution. This slide shows the investment and the spend for state public health funding. There are various levels of spend here, but again, no county at this time believes they will need to return funds at the end of the biennium. Just to highlight a couple of projects being done, Esmeralda, for example, is using this money to recruit and hire for a county health officer. Nye County is using funds to improve access and linkage with clinical care. As you can see between the two slides, we are currently in a year where the funds for SB 118 and these funds overlap. So there is $15 million in a single fiscal year. However, after this, only $7.5 million will be distributed to counties for the project. Other delays have been caused by the contracting process to our partners. Many of these require approval by local or district boards of health and the State Board of Examiners. Though this is important for transparency, as we've noted throughout our presentation today, it can cause a delay. Also, if these projects in the counties require hiring of staff, that can add further delay. A couple of challenges we see in the future with these funds, if they stay level, like many of our other federal awards, over time, this will result in a potential cut to services as staff salaries, contracts, and other program costs increase each year. Also, to date, these funds cannot be carried over between fiscal years. This creates a challenge. If the funds could be rolled over throughout the biennium, this would allow for delays not to be so problematic and offer greater flexibility and programming for the local authorities. Okay, we're now going to turn over. We do have representation from each of our local health authorities to answer questions and share in more detail the great work they are doing, but wanted to offer some highlights and priorities for each of our county partners. Carson City Health and Human Services. As Julia noted, they're longstanding public health accredited. And as you can see, through the funding through SB 118, as well as the state public health funds, they have a large focus on seniors and youth access to services, which is a big priority for their community. Moving on to Central Nevada Health District. As noted, this is our newest health district, and they've done an amazing job to increase capacity and serve the counties that they represent. With these funds through SB 118 and through the state public health funds, they've completed a community health needs assessment for all jurisdictions in the Central Nevada Health District. They've developed strategies to reduce barriers to service, increase access to core public health support, and they look to continue into the future to build infrastructure to support the new health district, as well as increase communication across multi-jurisdictional offices to allow for consumer access. They've worked to develop a communication system to support 4 offices in 4 separate jurisdictions to increase this access, as well as a web platform to increase communication and public service access to services. Moving over to our partners with Northern Nevada Public Health. As you can see, and I don't want to go over the entire slide, they're doing a magnitude of things to make a huge impact in their community through SB 118, as well as the state public health funding. One thing to highlight, though, is ensuring immunizations, the ability to purchase immunizations for the county, equaling protection for our second largest area in the state. And our partners at Southern Nevada Health Districts. Also doing a lot, as you can see on this slide, through funding offered through SB 118 as well as the state public health funds. One thing to highlight, along with their expansion and capital improvements, is what they're doing for healthcare-associated infection prevention and response to strengthen these efforts and add protection in the community. In summary of our presentation today, as noted, we have a volatility and changes with the federal government. We expect this to continue and will impact policy, programming, and funding in Nevada. As noted, we do work closely with our partners at all levels to mitigate efforts where we can and keep things running as smoothly as we can with these changes in volatility. We again thank you for all the support and stability we're getting from Nevada, both with this body as well as our governor's office and attorney general's office. And then one area of a challenge is the general fund investment having an inability to spend the funds between years in the biennium. This concludes our formal comments for today. We have a couple co-presenters on this item as well. Stacy Montooth, Executive Director, Nevada Department of Native American Affairs, who will be talking about formation of the Nevada Tribal Health Authority Council as established in Senate Bill 312 last session. And we're also joined today by Megan Kumlasi, Director of Public Affairs and Policy with the School of Public Health at the University of Nevada, Reno. She will be highlighting the work done by schools of public health at both the University of Nevada, Reno, as well as the University of Nevada, Las Vegas. We're happy at this time to cover any questions you may have, or we are happy to pass it on to our co-presenters and be available for questions after at the direction of the chair. Thank you.
Thank you. Thank you, Administrator, for the presentation. We appreciate you. If you don't mind, we're going to break here and see if there are questions relative to your presentation, and then we'll move on to the next two as they also have slides. Members, do you have any questions relative to this presentation that we've just received? Assemblymember Nadeem.
Thank you so much, Madam Chair, and thank you so much for the presentation. And I would like to know that how a regular Nevadan can approach the Department of Public Health Service and the services they provide through, are they free of cost, or is it there some cost, and how they can approach the department?
Julia Peak for the record. I can start, and we also have our health authorities here as well. I don't know if you'd like to call them to the table. So thank you for that question. So how would an individual know if there's a service that they would like to access? One of the best things is finding out who your public health authority is and what services you're looking to get. So one of the foundational public health services is helping folks access care. So if we don't offer the service, hopefully we can help navigate to the appropriate service available. But we do offer many services. So within our frontier counties, for example, we oversee the provision of WIC, the Women, Infant, and Children's Program. So we ensure that services are provided statewide. Obviously, within our frontier counties is where the health authority. We also provide community health nursing services. And so those are required to be on a sliding fee scale. That said, if you're not able to pay, then the service would be delivered for free. Vaccinations, all of us at the local and state, we bill for certain services if the insurance provides it. And in some cases, if we're doing a point of dispensing event, which we do to exercise our ability to give mass vaccinations, flu vaccines, for example, would be offered for free potentially at one of those pod events. So there's a variety of ways to access services. I would also like to highlight here, any Nevadan who needs a service, please call 211, access the website, because we provide the information that our supports have, our sister agencies have, what we fund. Much of our work at the state is done as a fiduciary agent. So we fund community partners to provide the services on our behalf. That information should be in 211. So for example, I need support because I need access to food. You could call 211. They also have on their website information on that. I need access to rental support. I need access to HIV services. 211 is really a central point for that service. And then if there is inability to pay, there's options to talk through that. We also have within our ADSD agency, the Office of Government Assistance, I think it's GovChod now. So within ADSD, we can have an ombudsman help somebody if they need to navigate services or payment for services. So a variety of options. 211 should be the take-home point to provide to a resident so they can help navigate that.
Thank you so much. That is very, very helpful. Thank you.
Senator Donyate.
Thank you so much, Madam Chair. I have a quick question first on slide 11. In talking about the unanticipated changes in federal grants, does DPBH by any chance have a master list of the displaced workforce or any of the grants that have been cut within the last 2 years? Just as a master list so that I can understand what the changes have been.
Julia Peak for the record, thank you for that question. We have, yes, we've tracked a lot of that. I think one of the biggest challenges to get you that answer is the complications with each of those funding streams. So in some cases, we're still waiting to see if we've lost it or not. In some cases, there was a delay in getting that. In some cases, the funds are within litigation. So we can provide you a list of what's been touched or commented to be touched by the federal government and action taken from there. I don't think at our level we've had to lay off any staff. I think at the local level they have, but they've also had the opportunity to use your general fund investments to retain some of those programs even after the federal grant has been cut. So complicated answer, and we will try to provide the committee with the world as we understand it on those federal awards and impacts.
Madam Chair, if I could follow up. So this is specifically why I wanted to ask that question. It sounds like, so I don't know if, obviously there's a lot of complicated matters going back and forth because as you mentioned, one day the HHS will cancel a grant, everyone freaks out, you lay your staff off, or you notify them that they're getting laid off. The next day you say, just kidding. And that's just the craziness of the Trump administration. But I think the thing that I'm most interested in is that as you're all navigating this, I want to know how many of the workers have been brought back because of SB 118. And so perhaps maybe if each of the jurisdictions, if they know from the top of their heads of what programs they were able to salvage or how many staff they were able to keep because of SB 118, I think that would be helpful for us.
Julia Peak, for the record, they can give some highlights now, or if you want specific detail, they can. I think Emma might be standing up in Las Vegas too. I couldn't tell if she wants to provide some information. I could tell you though, as she's walking to the table, and Ms. Dixon here as well from Northern Nevada Public Health will offer some comments. Some of the priority differences that you see between SB 118 and the ongoing state public health funds, their priorities changed as a result of federal funding cuts. One specifically being within the area of disease surveillance, often supported by our epi and lab capacity grant, that has had cuts, and they've had to change the vision for that funding based on those cuts. So I will turn it over to them for examples.
Thank you. Emma Rodriguez, for the record, with Southern Nevada Health District. So as Ms. Peak mentioned, one of our key priorities for the state public health funds was for the epidemiology and laboratory capacity that had been previously supported by CDC ELC funding, which was reduced at the federal level. Thanks to these state funds, we were able to continue that work. So most of these costs are personnel driven. I don't have the exact number off the top of my head. I know we do have our laboratory manager on the line. I'm not sure, Will, if you happen to have the number of staff. If not, we can follow up with you certainly and get you a more direct number, but it was really critical to make sure that we could keep going forward with these critical services. Will, are you able to answer that question?
Hi, yes. My name is William Bendick, for the record. I'm the Southern Nevada Public Health Laboratory Manager. And I can say that the staffing level for our lab sits at around 40, and without that state public health funding, we would more than likely have to cut 25% of our staffing who are directly responsible for performing surveillance testing for our local jurisdiction. At least that. And that's off the top of my head, but of course we could come up with a better answer, time permitting.
Good morning. For the record, Erin Dixon with Northern Nevada Public Health. I'm going to echo many of the comments that have already been made, and I will get you a list of all the titles of the positions that we've been able to save on the public health funds in SB 118. It's very similar to Southern Nevada Health District. A number of our positions have been in our epidemiology and disease investigation component. We have also had to use the funds to address shortage in staffing for our TB nursing, in addition to our chronic disease prevention program, and I believe some of our sexual health program as well. So that is primarily where the funding will be going in FY27 as well. Happy to provide that list for you though.
Jeannie Freeman, for the record, Carson City Health and Human Services. One of the biggest challenges that we've had related to the federal funding is that because of the insecurity associated with federal funding, we've had a lot of staff that have chosen to leave for other positions where they might have more stability when it comes to their salaries and so forth. I've currently had 5 staff that have left to go to other positions, and I do not have the ability to fill those positions due to that lack of funding. The SB 118 and the public health funding are allowing me to keep 0.75 FTE out of those 5 that I have lost so far.
Thank you. Thank you for providing that detail. We'll go now to Senator Titus.
Thank you, Madam Chair. Although I disagree with my colleague's comment regarding the administration, and I felt that it was inappropriate, I do agree with the request to have a list of what services have been, what grants have been denied, what potential grants you see. So I absolutely think that's really critical to know what we may need to do within the state. Having said that, I have huge concerns about Ms. Peaks, your comment regarding you don't have a contact in the federal government that you can speed dial when you have a question. What office was closed in San Francisco that you no longer can reach?
Julia Peak, for the record, our HRSA office, but they, even though it was HRSA, they really functioned as our SSH, Health and Human Services federal government lead. So we would have a question about, hey, I haven't heard anything on this grant, can you follow up? And they would bird dog that for us and get back to us. Huge during COVID, and that office was closed.
So what do other states do? Do you have colleagues in other states? Because I have a real concern about that. You should be able to reach out. You shouldn't get a notice on Saturday that we have a cancellation, and then Monday, oh, just kidding. That is not okay. And we need to be able to reach out to our federal partners, and you should have them on speed dial. And if you don't, there's something wrong there. So believe me, I'm going to dog that one, and it's a real concern of mine. I've already sent an email to Director Seaman, who has been appointed and has an interest in Nevada, but if we don't have a direct dial to somebody, we need somebody. And I don't know what your other state partners are doing. Do you have any insight from them?
Julia Peak, for the record, so many of the regional offices weren't closed. Ours was one of them because the San Francisco office was so expensive. That's how it's been communicated to us. Two issues of that there. The speed dial component was huge. I could text this person during COVID and they would get me an answer almost immediately, and that office again is closed. So we just need to work through that. The other issue with termination of a grant and hearing about it a day later, often our CDC colleagues are hearing the same. So we call them and said, did you hear this? They said we didn't, we're looking into it. So there's a disconnect there. Again, I don't know that the regional office would have known more than the CDC staff working on that grant, but having somebody to call that says, I just need help navigating at HHS has been really challenging. And then again, at the CDC or HRSA or SAMHSA level, not having our project officers have insight on when or what would be cut and the impact, that's been really tough.
So did they, for clarifying, thank you, Madam Chair, for a follow-up with this. Did they not have a HRSA office contact at all now, or did they move them to some other region?
Julia Peak, for the record, at one time we were told we'd be absorbed by another regional office, and they're still navigating how that looks. It's just been a period of disconnect as they figure out what that new structure looks like. And in the meantime, we've just struggled to have that one go-to for HHS that can really help us bird dog issues.
Thank you for that. It's really a problem and an issue, and I think we need to fix that. So we'll work on that. Thank you. Thank you, Madam Chair.
Thank you, Senator. We have one additional follow-up from Senator Danyate.
Thank you, Madam Chair. I wanted to go more into deep, specifically on the SB 118 funding distribution. I think I've obviously have had consternation with the health districts, more so dating back to the implementation of this in 2023. I know that there were some reforms that we were looking at during the 2025 legislative session, but given, of course, the rapid changes that we were seeing with federal cuts being made, the uncertainty that came with them, whether they were there or not, I thought it was important to at least keep everything in place for now. And I know that we were looking at a different type of distribution model that ultimately fell short. I think the hardest part that I'm trying to understand is there's obviously more that we can do to protect the workforce that has been displaced. There's more that we can do to provide more public health support on the ground. And I'm seeing the percent of spent still accumulating before June 30th. And so I think I'm just trying to make sure that I understand what DPBH's plan is to hold these counties accountable, or counties and health districts accountable for making sure that they're expending their funds, and what the plan is if they don't.
Julia Peak, for the record, I'll start and then I'm going to hand it over to my colleague who works more directly. A couple things that I just want to highlight with the implementation of this. So when we got SB 118, we did not know if that was going to be sustainable or one time. And so that really impacted how counties were planning to use their funds. Now that we're hopeful it's ongoing, and that was proven by the fact that the legislature approved that within our base budget in general fund, I think the way in which we're looking at how this should fund public health is slightly different. As you mentioned, it is per capita to the counties. DPBH does not take any funds off the top of this. We're excited to have the Tribal Health Authority now. They will get a dollar amount investment, not a per capita, but it is directed at local public health efforts. When we presented on SB 118 and then again with the general fund, we had talked about that this ideally would fill gaps in public health services statewide, and it needed to be based on a county's needs at that time. Since you gave us SB 118, there has been more volatility than expected with our federal funds. So we're having to revisit how that looks. It'd be unfortunate if it just sustains funds that where we had federal cuts. We really hope that this funding would help us build out more foundational public health services statewide, and we just have to see how that looks as we do have some funding volatility. But hopefully it will sustain programs and then fill gaps. That's the intention of the funds. And then if we do have another public health event or emergency, that we could direct funds accordingly to address that with those general funds. And then how we're holding folks accountable, similar with ARPA, those of you that have heard presentations from us and others at the Interim Finance Committee have heard what we do with monthly spend plans. If you expected to spend a certain amount in March and you're not spending that, are you going to recover that in April? If not, what should we do? So that's being done monthly, if not more often, and there's technical assistance calls that we have with each of those funded partners as well. Mitch, would you want to add?
Hi, my name is Mitch DeValier. I'm the agency manager for DPBH. Last name is spelled DEValiere. My program helps to oversee the ARPA funding as well as the SB 118 and the state public health funds. In the interlocal, we have a comment in there about reaching out to all of the health districts to get their projections from March until the end of June. And so we were able to do that. Even though the current distribution or the spend down seems to be a little bit low for some agencies, every one of them anticipates a full spend down by June 30th of 2026 for both state public health funds and the SB 118 funding. There's one county, Elko County, they anticipate that they'll leave $8,800 for SB 118, and so they will send that back to the state general fund by June 30th.
Thank you. Thank you all for the presentation and the clarity. We appreciate that. We do not have additional questions on this segment at this time, so we'll go ahead and move on to your next segment, which I believe is the Executive Director Montooth.
Good morning, everyone. My name is Stacy Montooth. I'm the Executive Director of the Nevada Department of Native American Affairs. I have just a few slides here to share with you about the impact of your work on my agency. So, as someone spoke earlier, it's always good to start with just a brief review. I want to remind you all that the Department of Native American Affairs was created to improve the quality of life for the first people of this land. Since 1965, our agency has been the conduit between the governor's office and our tribal governments. Often in Indian country, whenever we have a government meeting, we always start things off with a land acknowledgement. And for your convenience, if you will, I have included the department's official land acknowledgement that we use at all of our meetings. It's here on this slide, but I'd like to just personally say that I am grateful. This Northern Paiute is grateful to be on the Washishi lands today. I have the privilege of working and playing and living in Washoe territory. So I'm here today to talk about the Tribal Health Authority. So one of the most specific developments thanks to your work, is going to benefit our tribal governments. It's the creation of this Tribal Health Authority Council. So what has happened is you've empowered this unique council to focus on tribal healthcare priorities, our shortfalls, solutions, how we can duplicate successes. This body is even going to have the power to work with BDRs during the legislative session, which will specifically help our tribal citizens, again, the original stewards of this land. So let me remind you, if I may, the restructuring per SB 494, it explicitly lists our tribal governments as critical partners in the state's application for their strategy for federal initiatives. Having that in writing is a huge coup for our tribal governments. Also, this ensures that our health centers that always serve our tribal citizens, we're always going to be considered at the state level when policies are developed and implemented. This includes some vital areas: Medicaid reimbursement, workforce programs, which was mentioned earlier, and then data sharing and emergency care coordinations. Critical. We cannot do this on our own in Indian country, and are so great to have this state as a partner in this. In addition, the Tribal Health Authority Council will ensure that our people's priorities are included in the Rural Health Transformation Program, which was also mentioned and is why I'm here today. Our tribal representatives, we actually have someone who's on the current steering committee for the state's Rural Health Transformation program. And that's, again, to oversee the state and the federal investments, the flex funding, which is huge, helping us to modernizing our medical equipment, technology, and infrastructure. And I guess the bottom line for my agency is, because of your work, because of these changes and addendums to the NRS, my agency will have a full-time position, and this person will oversee the actions of this Tribal Health Authority Council. So to bottom line it, and I know some of our legislators like that, $112,000 will come my agency's way on an annual basis, and this again will pay for a full-time employee and related activities to get these voices together from all of our tribal governments that have tribal health centers, so that we can again strategize, look for commonalities, find gaps, and make meaningful recommendations as well as solutions. Specifically, I think this is the $100,000 slide. This is what has happened with the Department of Native American Affairs. Again, you all know SB 312 was passed. Governor Lombardo establishes the Nevada Tribal Health Authority. That happened on June 16th. I was contacted the very next day. Mitch is in the room, our tribal liaison. They were fired up to help our agency get the funding that we needed to get this Tribal Health Authority established. On our own, our department used an unorthodox way to get the word out that the Department of Native American Affairs is going to be hiring, and we have this amazing opportunity. So you could say we did a little promotion unofficially starting in September. We applied for the grant that it was provided to us from the Nevada Health Authority. We actually started that November 22nd. A lot of changes, a lot of things happened, everything from leadership changes to staffing changes. We had some setbacks, but we were able to perfect our grant application. We submitted it December 23rd. You all know what time of year that was, so we actually were able to sign our grant application on March 13. We've had, on February 11th, we've had training with DHRM, which I think is really important for you all to know. we're depending on another agency to help us to ensure that we go through the proper channels to hire this person who's going to oversee this authority, right? We have to get a Nevada employee, and our next milestone will be April 7th. It was also mentioned earlier, in some of these instances, you have to go to the Board of Examiners to okay some of our paperwork, and so that's exactly what we're going to do on April 7th. And I'm happy to answer any questions you all might have. I want to take the opportunity to thank you for always thinking about the Department of Native American Affairs and our tribal governments, our urban Indians, and I look forward to our continued partnership with not just the Department of Human Services, but now the Nevada Health Authority, and look forward to answering any of your questions.
Thank you for the presentation. It's always great to see you. Thank you for joining us today. Members, any questions?
Madam Chair?
Senator Titus.
Actually, this isn't a question. This is just a thank you. It's encouraging, and hopefully we can actually try to narrow the gap of disparity between Indian health and everybody else in this nation. And so thank you for your enthusiasm. I'm glad to see people on board. And boy, if you hit any obstacles, I want to hear about it. So thank you very much. Thank you, Madam Chair.
Pisha.
Thank you, Senator. Thank you. Okay, seeing no additional questions. Executive Director Montu, thank you so much for being with us today. We sincerely appreciate that, and we also appreciate being on our native lands.
Thank you. Thank you, Chair.
Next presentation we have, I believe, is from Ms. Megan Komlasi with the School of Public Health, the UNR. Thank you. It's great to see you.
Thank you, Madam Chair, members of the committee. My name is Megan Komlasi. I am the Director of Public Affairs and Policy for the UNR School of Public Health. And I'm so pleased to join you and grateful for the invitation to be here to talk a little bit about how the UNR and UNLV schools of public health fit into the public health system in Nevada. Julia Peak talked about how to have an effective and efficient and functioning system, we need public health to work at the federal, state, and local level. And to create an effective system in the state, we also need public health workforce and public health professionals, and that's where the universities come in. So we're a critical pipeline of public health workforce in Nevada. The UNR School of Public Health has nearly 2,300 undergraduate students and a couple hundred graduate students. We're proud that 80% of our students stay to work and live in Nevada, and a significant portion of our students are pre-nursing. So not only are we educating the public health workforce, but we're also helping educate the future workforce. The School of Public Health at UNR works closely with our state and local public health agency partners and supports the health of communities beyond just workforce development and training the next generation of public health professionals. We were an integral component to establishing an academic health department between the entire University of Nevada, Reno, and what was then the Department of Health and Human Services, now the Department of Human Services and Medicaid. And so this academic health department is a formal affiliation between the institutions that provides mutual benefits around research, education, service, and practice. And the idea is that academia informs practice and practitioners inform the academic program, so that we're constantly communicating and improving and making sure our state agencies have the workforce they need. In addition, we know that resources are limited in the state, and so we're all governmental agencies, and when we work together, we can accomplish more. The UNR School of Public Health also has an academic health department agreement, a strong one, with Northern Nevada Public Health. And we've done some really great things for public health workforce, and kind of that's just mutually beneficial. We have a mandatory undergraduate course at the School of Public Health now that educates students on public health careers, because there are so many, and it's a very they're a field with lots of different opportunities. We've also established a shadowing program in which students are exposed to different job opportunities at the local health authority. And we've placed graduate students at Northern Nevada Public Health and Carson City Health and Human Services, actually. So our students get workplace experience, and our local health agencies get expanded capacity. We're excited that we are close to finalizing an academic health department agreement with Carson City Health and Human Services as well. Through the ARPA Nevada Health Workforce Pipeline grant, which Julia mentioned as well, the School of Public Health has been able to increase the number of qualified healthcare and public health professionals by providing scholarships and training for everything from community health workers and doulas to supporting alcohol and drug counselor interns and peer recovery support specialist interns, as well as funding clinical supervisors for behavioral health professionals, as well as epidemiologists and biostatisticians and everything in between. A focus of our ARPA scholarships is upskilling staff at state and local public health agencies, whether through individual courses, certificates, degrees, and research shows that this type of training helps improve retention and career advancement. So if we can provide the skills and training to our existing public health workforce, we can entice them to stay and move up within their agencies. So we've done that through the Basics of Public Health course, which is an online course that helps those without formal training in public health to understand the field they're working in, from everything up to programming courses in R and Python, Power BI, and we're upskilling those with associate's degrees to bachelor's, bachelor's to master's, and master's to PhDs. We're also really excited about a new project with Nevada Health Authority and Medicaid, and so we're working together to better understand the health needs of populations throughout the state. We're looking to identify opportunities for earlier intervention to keep Nevadans healthier, to improve quality of care, and to reduce costs for Medicaid. And then finally, you'll notice the slides on the screen are a little different than those we submitted a week ago, because Dr. Kristen Clements-Knoll, who you'll hear from in a little bit, just published reports from the Youth Risk Behavior Survey, which we need to thank you all for. And Chair Brown, may thank you for your sponsorship of AB 331, which provided funding to the YRBS. And to everyone else for supporting that funding asked last session. The funding is critical to expanding the Youth Risk Behavior Survey to make it a comprehensive survey. We get some funding from the federal government for a handful of schools, mostly in urban areas, but through the state funding, Dr. Clements-Knoll is able to expand the survey to include middle schools and high schools, as well as rural, frontier, and tribal communities. So without this data, we wouldn't have as good of an understanding of the risky behaviors that youth are involved in. We also wouldn't know what they're doing in middle schools, and it's really important to understand at a younger age what young people are doing and what risky behaviors they're engaging in, so that we can intervene earlier and stop behaviors before they become habitual. So thank you all for supporting that. So these are some of the ways we support public health statewide. We're also looking to the future and working to identify needs in the state that we can help meet. So on this slide are 3 examples of that. We're very excited that the UNR School of Public Health will be opening a Doctor of Physical Therapy program in 2027. We plan to accept 35 to 45 PT students each year. And this is in an effort to address the statewide shortage of physical therapists, which is bad across the state, but really bad in rural and frontier communities. And another one of those statistics where we rank 47th for the number of PTs in Nevada. So very excited that we'll begin accepting students in just over a year. In addition, we're working with ARPA dollars. We are remodeling the old State Public Health Lab, which is on the UNR campus, and creating what we're calling the Public Health Innovation Hub. And this is going to include space for cutting-edge research labs, supporting environmental, behavioral, mental, and occupational health. It will offer community spaces that are going to foster partnerships and support experiential learning. It'll bring students, faculty, and Nevadans together to address real-world health issues. And then also we'll have some strategic focus areas or cores within this building. So very excited about that as an opportunity to bring people together and support the public health, the field of public health generally. And then finally, to improve alignment of public health infrastructure in the state's public health lab is transitioning to the School of Public Health. So this is something that's happening kind of as we speak. And this is something that'll be reflected in a legislative ask in the future. Don't have specific today, but look forward to bringing that back to you as we move forward. So this is just a note of gratitude from the School of Public Health. We're grateful to work with all of our partners who you've heard from today and with you on public health policy. Policy is one of the greatest levers that we have to improve the health of communities in a state. And so on behalf of the School of Public Health, thank you for your support, your attention, and all the time you're spending on these topics this interim. And then, because our partners at the UNLV School of Public Health were unable to be here today, just wanted to provide a little bit of an update from them. They too have academic health department relationships primarily with Southern Nevada Health District, where they place interns for public health students and healthcare administration students. They also have received ARPA workforce grants and have provided scholarships to increase the number of lactation consultants, to support graduate assistants at UNLV, and to support applied epidemiology fellows. And if you haven't seen it, I think in the materials for this meeting, there's a report that DPPH compiled, I think in November or earlier this year, about the ARPA workforce pipeline grant, and I would highly recommend taking a look at it. Some amazing scholarships have been provided through that opportunity. And I just, it's a great report that reflects some amazing work on behalf of a lot of different partners. And then in addition, through some funding from the state, UNLV was able to remodel their community space associated with what is now called the Nevada Community Health Coalition, formerly the Nevada Minority Health and Equity Coalition. And something that you'll hear more about later today is that they're filling a huge gap left by the closure of Immunize Nevada as they stand up the state's new immunization coalition. So I included a link to NVVAX on this slide. The coalition's first meeting is later in April. And so if you're interested in finding out what the coalition's going to do, who it's bringing together, or how it's going to make Nevadans healthier, feel free to join that. And that is it, Madam Chair. Happy to take any questions.
Thank you. Thanks for the presentation. I appreciate that. I do want to acknowledge that I do believe that we have someone from the UNLV School of Public Health here in the audience today. I'm not sure if you want to add comment to this as we close this presentation out, but you're welcome to come forward.
Good morning. My name is Brian Labus, last name spelled L-A-B-U-S, and I'm an associate professor at the School of Public Health. I hadn't planned on speaking on this item. I'm here for the immunization part because I'm the founder of NVAX, the coalition that was just mentioned. All the great things that UNR is doing, we try to do the same things here at UNLV. So the workforce grants, we're working with UNR. We split those. So Dr. Knoll and I have that grant together where we're trying to do those things throughout the state. In addition to their scholarship program, we have an epidemiology fellowship program here in Southern Nevada that places epidemiologists in local health departments here in Nevada for 1 year of field experience. So it'll give them what they need to compete successfully for jobs within the state, to keep our graduates here in the state, and hopefully bring in people from outside the state to try and improve an area where it's difficult to find people quite often. So thank you for this opportunity. I'd be happy to answer any questions about what UNR or what UNLV is doing along with UNR.
Thank you. Thank you for being here today and for putting that on the record. Members, any questions?
Madam Chair?
Senator Titus.
Thank you. So is there, you mentioned about vaccinations, is there still a way to report the vaccines, the WebIZ, the vaccine reporting location? I just want to make sure we can do that still.
Megan Komlossi for the record. I think the next agenda item is going to dive into that in depth, and so Vicki
And I can
Ives
wait then
and
if
team
they're
will
going
be able to answer that.
That's really important. Thank you.
Thank you. Thank you so much for that well-rounded presentation. There are no additional questions at this time, so thank you so much. We'll go ahead and close this agenda item. Moving on to our next agenda item is the presentation on immunization access and services in Nevada, including the impact of federal changes to immunization policies and schedules, status of statewide immunization coalition, and policy considerations. And we will welcome our Bureau Chief, Vicki Ives, along with co-presenters. Thank you for joining us today. It's great to see you. You are welcome to begin whenever you're ready.
Thank you. Vicki Ives for the record, I-V-E-S. I serve as a Bureau Chief for the Division of Public and Behavioral Health and the Bureau of Child, Family, and Community Wellness. And I'll be, after my presentation, introducing two members of the Nevada Association of Local Health Officials, Dr. Roseanne Suge, a medical epidemiologist from Southern Nevada Health District, and Ms. Erin Dixon, Deputy District Health Officer at Northern Nevada Public Health, in addition. And today, just talking a little bit about immunizations, the mission and vision and purpose were covered by our administrator and deputy administrator, so I'll move right into the agenda. Just going to talk very briefly about the Nevada State Immunization Program, some of the federal changes around recommendations, how those recommendations interact with Nevada law and statutes, and some vaccination trend data today. So the Nevada State Immunization Program works with all of the local health authorities within the state and vaccinators statewide, as well as with both the new statewide immunization coalition, NVAX, that you just heard about, and the longstanding HPV coalition that Nevada Cancer Coalition hosts as well. Really, the emphasis is around access to vaccines, facilitating distribution, and ensuring certain programs are available statewide for equitable access. Sharing science-based information is a key element. Nevada WebIZ, thank you for bringing that up, is Nevada's immunization information system, and it's still fully functional and key component. We have about 5 million records within the system. So management of Nevada WebIZ is one of the roles of the program, as well as managing publicly funded vaccine programs and state-funded vaccine programs as well, including Vaccines for Children and 317, amongst others. There is a tie for Vaccines for Children and 317 to ACIP recommendations. And just wanted to note, state funds are really specific to CHIP, or Nevada Checkup, in partnership with Medicaid and Nevada Health Authority. We facilitate access to CDC vaccines, pricing, distribution systems in partnership with them to serve all CHIP children statewide. And thank you as well for the state funding for the cocooning program, which supports vaccination specific to pregnancy. Some of the impacts were mentioned by Deputy Administrator Peak earlier. The program experienced one of those very rapid loss of funding, where 22 contractors had to be laid off within a day, with precipitous loss of COVID funding. There's a decrease in the base award this year, and one's anticipated next year as well in the main federal award. Okay. Oops. There we go. And then just regularly, historically, Advisory Committee on Immunization Practices, or ACIP, is really a space where there's a very clear process by which recommendations are developed on the use of vaccines and vaccine-related products like monoclonal antibodies. So ACIP really develops the recommendations on how to use vaccines and control disease, And then there's a process by which these recommendations go to the CDC director, who, if they approve and adopt, becomes part of CDC policy and gets published. And recently, there's been federal and ACIP specific changes, including just high level, the complete replacement of the membership of ACIP, replaced with a smaller number of members. There have been decisions around COVID-19 and changes to a broad swath of folks being under clinical decision making now, which is when clinicians and patients make healthcare decisions together. And it requires a documented risk-benefit discussion now within someone's scope of practice under that change. Some changes also on a specific vaccine related to measles, mumps, rubella, and varicella, changing that so that's no longer recommended for under 4, and asking for the disaggregation of varicella from that, changes to universal hepatitis B recommendations, and then in a very different pathway than we've seen before through the Secretary of the Department of Health and Human Services, large changes to the childhood vaccination schedule have all occurred, just high level for some of those changes. And really key takeaways, there's impacts to these recommendations. If they're adopted by the CDC director or Department of Health and Human Services, it can impact access, insurance coverage, ability to use our federal funds to purchase, order, distribute vaccines. And just with all the change, just noting there's been quite a bit of confusion for families, for providers, the general public, for lots of folks, a lot of change in a short period of time, and confusion can impact uptake, impact rates, and coverage. And then very recently, a temporary stay occurred that was referenced earlier or today in some of the public comment, and it basically there's some concerns around potential bypassing of scientific and administrative processes. So there is a stay, and specifically the Federal Advisory Committee Act potential violation is the focus of this. But it really temporarily stays and undoes a lot of those changes currently based on this temporary stay. So it really means that the schedule revisions that just happened to the childhood schedule, the recent ACIP member appointments, all of the ACIP votes, currently have no legal effect, and there's also the committee, just generally with ACIP, their activities are temporarily halted, and that ruling really stressed the importance of evidence-based vaccine policy. Now, within the Nevada legal context, there's 12 mentions in Nevada revised statutes, 2 in Nevada administrative code. NRS really focus on who is authorized to provide vaccines. There's some language specific to Medicaid and state-regulated health insurance, particular account for family planning program, and WebIZ reporting requirements. In addition, Senate Bill 5 of the 36th Legislative Special Session had elements specific to pharmacists that really rolled back ACIP recommendations and use to those that were in place as of January 1st, 2025. And then lastly, the Board of Health met early this month and approved a recommendation to use prior ACIP guidance under processes outlined in NAC 441A, Section 200, subsection 2, which really relates to guidelines adopted by reference and gives the Board of Health under certain circumstances to go back to using earlier forms of guidance if it's the best interest of the state. So that was recently approved. Really key element, no changes for, our statutes are the same, regulations are the same in terms of schools and daycare facilities, universities. These don't have a direct impact on that. And then just a couple ways to view the recent childhood scheduled changes. If you look in red, these are all vaccines that used to be recommended for all children that no longer are. This is just another way of looking at the same information On the left are vaccines recommended for all children, and on the right top, only for high risk, and the bottom quadrant on the right is that shared clinical decision making we just spoke about. And looking just at one example specific to hepatitis B vaccine, which changed from a universal birth dose framing under the new childhood schedule. It's really changed to focus on a birth dose only for hepatitis B positive mothers, shared clinical decision making for those with a negative status, changed the age of initial dose, added some language around serology testing, and included risk considerations as well, just as an example. And then lastly, this really is just intended to show you on the far right, these are in Nevada law, what's required in daycares and schools. And you can see that of these, there are 3, hepatitis A, hepatitis B, and meningococcal, that are required in Nevada law for schools and daycares, but aren't currently recommended for all children under the revised schedule. Just another way to look at the same data. We have been able to carry on all of our vaccination programs with federal funding, with state funding, the same as before these recommendations came out in terms of our ability to purchase, order, and distribute vaccines through those programs. So we have not seen changes as of now to that process. But we do see, confusion for the public, different guidance, and worry about vaccine uptake impacts because of this really dynamic environment. A recent wrinkle, CDC just announced that they're going to start charging for the distribution of state vaccines. So all the chip vaccines are for states. We're not a universal purchase states, but it's an incredible impact for those states that are. So any state funded vaccines, now there will be a cost sharing. That model isn't public yet, but it is effective 7/1/27 and creates another unfunded mandate. We also have an unfunded mandate specific to the IIS that to be able to keep that. Currently, that's federally supported, the IIS. And briefly in these, just really high level, this is some data related to measles, mumps, and rubella. Draw your attention to the top, the blue line, which is age groups 0 to 2 in Nevada for MMR vaccination rates. And just highlighting between the years 2015, when rates were at just about 90%, to 2025, where rates are at 85.4%. Just going to show a few examples of changes that we've seen. The other age group on here is 13 to 17, and that's like more of a 1 percent point decline. Hepatitis B birth dose, so this is just the initial dose. This is preliminary data, but really just wanted to highlight the no column. So it's comparing 2023 to 2025, we can see the number of refusals for that initial dose has increased. It's gone from a little over 5,500 in 2023 to a little over 9,000 in 2025. The 7 series, combined 7 series for 19 to 35 months of age, which prevent critical serious diseases before 24 months. This has race and ethnicity data, but just drawing your attention to the totals here as well. Between 2018 and 2025, the overall rates of all groups combined went from 66.1% down to 64.6% in that time period. And you can see quite a bit of variation by group, broken out by race and ethnicity. Just want to highlight the non-Hispanic American Indian or Alaska Native rates in 2018 at just under 63%, dropping to just under 57% for the 7 series. So it can vary by group, the impact, which is, why concerns around exacerbation of pre-existing inequities are key in terms of access. Looking at kindergarten only on this slide, exemption rates, we have both religious and medical exemptions in Nevada. Schools share their data with the Nevada State Immunization Program, and then the Nevada Health Authority's Office of Analytics presents those in a dashboard. There's report cards that go out to school superintendents too, sharing county level data. But when just drawing your eyes on the left to the vaccine religious exemption rates for kindergartners, there's a comp between U.S. and overall for Nevada for 24-25. You can see U.S. was at 3.4%, whereas Nevada was at 6.7% for religious exemptions. And then when you look at the school year 25-26, we see Nevada has jumped from 6.7 to 8.2% in religious exemption rates. We don't have the federal comp yet on that, but we will. Medical exemption also is 0.2 at the U.S. level and 0.5 in 24-25. So also that one's slightly more than double the U.S. rate. When you combine kindergartners, 7th graders, and 12th graders, who are the focus of that annual data collection with the schools, we see that medical exemptions were fairly stable, but private schools show a little different pattern. And then our trend with religious exemptions, you can see, consistently trending upwards. Overall, the change from the 2019-2020 school year at 3.5% is now at 8.4% in the 25-26 data. And then if you dial in, I know it's impossible to see on here, but the private schools are at 14.2% for that same year. So we have seen increases there. For interest of time, I'll skip that one. It's available in the slides. For one dose HPV vaccination rates, looking at age group and race and ethnicity for 13 to 17-year-olds, you can see the trend lines are a little clustered, a little closer together. We've seen a drop between 2018 and 2025 from coverage of about 51.6% down to 50%. But again, when you look at individual race and ethnicity groups, you see quite a bit of variation, and just wanted to highlight the non-Hispanic Black rates of just about 65% in 2018, dropping to just under 56% in 2025. And then looking at flu, two different types of data shown here on the left comes from a self-report data, a national survey, but it allows us to compare with the U.S. rate. Gray is the U.S. rate at 43.8% in 24-25, and in blue is Nevada at 33.5%. And then on the right, dialing in just to the percent of children 6 months to 17 years vaccinated against seasonal flu, we see an overall drop from the 24-2015 season at 22.2% to 15.4% in the 24-25 season. So a drop in percentage there. This is just one other way to show it as a heat map. Just draw your attention. Green would be more favorable rates, and red would be lower vaccination rates. Just drawing your attention to Esmeralda, for example, that in 2018-2019 had just under 11% rate, and by 25-26, 5.2% rate. But this heat map can kind of help you identify steepness of trends. It's just another format. And lastly, looking at RSV rates, just drawing your attention to the 0 to 2 age group represented here. You can see the increase from 2023 at 1.6% to 8.3% in 25-26. So seeing an increasing trend in our infant and toddler RSV rates. You can also see there's a decline in the 60 and over, not maybe the focus of today's, and you can get this vaccine at 50 now, but this was just to be able to compare years. So with that, I would love to introduce our co-presenters, Dr. Roseanne Suke and Ms. Erin Dixon.
Good morning. For the record, Erin Dixon. I'm the Deputy District Health Officer for Northern Nevada Public Health. I have just one slide here I'd like to share with you as the impact of what we're seeing when our vaccine rates are declining a little bit. Vaccines are our prevention, and investigation is our reaction. And so, as stated previously, Washoe County is seeing an increase in exemptions for both the DTaP and the Tdap vaccine, which is our best defense against pertussis, which, as a reminder, is a highly contagious disease. In 2025, we had 31 cases were investigated. That was the highest number since 2014. In 2026, NNPH has already investigated 19 cases, which has included workplaces, 3 schools with over 3,000 students total, a medical office, and sporting events. And unfortunately, there have also been a few infant cases with severe outcomes. Our limited epidemiological resources shift during our larger investigations to contact trace and case follow-ups, diverting their attention. And as a reminder, pertussis is just one of 90 reportable diseases that our team handles. And so I do want to take this opportunity to thank our team for their ongoing hard work. And I can hand it over to Southern Nevada Health District, and I will be available for any questions later.
Good morning. So Roseanne Sugay, S-U-G-A-Y. I'm the medical epidemiologist at Southern Nevada Health District. And thank you so much for this opportunity to give you a little peek into what we do on the daily. I wanted to shift the talk of vaccine preventable diseases to something we've been hearing in the news more often, which is measles. As you can see, measles is highly contagious. 9 out of 10 people who are exposed who are not immunized will get measles. And the thing with measles is there is no specific treatment, and there is a risk for severe complications. People can get hospitalized. A few years later, an infant can develop encephalitis and even death. With that as well, measles can be contagious 4 days before the rash shows up, which makes our work in contact tracing a little more challenging. So one case of measles will trigger a large multi-team response. We have not had a measles case since 2018 until 2025. So at the end of 2025, we did have 1 measles case locally. That would involve contact tracing. It involves exclusions. If there are people we can confirm were exposed and are unvaccinated. When we talk about contact tracing, that will be anywhere we can identify that a case basically visited. So whether it's a school, a grocery store, or a resort corridor, those are all things we would have to consider. And monitoring for measles can take up to 21 days, which is the incubation period for the disease. So you can see that there's a lot of public health activities that happen even with just 1 case. We don't need an outbreak for this to happen. Given that we are also a city where a lot of people come in to visit, when we do have a case reported of somebody who had measles, even if they're not a Clark County resident, if they were in Las Vegas when they were contagious, that is also something that we would have to investigate. As you can see, in terms of those travel associated reports, in 2024, we had 1 investigation of and public notification because there was a case of measles that was here. 2025, we had 4 reports, and we're only in the first quarter of 2026, and we've already had 1 report of an exposure. And as you've already heard from Vicky, vaccine exemptions in schools have increased, and there is a decrease in our MMR coverage within schools. That's it, and happy to take questions as well if there are any.
Thank you. Does that conclude your presentation?
Yes.
Thank you. Ms. Ives, does that conclude your presentation as well? Thank you. I could see your head. Thank you. Great. Members will take questions. Anyone have questions at this time? Senator Titus.
Thank you, Madam Chair. I appreciate it. And thank you for the updates on the vaccines. A couple questions that I do have. Again, my last question was before you guys came to the table. we do have quick access continued when I give a vaccine or receive a vaccine. We can you rapidly are still required to put it into Web ID or whatever it is that we use, so that we can make sure who's vaccinated and who's not. Is that correct? That's not changing.
Vicki Ives, for the record, yes, that's correct. That hasn't changed. A few years ago, there was a threat by CDC to take away all funding for our IISs, everyone, not just Nevada, and then they reversed themselves, so it didn't actually happen. So it's federally funded
That
completely.
has not changed.
No.
So thank you for that. Second, I have a couple questions, if I might, Madam Chair. Back to page 15. When you look at the declining rates of immunization, say for just the MMR, the rates have really started to decline, not during this current administration, but long before that. I mean, I think we saw a complete distrust during and after COVID. And what I'm frustrated by is that we're not seeing, I didn't hear anything in your presentation, and maybe it will come later, on what we're doing to kind of combat the phobia against vaccinations, because there's been a distrust and people declining vaccines long before this current administration. So what are you doing to help kind of stop this flood of people not getting these vaccines? And again, it started long ago, and I'm not hearing any of that. And are we going to get a presentation on some ideas, some brainstorming, how we can help combat that distrust?
Vicki Ives, for the record, thank you for the question, and to the chair and through the chair. We have numerous efforts around vaccine confidence. I do think we work closely with all the local health authorities, as well as funded partners like the coalitions that were mentioned in that vaccine confidence space. That was a huge emphasis with the COVID funding that was lost as well. So some of those staffing impacts that filtered down to the locals as well, that had an impact on some robust efforts around building vaccine confidence, but it didn't end them. All of our funded partners, it's a component of our federal awards too, just the importance of using trusted messengers to share information. We partnered on prior funding with, even at the provider level, partnering with medical societies to reach out to other providers, and just like within communities with lower vaccination rates, just intentionally working with trusted partners to try to get that messaging out. Numerous informational campaigns focused on have vaccine confidence and sharing fact-based information to present to people have been ongoing. There's Nevada Broadcaster Association long-term campaign just completed in January. We had, working with the Nevada Association of Counties, a rural focus vaccine information and confidence campaign that ended. A lot of those were supported on COVID funds, and with some of the cuts that we're finding, we're really relying on getting information out to providers, to partners, and funding partners to work in that space as well.
A follow-up, Madam Chair? So one of the things that I see is, and I've really been a proponent of, is access to care. And you mentioned Esmeralda County, which I represent, and they're dropped dramatically. They never had a good record on getting vaccines. But I don't know that it's distrust as much as access. And we here in this body have been trying to improve access by allowing pharmacists and going to, I got my vaccines at Walmart. I mean, I think that it's important to make sure that access is there, and those counties don't have that. Tonopah, for example, no health care. I mean, they have a nurse there at times, but just really concerned about that access. What are you doing to help rural counties with the access?
Vicki Ives, for the record, thank you for highlighting that. One area that we're trying to expand is, oh, sorry, I'll jump right in, is we're trying to partner with Kroger to get their stores to all be vaccines for children providers. So it's taking a while, but there's a champion within the Kroger system. So that's something we're working on to get more pharmacies as VFC providers is one area to help support rural access. Funding the Central Nevada Health District as a newer partner to the immunization program is another. But yeah, access is key. And even when something, say for the RSV, Nevada is one of many states that extended the season to April, and we shared that information. But you know, we're hearing from residents that they had to go to 4 pharmacies, and even though it's allowed, and they actually took the technical bulletin with them and couldn't get vaccinated. They eventually found a pharmacist provider who would, but even if something's allowable and doable, you know, maybe corporate chains set the age at which over which they have to serve. So if they set it at 8 or at 12 at the corporate level, that decreases access for your younger ages potentially. So there's a lot of variables there, but I think one of the most promising areas in increasing access is more partnerships with VFC providers through chains, through pharmacy store chains is one area.
Julia Peak for the record. Just to add, I'd be remiss if I didn't mention the Rural Health Transformation Grant again. I think that has such great opportunity, and the minute really when we heard the funding was going to be coming to the state, Medicaid reached out to our agency to figure out how does this impact public health, specifically in the counties in which we oversee as the health authority, but all of the counties that are able to apply for this funding. So locally, as we look at how we modify health outcomes is one of the things that's looked at. If it is access, you know, our community health nurses are looking at that. Do we apply for certain components of that award? Does the community apply for certain components of that award to really move the needle? If vaccinations is a priority, I think it'd be great to talk offline, especially with the Medicaid team, to see which specific funding categories and who would be appropriate to support that. Huge opportunity to move the needle in those counties.
One last question or observation. I see from the list of what the new recommendations, it's important in some aspects of hepatitis, RSV, those type of things, but the overall recommendations are still there. The DPT and all of those that, and I've made this comment before that prior, when my thousands of hours working in an emergency room, when I recommended a tetanus shot to somebody, they might say, "Oh God, doc, I hate shots," but they never said, "No, I won't take it." If I said, "No, you're due," etc. So something happened during COVID subsequently where they questioned every vaccine. Looking at what their new recommendations are, they're not questioning every vaccine. We are still recommending on the federal level, the state level, DPT, and those routine childhood immunizations. The pushback's been hepatitis, whether you agree or disagree, the RSV, whether you agree or disagree. But I don't see our state doing a good enough job to say, hey, these are still recommended, because it's an overall pushback on vaccines. And I really want to see more of a push in reaching out, public service. I mean, I think it's critical, and I don't see us, we do a lot of complaining. I see a lot of concerns. You can blame whoever you want to, but at the end of the day, it's still, in my mind, communications about getting the information out there about these vaccines, because I think they're critically important. And I see a lot of money being spent on a lot of complaints, but not any improvement. So you have my cell numbers. You need to reach out. I am happy to help however I can, because I think it really is a public disservice that we are not actually communicating what the vaccine recommendations really are still. And folks aren't getting any of these vaccines, which is crazy to me. So again, I just need to see more public outreach. Thank you. Thank you, Madam Chair, for letting me vent a little bit here.
Julia,
thank you, Senator.
Sorry.
Go ahead.
I was just going to say, for the record, Dr. Titus is the longest standing county health officer, so I think perhaps we can work offline to figure out how the county health officers could also be that trusted voice. The trusted voice is so important, and you talked about it as the physician as well. New opportunity, just to reiterate again, the Vaccine Coalition, supported by UNLV, is going to be restarting. That's where we can have the conversations about how do we get to the individuals that are most impacted. But I do think the county health officers and or district health officers, depending on that makeup, are a huge trusted partner in the community. So however we can get you the information you need, happy to do that. Thank you.
Thank you. We'll move on to Senator Danyate.
Thank you, Madam Chair. Before I go into my questions, comments for policies, because I want to hear the feedback on some of these things, these conversations that have happened over the last 12 months. I just want to make sure that folks know that I think that sometimes in this conversation, we get lost in the argument of mandate versus choice. And I think in my questions, I want to make sure that you can, I want to emphasize that you can achieve parental choice while also increasing vaccine uptake, which is kind of to the comments of my colleague up north. There have been a few things that we've learned from the pandemic, and I wanted to get feedback from the administrators here, because I think this can possibly go into the policy recommendations that the committee does. Obviously, during COVID, we did a standing vaccine order for the COVID-19 vaccine. I know that some states, Virginia comes to mind, New York, et cetera, have been looking at streamlining standing orders, either done through a district officer, county officer, or through the state's chief medical officer. If we were to go down this route of looking at vaccine access and removing the barriers as much as we can, again, not talking about mandates, et cetera, but just looking at from the access perspective, does the department, or does DPBH, et cetera, have the ability to start implementing this? And what would it take to implement such a program? Is it based on the COVID-19 lessons? Are we going to have to hire staff to implement this change? Are there regulatory considerations that we have to implement specifically on that point? And then I'll throw two more ideas.
Vicki Ives for the record. I think we're in a different situation now, just because of the Board of Health piece that we're functioning on the recommendations that were existing before that change in the state, and we have schools, universities, and daycare facilities, codified there. So I know there's a really varied group of folks involved with all the local health authorities and the state entities looking at vaccine policy, and recent discussions, I would say, have not focused on standing orders, if that's helpful.
Yeah, Julia Peak for the record. As Ms. Ives mentioned, we've had a lot of discussions with the public health leadership in the state. That includes the universities, NACO, and others, as changes have come related to vaccinations and other public health policy. And so we, as a group, figure out what options that we have. Southern Nevada Health District was one of the first to put out a standing order. I believe it was for COVID at the time when the changes first occurred, but I can double check that for you. That was one option we looked at doing. So there are a number of tools in the toolbox to address access. It turns out we didn't need that later, but that's one of the options. I think at this time, one of the biggest challenges we have is confusion on access. And that's the communication piece that we've all talked about, confusion on access. So as Ms. Ives mentioned, we've put out information where members of the public literally bring the information from the state saying, I can't access this vaccine, can you please give it to me? So there is a disconnect there about the information and education that is affecting access. And in that case, Senator Danyate, to your point, that is total patient choice. They do want it, we have access to it, they should be given it, and there's a disconnect in those situations. So we as public health community are meeting and saying, here's what happened, what do we do? Do we need to put out more technical bulletins? Do we need to do additional messaging? Is there a standing order? In that case, we did one initially at the health district to try to address some of those access issues.
Thank you. And I think the reason why I was asking that is because you're completely right that I think some of the constituent concerns that we've heard is the navigation of being able to access that service or that particular outcome. I would love for the department, maybe if, I think there's a lot of interest from the committee members on this subject area, perhaps if the department can look at really how, I think there are reforms that we can do in terms of achieving parental permission at the school district levels to implement outreach efforts, et cetera, at the school level. That seems to be a correlating concern that has been repeated over and over again. The complication of how do you retrieve a parental access or consent for procedures, et cetera. Like, this is not just unique to vaccines. I think it's coming up in other circumstances, but I think your department probably can help us reform and create a statewide regulatory structure that we can start to simplify and make it easier for parents to give consent for certain procedures. I'd love for your department to give us, and I know you just gave a grant for a statewide coalition. Obviously, we've seen the efforts of why that came to be fruition, why that came to be over the last few years. But I would love, I guess my point being is, I want the department to give us a budget of, this is what it would take to develop school-based clinics in Esmeralda County. This is what it would take for us to simplify and make sure all the school districts are in the same line in terms of reforming consent forms and having an electronic system so that parents can consent, right? This is what it would take for us to implement needle-free alternatives, right? I think FluMist is something that's already approved by the FDA that doesn't require a needle injection, kind of to the comments of my colleague up north, right? These are things that we can use to implement already and products that are coming on the market, but I just want to make sure that our laws are reflecting of that.
Julia Peak, for the record, agree and understand. I would also say our health authority partners are doing a lot in the areas of school-based health as well. So both departments, I would say, are working on this topic. And as we get more clear granular issues of the specific areas related to vaccination where folks are having a barrier to get their child vaccinated. I'll also, again, you said it, but I'll say it again, the coalition has always been a great partner to work in schools to get vaccination access, and having a brief hiatus of a coalition was a challenge, but we can definitely look at school-based health services with our partners at the coalition and then the health authority to figure out how we can better address that.
Thank you. Members, any other questions? Okay, seeing none, thank you so much for your presentation. Thank you for being here today and for answering all of these questions. Thank you for the care of our community and helping to keep us all safe. With that, we will move on to the next presentation, members, just so that you are aware, this is the last presentation we'll do, and then we'll take a quick break for lunch, and then come back for the last couple of presentations. So the next item on our agenda is an update and policy recommendations on tobacco control and youth vaping. We have a number of presenters that are here today. Kristen Clements-Knoll, Foundation Professor and Graduate Director of Epidemiology at UNR, Jennifer Pearson, Associate Professor at UNR, Nicole Chacon, Manager, Nevada Tobacco Control and Smoke-Free Coalition, and Jennifer Atlas, Government Relations Director for the American Cancer Society and Cancer Action Network. Thank you all for being here. You may begin when you're ready.
All right, Kristen Clements-Knoll for the record. Dr. Pearson, can you give me a thumbs up? Can you see me? Great. Do I need to share my screen? Sorry. You guys are gonna do it?
No, I will advance for you, Kristen.
Okay, thank you, Jenny. So I'm going to be presenting data on the past 10 years of data collection from our Youth Risk Behavior Survey. I really want to acknowledge our partners on this project, the Nevada Department of Education, Nevada Division of Public and Behavioral Health, Nevada Statewide Coalition Partnership, and all of our school districts, and certainly the Nevada students. Go ahead, Jen. So I just want to take a few minutes to explain how the Youth Risk Behavior Survey works nationally and how it works in Nevada, which is different. So for many, many years, the Centers for Disease Control and Prevention have funded states to conduct a state-level YRBS. So in Nevada, that means we sample about 36 high schools statewide, only high schools, and the majority of these schools would be in the Clark County School District. Through AB 331, the Nevada Division of Public and Behavioral Health is contracting with UNR to sample all other high schools and middle schools, and this includes our tribal schools across the state. And so in 2025, we sampled well over 200 high schools and middle schools with this supplemental funding. We also have NRS statute that requires that school districts participate in the biennial YRBS using passive parental consent. And the biennial timing is in the odd numbered years. So we just finished data collection in 2025. Classrooms at each school are randomly sampled, and the teachers and the classrooms, they share the incentive with the classrooms, receive Amazon gift cards for participating, and then if they hit a 80% response rate. Following parental permission, the students complete an anonymous survey in the classroom, so it takes one classroom period. So in 2025, in our high school sample, we had 99 schools participate. That was 5,584 students overall, and that combined school and student participation rate was just about 67%. I have not seen the national data, but in 2023, our state had the second highest participation rate, and I believe in 2025 will be either the first or the second. In our middle school sample, we had 114 schools, and that was 6,000 students, and that was an overall response rate of 70%. Nevada is one of the only states, there's about 3 states that conduct a middle school sample, and the middle school data is critical to our public health prevention work. So we're very, very appreciative of the supplemental funding to be able to have a middle school YRBS. Next slide. So first I'm going to talk a little bit about some of our trends in cigarette use. Next slide. So this shows our state level data, and first we'll look at the high school rate, and you can see that from 2015 to 2019 there was a decrease in lifetime cigarette use, so dropped from 32% to 18%. But since that time, with our high school students, we've been relatively stable, very stable in 2023 and 2025, around 15%. We would have hoped that that decrease we've seen over the past, not just 10 years, but 20, 30 years would continue, but it appears to be stabilizing. We see a similar trend with our middle school data, where there was more of a decline from 2015 to 2021. And now the prevalence of cigarette smoking, lifetime cigarette smoking is very stable, around 7%. Next slide. When we look at past 30-day use, we see that there was still that initial decline with our high school students from 15 to 2019, but the prevalence is very stable, and actually we've seen a bit of an uptick in 2025. And with our middle school sample, we've got about 2.4% of the sample reporting past 30-day cigarette use, and that's been consistent. We haven't seen a drop. We do monitor our past 30-day data very closely because this is more sensitive to any sort of changes in social norms or changes in prevention activities. Next slide. So we have some additional questions on the YRBS that are very important. One thing we look at is early initiation. And for the high school sample, that is defined as beginning to smoke cigarettes before the age of 13. And 8.2% of high school students smoke cigarettes for the first time before age 13. Our middle school sample is younger, so early initiation is defined as smoking before age 11, and 3.4% of middle school students smoke cigarettes for the first time before age 11. So very early initiation in both the high school and the middle school sample. We also ask a series of questions around perceived risk of harm. We know that both, what your perception is of harm from different substance use, as well as what you perceive your peers think about substance use or your parents. are really important for shaping social norms. And about 40% of high school students said that there was no risk or only a slight risk of harm for smoking one or more packs of cigarettes per day. About 38% of middle school students reported that there was no risk or slight risk of harm from smoking one or more packs of cigarettes per day. So this is certainly an area we want to, sort of work to change, not just the perception of harm, but also some of the other social norms. We also asked high school students about their ease of access, and about 40% of high school students thought it would be very easy or fairly easy to obtain cigarettes if they wanted them. This would be all students. It's not just students who are current smokers. Obviously, that is a much higher percentage if we look at those who are currently smoking cigarettes. Next slide. So I'm going to switch now to electronic vapor product use. So this would be all electronic vapor products, and I'll talk a little bit more about some specifics a little bit later on in the presentation. So as we saw sort of nationally, lifetime electronic vapor product use sort of peaked to 2015, 2017, 2019, and then declined. But we have seen pretty stable prevalence with 33% of high school students reporting lifetime use in 2023, and that really didn't change in 2025. Somewhat similar pattern with middle school students. In our most recent years, we have 17.5% of middle school students reporting electronic vapor product use and lifetime, and 18% in 2025. Next slide. With our past 30-day use, we saw an initial decline, but then an increase followed by subsequent declines. But again, we have not seen that strong decline from 2023 to 2025. So in our most recent years of data collection, we're at about 15% to 14% of high school students reporting past 30-day use of electronic vapor product use. And with our middle school students in 2023, that was 19.5%. And in 2025, it was 8.5%. Next slide. We also have separate questions where we look at what youth are vaping. So in the light blue, we have the proportion of youth. So we'll look at the high school students first, who reported vaping marijuana in the past 30 days. And that's been relatively stable, 16% in 2021, 15.7% 2023, and 14.6% in 2025. And a very similar percent, almost identical percent report vaping nicotine. So this would be e-cigarette use, and that's hovering between 13 and 15%. In our middle school sample, we also see that a similar proportion are reporting vaping marijuana as vaping nicotine. It has gone up over time in our middle school samples. It was about 5% in 2021. And in 2025, we have 7.4% reported vaping marijuana in the past 30 days, and 7% or so reported vaping nicotine in the past 30 days. Next slide. It's also important to just look at how youth are using, what their usual mode of administration of marijuana is. This is data just on those who reported using marijuana in the past 30 days. And you can see both in our middle school and our high school sample, 40.5% said the usual way that they would use marijuana is by vaping it. And the middle school sample, very similar proportion, 38.3%. And we have seen over time that a larger and larger percentage of youth are shifting from smoking marijuana to vaping marijuana. Next slide. Couple additional findings as we looked at early initiation of cigarettes previously. This question looked at early initiation of using electronic vaping products, and 6.1% of middle school students first vaped before age 11, and 11.2% of high school students reported that the first time they vaped was before the age of 13. And even higher proportion of high school students, 50%, reported that they thought it would be very easy or fairly easy to obtain electronic vapor products if they wanted them. Next slide. So we just released our 2025 statewide data. You can scan the QR code to obtain our state reports. We also prepared coalition level reports that we have sent to the coalitions, and we are now starting to work on regional reports. So rural reports, from different counties, but all of our reports are posted as they're developed at our website, which is shown here. And I'm happy to take, I think I have a time for a few questions.
Thank you for your presentation. Thank you. Do you want to present before we take questions? Back and forth. Okay, thank you. Thank you so much. Members, any questions on the reports that we've received so far? Okay, I think we're good. Thank you so much. I appreciate the information. I did pull up the QR code and look forward to looking at the newest report with regard to the data. It's troubling to see that we still have growing access to vaping and tobacco, so I appreciate the information. Okay. From that, we'll move forward with the next part of our presentation.
All right, good morning, or afternoon maybe. My name is Jennifer Pearson. I am an associate professor at the School of Public Health at UNR. Last name spelled Pearson. And today I'm going to be sharing some results from an ongoing study that's answering a simple question: does electronic ID scanning reduce underage tobacco sales? Before I get going, I just want to briefly acknowledge my colleagues and the funders. So this is an ongoing study funded by the National Institutes of Health and conducted by colleagues at UNR, Rutgers, and Wake Forest universities. Just a caution, these results have not yet been peer-reviewed and are ongoing, and any policy recommendations reflect my own interpretation, not that of the NIH or my co-investigators. So, in 2019, as way of some background, the federal minimum age to purchase tobacco was increased to 21. In 2021, Nevada passed AB 360, which requires clerks to electronically check IDs for anyone who appears under the age of 40 attempting to buy tobacco. And that law was implemented January 1st, 2023. And this is great because it is a much stronger standard than simple visual checks alone, and promises to decrease underage access to tobacco, which, as Dr. Clements Knoll presented, is absolutely still an enduring problem. So my colleagues and I saw this as an opportunity and decided to put together this study. And we're asking two main questions for this part of the study. The first one is implementation. So are the clerks actually scanning IDs as the law requires? And second, are there certain store types that are more or less likely to scan IDs and follow the law? And then secondly, effectiveness. Does scanning IDs reduce illegal sales to underage buyers? And that is actually a rather complex question, but I'm going to present preliminary data today. So what did we do? Well, we compiled a random sample of tobacco retailers in Washoe County during summer 2025. And I employed 9 underage students from UNR, ages 18 to 20. Their pictures are there. None of them look over the age of 40, certainly. And actually this morning you heard one of them call in, and then at least 2 of them submitted written comments as well to this committee about their experiences. We told the students not to lie about their ages and to provide ID when asked, and this was not a fake ID, this was a real ID. They were instructed not to try to look old. They were instructed to just act as they would normally. Our design was meant to just mimic real-world experiences and not to change clerk behavior. The clerks did not know they were being observed, and we did not provide any education or warnings to retailers who sold to the underage buyers. So what we accomplished is we completed over 1,000 attempted tobacco buy attempts at 66 stores in Washoe County. And again, the data were collected last summer. So first, I'm just going to show you some brief data about whether the law is actually being followed. So prior law just said you need to check ID, right? Visual inspection. So 86% of purchase attempts, and 86% of these attempts, the clerks were checking ID. So they're doing a reasonably good job of following prior law. However, current law, only 57% of attempts, the clerks actually scanned the ID. So certainly there is plenty of room to improve, when it comes to following the new law. Next, I'm going to show some preliminary data about why scanning matters. So first, overall, so independent of checking or scanning, overall, 21% of purchase attempts ended in a tobacco buy. And I don't know if people can see on the video, but I have 2 large containers here of tobacco products. This is everything that my buyers purchased. I could open the tops and you could smell the incredible smell of flavorings as well. These are cigarettes, cigarillos, nicotine pouches, e-cigarettes, and smokeless tobacco. So, if the clerks did not check IDs at all, not even a visual inspection, 96% of the attempts ended in a tobacco purchase. So certainly, some sort of check is absolutely essential. If the clerk just checked the ID, didn't scan, 18% of the purchase attempts ended in a sale. So 21% to 18%, that's not great, right? So the visual inspection's not really decreasing underage sales. However, if the clerk scanned the ID, only 5% of purchase attempts ended in a sale. So that is kind of preliminary data, but pretty convincing preliminary data, that the scans do decrease underage purchase of tobacco products. So given that, where should we focus resources? Well, these are 3 groups of bar charts by type of convenience store, by type of store that sells tobacco products. So you've got chain convenience store on the left, non-chain convenience store in the middle, and then everybody else on the right. So what you can see is that the chain convenience stores, they do the best job of checking IDs. That's the blue column. So 93% of purchase attempts, they checked the ID. That decreases to 78% of purchase attempts, they scan the ID. But you can look at non-chain convenience and everybody else, they're not doing as good of a job checking, and they're certainly not doing as good of a job scanning. And then 15% of the purchase attempts at chain convenience stores ended in a purchase. But that was higher for non-chain convenience stores and everybody else. But then you can see when scanning happens, the proportion of completed tobacco sales to underage people goes way down. So that suggests to me again that the scans do reduce underage access to tobacco products. So what did we learn? Electronic ID scanning really does look like it will yield fewer underage tobacco purchases. And why is this important? Easy access increases risk of lifelong nicotine addiction, disease, and death, not to mention incredible burden on state Medicaid budgets. The state could lose also a decent amount of federal money, 10 to up to 40%, depending on the year, if underage sales violations during SINAR inspections, which are inspections that started, I want to say, in 1992. They are federally mandated. They are when underage people go into tobacco outlets attempt to purchase, and if they are successful, a fine is incurred by, I believe it's a sheriff who accompanies the underage person. So those violation rates are reported to SAMHSA every year, and if it goes over 20%, then SAMHSA can remove SAMHSA dollars. So the next steps for this project is we are going to be repeating data collection in summer of 2026 and 27. And we are talking with the state about expanding data collection to other parts of the state. Again, this was just in Washoe County, just for budgetary and logistical reasons, but we'd love to take this to the rural areas and definitely to Las Vegas. So I know that you all are interested in policy recommendations, so I have a couple. First, I think there's a really great opportunity here to increase support to strengthen education and enforcement about the law that you passed in 21. And I would be very interested, obviously we're going to include the public health community in figuring out how to strengthen this education enforcement, but I'd really be interested in involving the retailers, particularly the non-chain convenience stores and the vape and tobacco shop retailers, in what can we do to make sure you guys follow the law, right? So how do we increase education? Maybe we need to translate materials into other languages, or additional languages, I should say, so that we can actually increase awareness of and compliance with this law. And then the second policy recommendation, this is just something that I noticed because I asked my buyers, and there's two of them, Miles and Kaz, for their IDs. I was curious about, is there something about the ID that is making visual inspection of their IDs difficult for clerks? So as the state is trying to improve scanning and access to scanning technology, maybe there's a way to improve design. So these are IDs that were issued after the summer 2021 redesign of IDs in Nevada. Miles was age 16 at the age of the issuance of his ID, and you can see that red lettering. It says under 18 until a certain date. Okay, but he was 19 at the time of data collection when he was going out and doing these underage sales. So that red lettering does not help a clerk visually inspect his ID and say, okay, yes, it's simple math, but they've got lots of things going on. I don't know if you guys have spent a lot of time in a convenience store anytime lately, but it can be a little chaotic in there. So they're just trying to get through a long line of customers. It would really help, perhaps, if it said something like under 21 also until a certain date. And Kaz, on the right hand, Kaz was 18 years and 1 day when he got his license, and it says nothing at all about when Kaz turns 21. So, maybe this is some low-hanging fruit, something to consider. So that's it from me. Thank you so much for your time, and I am happy to answer any questions.
Thank you for the presentation. Thank you for the data and the show and tell. Please don't take the lid off. Members, any questions on this presentation? Assembly member.
Thank you so much, Chair. Thank you for the presentation. I have a general question about cigarettes. If the age when a student or any person can acquire a cigarette, that is 21 years. So how so many elementary school students, they are getting access to cigarettes or vaping? That is so concerning.
Right. So the data that Dr. Clements Knoll presented was from middle school, but that's still, as young as 12. That is absolutely concerning. So the younger they get, the more likely they are to have access via social sources. So friends, or if a parent smokes. This is why one thing that we often overlook in policy discussions at the state level is that smoking cessation for parents is tobacco prevention for kids. It reduces access. It also reduces modeling at home. A kid sees their parents smoke and, they say to themselves, well, it's a possibility for me too, right? So it's social sources, and it's stealing from your parents. The idea behind increasing the age to 21 was not a lot of 21-year-olds are hanging out with 13-year-olds, right? 18-year-olds, perhaps they were still in high school, they could totally give a pack of cigarettes to their 16-year-old friend. But it's increasing the age difference and the social distance between people who are legally allowed to purchase and people who we absolutely want to keep away from tobacco products.
Thank you. Members, any other questions?
Madam Chair.
Senator Titus.
Thank you, Madam Chair. First, thank you for being at the table. Great. I love that you're actually getting your students engaged in some of this public health issues. You actually put them out there. So kudos to you for doing that. Couple questions. Smoke shops. Did they go into any of the native smoke shops?
We did not include them in our sample because I am unclear as to whether or not they need to follow the tobacco 21 minimum age.
That'd be a great answer somewhere.
Great
Somebody
question.
has to
Yes.
have that
Right.
answer, whether
Right.
the smoke shops, because in my rural counties, that's where a lot of the purchases are done because of tax benefits. So we really do need to get some answers on that. I'm not sure who to ask, but I certainly think it's an important.
I can find out.
Thank you for that. The second thing is access to the scanners. It's easy for the big chains, the Walmarts, et cetera, to have those scanners.
Right.
Do these small mom and pop little shops have access to those scanners? And if so, what are the costs to do that?
That's a great question. I believe my colleague who will be presenting next can speak to that. She mentioned that the state has developed an app that mom and pops can use.
Good. Thank you for that. And finally, if I might, one more question, Madam Chair. We have RAN, Retail Association of Nevada. Have you co-partnered with them at all to educate their members on this process? And if so, has it worked? And I worry that, yes, they're big members, the Walmarts, et cetera, are part of that. But what about all these other small, how are we educating these other mom and pops to do these scanning?
Yeah, so this study is limited to observation. We're not trying to educate or change anyone's behavior. However, my colleague at the state who's coming up next, I think she can speak to that.
All right, I'll leave you off the hook, but
Great.
thank you for what you're doing.
Thank you.
Thank you. Thank you, Senator, for those questions. We'll ask legal to follow up on clarification relative to the authority on tribal lands and the tribal smoke shops. And so with that, we'll move on to the next presentations. And if you don't mind, we'll take them both together and then we'll take questions at the end. Okay? Thank you so much. Go ahead.
Hello, good afternoon, or yes, afternoon, Chair Brown May and members of the committee. Thank you for allowing us to present to the committee today. My name is Nicole Chacon, C-H-A-C-O-N, and I manage the Nevada Tobacco Control and Smoke-Free Coalition, along with Jennifer Atlas from the Government Relations Director of the American Cancer Society Cancer Action Network. We're going to talk to you today a little bit about our coalition's priorities for 2027, and we can answer some of those questions that were asked in the last presentation. So our mission, did that move? There we go. Okay. Our mission at the coalition is to improve the health of
the slides working. Oh,
you can. Okay. It's
We're
not showing on our screen, so. Okay, I'll just continue. Our mission is to improve the health of all Nevadans by advocating to eliminate exposure to secondhand smoke and vape emissions, to expand access to cessation, and to reduce commercial tobacco use. So our coalition's funded partners follow CDC's 4 tobacco control goals, which aim to reduce death and disease from tobacco use by preventing youth initiation, promoting adult and youth cessation, eliminating secondhand smoke exposure, and advancing health equity. We do this by supporting objectives like implementing evidence-based community-wide strategies, strengthening surveillance, and reducing disparities in tobacco-related illnesses. This is just a sample of many of our organizational members, which include local, regional, and national nonprofits, local and state governmental organizations, rural prevention and substance abuse coalitions, academia, etc.
So I'm going to just briefly touch on the first few policy priorities because that's not where the focus of our time is to be today. We really want to focus it in on the tobacco prevention and control funding piece. So when it comes to clean air, we want to close those loopholes in the Nevada Clean Indoor Air Act and establish comprehensive smoke-free laws. So nearly 20 years coming up on the passage of the Nevada Clean Indoor Air Act, which will be in December of this year, believe it or not, nearly 40% of our workforce in Nevada is still exposed to secondhand smoke daily in their workplace. And we believe that all workers deserve those same protections. When it comes to youth access, and this was referenced in the previous presentation, we would be addressing that through tobacco retail provisions. There's a number of ways to do that, but they all come down to increasing enforcement and accountability for tobacco retailers. One of the ways to do this is to conduct annual compliance checks. As of now, they're only required once every 3 years. And then when it comes to flavoring, we would want to prohibit the sale of all flavored tobacco products that are most popular among youth and other priority populations. We know nationally almost 90% of all youth who report using tobacco products use flavored tobacco products. And vulnerable communities report using flavored tobacco products at a much higher rate than other communities, with rates as high as 80% in the African American community when it comes to using menthol products. I also want to emphasize that this means no youth penalties for the purchase, use, and possession of tobacco products. This would be focused in on the retail level. So now we're going to talk about specifically our tobacco prevention and control funding. So there's a lot going on in the slide. I want you to focus on the right side first. This is the current state of the funding for Nevada for tobacco control and prevention programs. When we look at, these are 2024 annual figures. When we look at the estimated revenue that was brought in from cigarette tax, so that's specifically just combustible cigarettes, that's about $130.9 million. And then other tobacco product tax, so those are everything else. So cigarillos, with the exception of cigars, cigarillos, vapes, the nicotine pouches, smokeless tobacco, that's about $32.9 million. And then the Juul settlement funds brought in $14.6 million. I just want to note that $0 out of this, all of these funding, all of this revenue was allocated to tobacco control and prevention. The same year, Nevada received an estimated $36.5 million through the Tobacco Master Settlement Agreement funds, and about 3%, $1.1 million, was allocated to tobacco control and prevention. So when we look at all of these funds, the revenue that was brought in via tax and settlements, we're looking at over $214 million, and about 0.5% was allocated to tobacco control and prevention. So of that 1.1 million, where does that stand? So that's about 3% of what CDC recommends that a state of our size with our population be funded. They would recommend us to be at $30 million. We, of course, rank low, 46th in state funding when it comes to how we fund tobacco control and prevention programs in Nevada. Our cigarette tax rate currently stands at $1.80 per pack. That was last increased in 2015. The national average is about $2.05 per pack. And then that other tobacco product tax that we discussed earlier, that's 30% of the wholesale cost. And that figure has never been increased in Nevada. So I'm going to turn it over to Jen to talk a little bit more about our policy recommendations as a result.
Thank you so much. Good afternoon, Chair Brown-May and Vice Chair Doñate and members of the committee. My name is Jennifer Atlas, for the record, and I am from the American Cancer Society Cancer Action Network. And I'd like to walk you through the NTCSC's policy recommendation regarding funding for tobacco control and where that revenue could come from. As Nicole mentioned, the tax on cigarettes has not changed since 2015, and the tax on other tobacco products, OTP, such as vapes, e-cigarettes, pouches, has never been increased. Significantly increasing tobacco taxes and investing in tobacco prevention and cessation programs saves lives, reduces healthcare costs, and generates revenue. It's one of the most effective ways to prevent youth from starting to use tobacco and encourage those already addicted to quit. Our recommendation is to address the missed revenue opportunities and increase cigarette tax by $2 per pack, with a parallel tax on all other tobacco products at 50% of wholesale price to achieve the tax parity. So this increase would provide a projected revenue of over $72.6 million for the state. And it's important that all other tobacco products, including e-cigarettes, are taxed at 50% of wholesale to parallel that new cigarette tax in order to encourage people who use tobacco to quit rather than switching to lower taxed and lower cost alternatives. If all tobacco products are not taxed at that equivalent rate, Nevada can expect to see diminished positive outcomes for revenue and public health. These numbers are also important because big tobacco spends millions of dollars each year to market their addictive products. Without this significant tax increase, tobacco companies can use coupons, discounts, and price manipulations to offset any kind of smaller increase. Reducing smoking in Nevada would generate significant healthcare savings, including millions over the next 5 years, from fewer lung cancer cases, improved pregnancy outcomes, reduced heart attacks and strokes, as well as nearly $5 million in Medicaid savings. In the long term, declines in both adult and youth smoking could save the state over $238 million. These savings come alongside substantial improvements in public health. Looking ahead, we're expecting to see a few threats to public health. One of them is vape product directories, and these redirect state resources, and they don't have any proven benefit to state or public health. The other is a tiered tax structure for modified risk tobacco products, and it creates a separate lower tax for products marketed as less harmful. This is problematic because the FDA has not authorized these products as smoking cessation tools or proven them to be safer. Treating some tobacco products differently based on marketing claims is unnecessary and burdensome, and it effectively gives a tax break to products that still pose serious health risks. All tobacco products need to be taxed equally to protect public health and prevent misleading incentives. The relatively low price of tobacco products makes it too easy for youth to afford to start smoking and continue smoking. And current tobacco tax rates do little to defray the enormous societal cost smoking has on the economy. If we're serious about reducing the toll of preventable cancer and chronic disease in our state, a high impact tobacco tax increase such as this one would help us achieve that life-saving mission. We thank you for your time, and we are always available as a resource and to answer any questions you might have.
Thank you for your presentations. Members, questions? Senator Titus.
Thank you, Madam Chair. Thank you for the presentation. These sin taxes, as you said in your presentation, none of it really goes to tobacco prevention. So you are pushing for an increased tax on something that doesn't go to prevention. At the same time, perhaps at what level have you done any research on what level does the increased tax then increase the illegal market? Because at some point people say, we're not paying these taxes, it makes more sense for us to go buy it from somebody illegally. And so have you done that research on what states, at what point is that tipping part where it makes more sense to buy illegally, or again, these smoke shops that I think we really need to be engaged in because they are in every community. Washoe and Clark have smoke shops. And so are we just pushing our folks to those areas? And again, we're going to increase taxes, but where's the money to increase prevention? I was on decades ago, literally, I'm saying how old I am, when we first had the tobacco settlement. There was actually some funding there that was later stripped, and we were supposed to just use it for tobacco prevention programs. And it was something like 5% of, we were given an allotment and we could only spend the interest on that for programs for prevention and actually make an impact. If the tobacco funds were really doing in the settlement what they were supposed to do, we would totally stop people from smoking, and then we wouldn't even need, that's what these funds were supposed to do. That doesn't go there. And I'm worried this tax shouldn't be a benefit to the general fund of the state of Nevada. It should go to prevention. And so I'm really worried that just by taxing it more, we're really defeating the purpose. We're going to increase the illicit market. We're going to increase folks going to the smoke shop, and none of it goes to prevention. So help me see what you're thinking. If you're thinking that you're just going to tax it so high people aren't going to buy the product, then the state of Nevada doesn't have the income to the general fund, and it's also going to go to the illicit market. So kind of clarify that for me. Thank you.
As you prepare to respond to the senator, and I thank you, Senator, for those questions, understand, and if you could consider it from the point that she last raised, that this should not be considered a revenue producer, and that what we're trying to do is change behavior so that no one is purchasing tobacco. If you would just speak to it probably from that frame of mind.
Thank you. That's a great question, Nicole Chacon, for the record. So I'll try to tackle it all. And the second piece of raising that tobacco tax by a significant amount, it is one of the benefits is to drive down the rate. So that saves the state money in the long term, right? But also the second part of that is we do need some more dedicated and sustainable funding for tobacco prevention and control. Now, we aren't picky about where that money comes from. If it comes from that $2 tax increase and some of that is dedicated to tobacco prevention and control funding, that's fantastic. If we can reallocate more of the master settlement agreement money where a certain dollar amount more than what we get right now is dedicated to tobacco prevention and control, that's fine as well. We know that the Millennium Scholarship is funded under the MSA, and it's meeting some obstacles. So, maybe some of this money funds that. But yes, absolutely, the second part of that is that we do need to provide sustainable tobacco control funding. And to be honest, the partners and the people who do the work aren't picky where that comes from. There is a local lead agency model that's already set in statute that is a mechanism for how that money comes in through the master settlement agreement, and how that gets distributed to partners around the state. So that's already, that model's already in place. So again, as long as it's something that's sustainable and we're not coming back and fighting every year for more and more funding and taking a smaller piece of the pie, that's ultimately what we want. The second part of the question about illicit sales, there's a lot of evidence of what's happened in other states that initially there is a little bit that happens when you do increase the cigarette tax, but that ultimately the state still does gain more money than were they never to have increased the tobacco tax at all. So I'm happy to provide some citations and sources for you after this meeting if you'd like to see that. But it definitely has been studied in many other locations where they've increased the cigarette tax.
So thank you, Madam Chair, for the question, and thank you for that second response regarding the how high you tax something. And I'd love to see the studies from the other states, what that looked like, and what the actual numbers showed that it's still. Maybe is your goal to decrease purchase, and if so, then how did you increase income from that? So I think the increased tax really has a mixed bag of what it could potentially do, either drive down people buying it because now it's too expensive for the average 18-year-old to get, or it actually increased funding for programs. And so it's kind of a mixed bag of how this could happen or what the results would be. And I'd love to see other states results from other states. Thank you, and thank you, Madam Chair.
Thank you, Senator, for those questions. I appreciate that. Having come through a time earlier in my life, right, and much of the tobacco control and smoke, the progress that we've made relative to this public policy area, I'm curious to know, have you spent any time working with the retailers or public spaces that are still allowing smoking in their establishments? And if you have not, are you open to doing that as a way to move this policy priority forward?
Nicole Chacon for the record. Yeah, I know in the last 20 years since we passed the Nevada Clean Air Act, there's been a lot of work with the different health departments to work voluntarily with different businesses, with university campuses, with a lot of multi-unit housing. It's a big problem in multi-unit housing where there's shared ventilation. So there has been a lot of voluntary policy passage that's been done over those 20 years. I think if you're talking about casinos and things like that, that's been a harder climb. I mean, we did some local smoke-free work a while ago, and we tried to work with specific casino owners and things like that. That's a little bit more challenging. I think our partners are always willing to work with people and to provide them the information so that they know that that they can pass smoke-free policies on their own, that they don't have to be mandated to do so. But it is easier when it's a level playing field and everybody's doing the same thing, absolutely. And ideally, we want all of our workers to be protected. And like I said, nearly 40% of our workforce is still not protected almost 20 years later. So that's a huge consideration for our partners.
Thank you. And then one last question before we break for lunch. I do have a constituent who reaches out on a regular basis who lives in an apartment community and experiences adverse effects to his living conditions as a result of marijuana smoke. Has there been any work done around that particular issue that you're aware of that we can highlight here?
Nicole Chacon for the record. So our coalition doesn't deal too much with marijuana, but a lot of our funded partners that work in tobacco control also deal with marijuana. So I know, like the example I'm going to give is the Southern Nevada Health District has a huge multi-unit housing database, and I know some of our partners up north do as well, of communities that have made themselves voluntarily 100% smoke-free, and that includes cannabis, absolutely, because like I said, it is a huge issue with shared ventilation. So they advertise those businesses and those homes, I should say, so that people who are looking for it can go to that directory and find places where they might be. It's not always easy to move out of a situation if you're already in it, but there are a lot of, we can also offer legal resources from like the Public Health Law Center of ways to get out of a lease and things like that. But there actually is a huge number of apartment complexes in Southern Nevada specifically that offer 100% smoke-free, vape-free, cannabis-free living.
Thank you for that information. I appreciate you. Thank you all for being here. I don't see any additional questions at this time. Okay, thank you so much. Members, we are going to break for lunch. It is now 20 minutes till 1. Let's take a quick 30 minutes if you're okay. We'll come back at 1:10, and then we just have a couple of presentations left on the books. Thank you. We'll see you back here at 1:10. We'll stand in recess. Okay, let us come back from recess. We'll officially call this meeting back to order, and we are getting ready to move on to our next agenda item, which is agenda item number 8, presentation on gun violence, injury statistics, and public health focused policy recommendations. We have presenter Emily Walsh with she's the Law and Policy Advisor for the Center for Gun Violence Solutions at Johns Hopkins Bloomberg School of Public Health. And she joins us today virtually and is online. Thank you so much for being here, Ms. Walsh. You are welcome to begin your presentation whenever you're ready.
Thank you very much. I'm going to just quickly take a moment to share my screen. All right. And is that visible to folks?
Yes.
All right, thank you so much. Good afternoon, and thank you very much for the opportunity to present before this committee today. For the record, my name is Emily Walsh. I am the Law and Policy Advisor with the Johns Hopkins Center for Gun Violence Solutions, also an attorney. And I'm here today because gun violence is a public health crisis, but it is preventable. Last year, nearly 600 Nevadans lost their lives due to gun violence. And today I have the privilege of sharing with you 5 policy solutions and recommendations that will help save lives and reduce both the human and economic cost of gun violence in Nevada. So I'm going to begin with an overview of the public health approach to gun violence, an overview of the relevant data, both on the national scale and in the state, and also review our evidence-based policy recommendations, concluding with a brief overview of the legal landscape. First, I'd like to briefly introduce the center. So we are located within the Johns Hopkins Bloomberg School for Public Health, one of the top public health schools in the world. We are the only combined gun violence prevention research and advocacy center in the nation. So we employ highly experienced researchers, biostatisticians, faculty within the university, as well as public health trained advocates. So as a center, we engage with policymakers like yourselves at every level, as well as law enforcement, community partners, healthcare providers, and researchers across the country. We perform rigorous research, determine which solutions are backed by that evidence, and then advocate for their adoption at the state, local, and federal level. So as I mentioned, gun violence is not inevitable. It is a public health crisis, but it is preventable. So I'm going to start with an introduction to public health. What is public health? Generally, it helps prevent injury and illness at a whole in communities and across populations. So it's large-scale, evidence-based solutions to help people live longer and healthier lives. And why do we use a public health approach for gun violence? First, because gun violence is complicated. It's a multifaceted problem that takes many forms and requires many different solutions accordingly. You may have seen this example depicted as a Swiss cheese model, depicted here. So no single intervention alone is sufficient by itself, but if you stack enough solutions and interventions together, you're able to prevent the vast majority of gun deaths and injuries. The public health approach addresses the many forms that gun violence takes by focusing on both firearm access and the underlying factors that contribute to gun violence. This involves a comprehensive approach, like what's been used to tackle other public health crises in the US, from eradicating diseases to reducing injuries and deaths from smoking and car accidents. So take the car accident example. We take for granted today many of the myriad regulations and cultural expectations around driving, but it took a lot of public health research and advocacy to get to this point. This approach included funding studies, regulating manufacturers, requiring drivers to apply for and receive licenses, including training, with periodic renewals required before driving, registering cars, enacting speed limits, enforcing laws aimed at reckless driving, requiring drivers to wear seatbelts. It took all of these interventions at different levels to reduce the risks associated with car accidents. So what the public health approach has in common is identifying different opportunities for intervention at all levels and at all temporal stages. And these are evidence-based solutions that are driven by the data. So this is just a depiction of the public health interventions at different levels that occur in the gun violence context, with broad-based socioeconomic factors at the bottom, all the way to individual-based interventions at the top. And you can imagine this model employed in, for instance, the car accident example that I referenced above. So it takes all of these approaches at all these levels to effectively reduce gun violence. In this section, I'll be providing an overview of the categories of gun violence that we identify and some key data points, both around these types of gun violence in the US nationally and Nevada level statistics to help inform your policymaking. One of the reasons that gun violence requires a multifaceted approach is that there are different forms of gun violence that carry different risks and require different approaches to prevent. So the horror of mass shootings often captivates the headlines, and that fear lives in the heart of most Americans. But the gun violence crisis looks different in different places. Today, I'll be focusing on the subcategories that relate to the policy solutions that I'll be discussing. And I'll be using the latest available CDC data, unless otherwise specified, which is from 2024. And in 2024, 44,447 people died by firearms in the US. That's an average of 1 death every 12 minutes. And over half of those deaths were firearm suicides, which is what I will dive into first. So firearm suicide makes up the majority of gun deaths in the US. In 2024, 27,593 people lost their lives to firearm suicide, which is an average of 1 person every 19 minutes, and more than if you filled the T-Mobile Arena in Las Vegas. What's important to note is that guns are uniquely dangerous when it comes to suicide. So most suicide attempts overall do not result in death, but 90% of attempts that are committed using firearms do result in death. So it's a uniquely lethal method. Furthermore, 90% of people who survive a suicide attempt do not go on to die by suicide. Putting this together, this means that access to a firearm during a suicide attempt mostly means no second chances, and what may be a momentary crisis turns into a permanent and irrevocable decision. It also means that if we're able to put some time and space between a firearm and someone experiencing suicidality, there's a strong chance that their life can be saved. And this is borne out by the data. Access to a gun in the home increases the odds of suicide more than 3-fold. Most of the remaining gun deaths in the US are homicides. In 2024, this was a little over 15,000. Guns are also used in the large majority, nearly 80%, of homicides overall. Sadly, the gun homicide rate in the US is over 25 times higher than other industrialized countries, which is unsurprising, especially given that research shows that states with higher gun ownership rates consistently have higher gun homicide rates. But gun homicide also encompasses several subcategories that are worth discussing separately. The first is domestic violence. So the data behind the deadly intersection between guns and domestic violence is pretty staggering. Nearly 1/2 of all women murdered in the US are killed by a current or former intimate partner, and more than half of all intimate partner violence against women is committed using a gun. Nearly 4.5 million women have reported being threatened by a gun in the US, and nearly 1 million women have been shot or shot at by an intimate partner. Ultimately, women are 5 times more likely to be murdered when their abuser has access to a firearm. This is another space where, like with suicide, removing a gun during moments of crisis can save lives. The second subcategory of firearm homicide is one that we're tragically all too familiar with: mass shootings, largely defined as shootings in which 4 or more people are shot or killed. The annual number of mass shootings has doubled from 2013 to 2022, now with an average of 600 mass shootings per year in the US. States with weaker gun laws and more gun ownership tend to experience higher rates of mass shootings. And while mass shootings comprise of a small percentage of overall gun deaths every year, they occupy a large space in our public psyche due to the collective trauma and the fear that it could happen anywhere. So 1/3 of adults report not going to a place or an event due to fear that a mass shooting might take place. And one study found that Hispanic adults are twice as likely to report experiencing the stress that a mass shooting might take place often or constantly. Apart from firearm suicide and firearm homicide, there are also unintentional, or sometimes referred to as accidental, shootings. Often this happens when guns are not safely or securely stored. I'm sure you've seen tragic headlines recounting when a child or even a toddler gains access to an unsecured gun and unintentionally shoots themselves or a family member. So every 6 days, a child under the age of 10 is killed as a result of an unintentional shooting. And in 2024, there were 450 such deaths across all age groups. Finally, one often overlooked dimension of gun violence is non-fatal injuries, people who are shot and injured but do not die as a result. This is tens of thousands of Americans every year, between 80 to 100,000, more than 200 people each day, represented by this graphic here. Being shot has lifelong repercussions. It can mean lifelong physical injuries, psychological and emotional trauma, and economic burdens from medical costs, the need for new housing accommodations, issues with employment. So the repercussions occur long after the wound itself has healed. Before I dive into the most recent Nevada-specific statistics, I want to zoom out and situate Nevada among all the 50 states. So this chart shows the overall gun death rates for 2023 from high to low, with orange indicating gun suicide, light blue indicating gun homicide, and dark blue indicating other, for the most part unintentional shootings. And the dotted line indicates the national average of 14 deaths per 100,000 people. And this is where Nevada sits. It had the 12th highest gun death rate in 2023, or a little over 19 deaths per 100,000 people. So in 2024, 582 Nevadans lost their lives due to gun violence. To put that in perspective, that's the equivalent of around 3 to 4 large airplanes, and approximately 170 more people than died in car accidents in 2024 in the state, according to the Department of Public Safety. Of those 582 deaths, 170 were homicides and 402, or 69%, were suicides. 23 of these deaths were young people between the ages of 1 and 17. And gun violence was in fact the second leading cause of death among young people in Nevada in 2024. And while the devastating human toll alone is enough to spur action, it is also important to note that gun violence in Nevada carries a large economic toll. The estimate is approximately $6.3 billion per year, or $1,956 per taxpayer. Finally, we have not yet performed this analysis with the 2024 CDC data, but in 2023, there were at least 56 domestic violence-related homicides in Nevada, and 73% of those were committed using a firearm. So you can see at a glance that firearm suicide and homicide, particularly domestic violence-related, are pressing public health issues to address. To continue the overview of gun violence in Nevada, this chart shows the overall gun death rate broken down by type from 2015 to 2024. So guns were used in the majority of homicides. The overall gun death rate has increased 15% over that time. And guns were also used in the majority of homicides and suicides in the state in 2024. So guns were used in 77% of homicides overall and 59% of suicides overall. So firearm suicide makes up the majority of gun deaths in Nevada. In fact, Nevada has the 11th highest gun suicide rate in the country. As mentioned on the previous slide, guns were used in 59% of all suicide deaths in Nevada in 2024. And the overall gun suicide rate in Nevada actually increased 20% between 2015 and 2024, as you can see from the light blue line on this chart. We also have some demographic breakdowns that show that older men, particularly older white men, are particularly at risk of firearm suicide. So men in general were 5 times more likely to die by gun suicide in Nevada, and 45% of gun suicide deaths were people over the age of 45. And while white men over the age of 34 constitute approximately 15% of the population in Nevada, they accounted for 50% of all gun suicide deaths in 2024. So while gun suicide is prevalent across all demographics, it's particularly urgent among older white men and generally has a prevalence in more rural areas as well. So Nevada has also experienced a considerable number of gun homicides in 2024. The gun homicide rate, shown by the orange line, has increased 22% from 2015 to 2024. And as with suicide, men are nearly 5 times more likely to die by gun homicide than women. But unlike gun suicide, gun homicides trended younger, with young people between the ages of 15 to 34 making up about 45% of gun homicide deaths in the state. Firearm homicide also presents a different racial breakdown. So Black Nevadans were 5 times as likely to die by gun homicide compared to their white counterparts. And Black women in Nevada were in particular 3 times as likely to die by gun homicide than white women in Nevada between the years 2020 and 2024. I've shared a lot of data about the public health crisis of gun violence in the US and in Nevada specifically. And the good news is there are policy solutions that our researchers have determined that are backed by evidence to reduce the tragedies that I've discussed so far, particularly around reducing firearm homicides, suicides, and unintentional shootings. So these 5 policy areas are the top recommendations by the Center for Gun Violence Solutions, and I'll be discussing the basics of each and providing some brief comparisons to existing Nevada law. But to give a brief preview, these 5 areas are safe storage, which entails locking up firearms to prevent unauthorized access, firearm purchaser licensing laws, also referred to as permit to purchase, which requires individuals to apply for and obtain a permit prior to purchasing a firearm, firearm removal laws, which are mechanisms that temporarily remove firearms from individuals at heightened risk of suicide or violence against others, regulating public carry, so regulating how and where people can carry firearms in public, particularly in sensitive places, and community-based violence intervention programs, which are a variety of programs rooted in a public health approach that address individuals most at risk for gun violence. Our first policy recommendation surrounds safe storage. Safe storage laws are among the most well-studied and evaluated of all state gun laws and are backed by over 2 decades of research. Studies show that safe storage laws can prevent firearm suicide, homicide, unintentional deaths, and injuries. Safe storage laws also help prevent gun theft, which is a major source of guns that flow into the criminal market and are subsequently used in crimes. Safe storage laws fundamentally are based on a core tenet of injury prevention. And that principle is that separating at-risk individuals from the potential sources of injury saves lives. So these laws interrupt the pathway from exposure to harm. Surveys show that 54% of gun owners do not securely store all of their firearms. And this is important for many reasons, one of which is that an estimated 82% of youth suicides involve a gun belonging to a family member. And 76% of school shooters accessed the firearm that they used from their own home or that of a relative or friend. But by securely storing firearms, gun owners help prevent anyone from being able to access the firearm who should not be able to have access. That includes children, people who might be prohibited from owning guns themselves, or anyone else in the household who might be at risk of harming themselves or others. Storing firearms in a locked device also places barriers between a person's contemplation of suicide and access to those highly lethal means, as previously discussed. You can also see here there's broad support for safe storage laws, including a majority of gun owners. And one important point is that the storage options available today for guns are not your grandfather's lock boxes with a key and a padlock. There are affordable, quick access options, including biometric or fingerprint access, that allow for speedy access while still preventing unauthorized access, and even for the owner, requiring just one more step between someone's contemplation of suicide and access to that gun. Strong safe storage laws, which are laws associated with the greatest reduction in deaths and injuries across the spectrum, have the following components. First, a general requirement that guns are safely stored whenever they're not under the owner's direct control. And we take direct control generally to mean on one's person, actively in use, or around them near such that they could prevent someone from accessing it if someone were to come up. We recommend a hard-sided container to prevent folks from being able to access the firearm by cutting through the locked device. Having a locking mechanism that prevents anyone who doesn't have the key or the code or the fingerprint to be able to access it. For vehicles, we recommend affixing the container to somewhere within the vehicle so there's no smash and grab opportunities from thieves, and also keeping it out of plain sight because firearm theft from cars is a major and a rising problem in the US. We also recommend that dealers distribute materials and post signs at federally licensed firearm dealerships, establishing the recommendations and regulations around safe storage. And we suggest that states additionally collect data on the implementation of these laws to ensure that it's equitable and effective. In addition to the general requirement that guns are securely stored whenever they're not in use, it's also recommended to have additional penalties associated with children, access by children and prohibited persons if they're able to access the unsecured weapon. And these are often referred to as child access protection or CAP laws. So to briefly look at current Nevada law, currently Nevada has a child access prevention law only. I've included the citation here. On the good hand, Nevada does currently require dealers to distribute locking devices with the sale of each firearm. With that citation I've also currently included, which is a good thing. The current CAP law requires that persons are guilty of a misdemeanor if they negligently store or leave a firearm somewhere that they know a child might obtain it without authorization. Our recommendation is to expand the storage requirement to be a generalized requirement, so not just based on if you think a child might be in the vicinity, but just a general requirement across the board to make that guidance consistent for all gun owners to prevent any unauthorized access, not just if they think a child might be present. We also recommend a vehicle requirement and adding prohibited persons to the CAP law. So right now it just applies to children. The recommendation is that there are additional penalties if access is allowed by someone who is prohibited by law from acquiring a firearm. The second policy area is called Firearm Purchaser Licensing, or FPL, sometimes referred to as permit to purchase. This policy requires prospective gun owners to apply for and receive a permit before purchasing a gun. And this application process includes a few different things. The first is fingerprinting, which helps state law enforcement more accurately identify the applicant and screen out prohibited people who might not otherwise be flagged in the federal background check system. Fingerprinting also acts as a deterrent to potential straw purchasers and for purchasing guns for the purpose of being used in crimes, if the applicant knows that their fingerprints will be associated with the application. Laws requiring fingerprinting were associated with a 45% decrease in gun trafficking, interstate gun trafficking in states that had FPL laws, compared to states that had FPL laws without fingerprinting. We also recommend requiring proof of a firearm safety training course with a live fire component to ensure that people are able to load, unload, handle, fire, and store their firearms safely. The in-person step, which may constitute fingerprinting, helps deter people at risk of violence or self-harm. So people with dangerous or unlawful intent may be less likely to go through the process of obtaining a gun if they know they have to interact directly with law enforcement. This component is linked to a 9% reduction in firearm homicide rates in urban counties. And the comprehensive background check simply means running both the usual federal system and the state and local records that may not have been reported to the FBI, such as certain misdemeanors. Research shows that FPL laws are associated with reductions in all forms of gun violence, from homicides to suicides. It's another way to put time and space between a suicidal moment and a gun, as it's not uncommon for people in crisis to go out and buy a gun and use it that same day to end their lives. This is another way to avoid that. As one illustration of this policy's effectiveness, Connecticut's FPL law was associated with a 28% reduction in the state's firearm homicide rate and a 33% reduction in firearm suicides. Conversely, when Missouri repealed its FPL law, the state saw a 25% increase in firearm homicides and a 16% increase in firearm suicides in the years following its repeal. These laws are also associated with reductions in mass shootings and of shootings both of and by police officers. FPL laws have been associated with a 28% lower rate of shootings by police in particular. And as you can see here, surveys indicate broad support for FPL laws. And I'd like to draw your attention specifically to the gun owner support rate in states with and without FPL laws. And one possible extrapolation is that the law has worked well for gun owners in states that actually have it and has not been perceived as a barrier to lawful gun ownership. Comparing to current Nevada law, Nevada does not currently have a firearm purchaser licensing law, but I will note that the application process to obtain a concealed carry permit in the state currently has almost all of the key requirements. the application with the in-person component, fingerprinting, a firearm safety course, and an enhanced background check. So our recommendation here is adoption of firearm purchaser licensing law. The third key policy area is temporary removal. These are mechanisms to temporarily separate a person from their firearms during a period of heightened risk. Temporary removal mechanisms are critical because they allow for proactive, civil, non-criminal intervention before a tragedy can occur. And this occurs in two important contexts. The first is domestic violence. So as previously discussed, guns and domestic violence are a lethal combination. Women are 5 times more likely to be murdered when their abuser retains access to a gun. Domestic violence also had a role in mass shootings in 68.2% of the time from 2014 to 2019. That could mean either the individual had been previously convicted or involved in the justice system regarding domestic violence or committed an act of domestic violence prior to engaging in their mass shooting. The other area is threats of harm to oneself or others outside of the domestic violence context. So warning signs are often present when someone is at risk of harming themselves or others, and family and loved ones are often the first to know and to notice this. But even if they see troubling signs, there's often no other proactive measure that can be taken apart from institutionalization, which carries its own long-lasting side effects. So there are two main types of temporary firearm removal mechanisms. The first are domestic violence protection orders, DVPOs, and there's two types here. There's temporary and there's extended. Temporary requires one to demonstrate not just that domestic violence occurred or that there is a sufficient risk of domestic violence, but that immediate relief is required. For extended, they're longer term and after an opportunity for full notice and hearing. And then the second type of temporary removal mechanisms are referred to as extreme risk protection orders, which address serious risks for harming oneself or others outside of the domestic violence context. And I also want to just quickly note that these mechanisms have long been held by courts to comport with both the Second Amendment and due process protections guaranteed by the Constitution. I'd be glad to share resources to that effect as well. So current Nevada law and our recommendations. So Nevada actually has an extreme risk protection order law, referred to as a high risk protection order, or HRPO, which is great. Nevada, of course, does also have domestic violence protection order firearm removal mechanisms. However, there are opportunities for major improvements, especially remembering that states that have domestic violence protection order mechanisms that require firearm surrender were associated with a 12% reduction in intimate partner homicides. So currently, under Nevada's domestic violence protection order scheme, firearm purchase or acquisition is prohibited for people that are subject to extended orders, so this longer term type. But only purchase and acquisition is prohibited. So possession is not prohibited. So someone could retain access to the firearms they already have possession or control or custody of. They just can't go out and buy new ones. And currently, firearm surrender, firearm prohibitions are not available at all for temporary protective orders, which again is when the person has been able to establish that the risk is so high that there must be protection right away. So obviously very important to have firearms separated during that point. Surrender also is not required currently under either practice. Under Nevada's high-risk protection orders, there are temporary and extended orders available, which is great. One area to consider improvement is implementation. So in 2025, there were 19 orders issued. Our implementation experts did a comparison and found that the rate of usage is lower than other states with ERPO laws. So there's an opportunity for action there. We do host a national ERPO resource center with ERPO implementation experts that work across the country to provide trainings and resources to law enforcement, judicial officers, and other parties involved in the process, and we'd be happy to provide that expertise as needed. The fourth and second to last policy area is regulating public carry. So broadly, this means regulating how and where guns can be carried in public spaces, especially sensitive places with risks for violence. There are two different types of public carry. The first is concealed carry. So who is able to carry a loaded, concealed handgun and where? and the second is open carry, so who can carry visible firearms in public places and where. Given the current prevalence of public carry, both concealed and open, it's hard to imagine that this did not used to be the norm. But as you can see here from this graphic, concealed carry was actually extremely regulated back in 1980 and has vastly proliferated to where we are today. So the graphic to the left shows in green the states where you could not obtain a concealed carry permit, you could not carry a concealed firearm, and in blue was may issue, so generally folks would have to demonstrate a specific need for to concealed carry before being issued a permit. And as you can see on the right now, there's a lot of permitless concealed carry and otherwise shall issue. So public carry has proliferated greatly over the past 40 years. And carrying guns in public places poses risks to public safety in a few ways. The first and most obvious is that it allows confrontations to escalate to deadly violence more easily. So it makes interpersonal encounters turning deadly. It also creates opportunities for armed intimidation that has implications for our democracy, for instance, at polling places, government buildings, and demonstrations. And overall, we see that states that more strongly regulate public carry are associated with lower rates of gun crime across the board. So there are 3 actionable policies that address the risks associated with public carry. The first is requiring individuals to apply for and obtain a permit for all public carry to ensure that they're not dangerous and are trained on safely handling and firing the weapon. The second is prohibiting public carry in sensitive places. I've listed some places as examples, not exhaustively. We've also recently published a report on the intersection of alcohol and firearms, which has additional recommendations for states and localities, and I'd be happy to share that resource as well. Finally, our public policy guidance recommends, public carry policy guidance recommends repealing stand your ground laws, as they can lead to conflicts escalating into deadly force encounters, even when that person could have safely retreated and avoided a loss of life. These laws are associated with increases in gun violence as well. So current Nevada law, Nevada currently requires a permit for concealed carry, which is good. As I mentioned before, it includes fingerprinting, enhanced background check, firearm safety course, but a permit is not required for open carry. That would be an opportunity for improvement. Nevada also currently has a stand your ground law, and also currently has preemption statutes on the books, which relates also to sensitive places. So the preemption statute basically prevents municipalities and localities from enacting their own firearm safety laws. For instance, if they wanted to prohibit firearms at a city hall, they might be prevented from doing that because of this preemption statute. And in terms of sensitive places, Nevada currently largely prohibits carrying firearms in schools and daycares, which is good. However, it is allowed on the premises of public buildings, except where metal detectors or signs are posted at every public entrance. It is also currently allowed at polling places and places that serve alcohol. However, I will note that last year, I believe, a bill was passed but vetoed that would have prohibited carrying at polling places. So our recommendations on those lines are below. And the final policy recommendation relates to an area called community-based violence intervention programs. These programs use a public health approach by identifying individuals and neighborhoods at the highest risk for gun violence and address the underlying concerns and use targeted interventions to prevent violence between individuals. So to take a step back, community violence often consists of gun homicides and injuries that take place outside the home, so not in the domestic violence context, and between individuals or groups, so not mass shootings. It often takes place in neighborhoods that have been systematically neglected or disinvested, and disproportionately affects Black and Brown communities. Community-based violence intervention programs, or CVI for short, take a variety of different forms, which I've listed here. So violence interrupter programs employ and train credible members of the community, sometimes people who have been formerly involved with gun violence themselves, to interrupt cycles of violence and change the norms around using guns to solve conflicts. Hospital-based interventions use the same approach to prevent retaliatory violence and also connect people with social services to reduce risks for future violence. Other models, like focused deterrence, create partnerships between law enforcement and community partners to identify chronic violent offenders and prevent them from engaging in future violence. Behavioral programs would support, identify persons impacted by violence, and provide cognitive and behavioral interventions, often paired with services like job training and life coaching. And violence reduction councils bring together a variety of law enforcement and community stakeholders to analyze gun violence at the city or municipal level and identify gaps and opportunities for intervention. The good news is these programs work. CVI programs have been shown to significantly reduce gun violence. For instance, a Baltimore program based on the violence interrupter model was associated with an average 32% reduction in homicides and 23% reduction in non-fatal shootings. And a violence reduction council adopted in Milwaukee was associated with a whopping 52% reduction in gun homicides. We've recently come out with a toolkit that municipalities can use to start these violence reduction councils in their own localities, and we'd be happy to share that as well. And where lawmakers like yourselves come in is that sustainable funding for all of these programs is absolutely key. So these programs depend on hiring and training people who are uniquely positioned to credibly perform these interventions. And the programs require a buildup of trust in the community over time to succeed. So other states that have seen success with these programs have allocated funding for these programs during their budget cycles. Finally, I want to mention 3 other policy recommendations that are still impactful, if not among our top 5. The first is establishing an Office of Gun Violence Prevention. The Office of Gun Violence Prevention is a model that's been started to be adopted in other states across the country. It provides basically a clearinghouse for agencies to collaborate across the government to create sustained and effective strategies and approaches, to test implementation, see what works, collect the data, evaluate, really provide a coordinated response for greatest effectiveness. And I'll also note that I believe a bill that would have established this was passed, but also vetoed last year as well. Our second is a large capacity magazine ban. So prohibiting the manufacture, purchase, or possession of magazines that hold more than 10 rounds. Our estimate is that laws that ban LCMs are associated with a 49% lower rate of fatal mass shootings and also a 70% lower rate of individuals killed in mass shootings for states with LCM bans. And that's because it requires folks to reload and not continue shooting without stopping. And finally, lost and stolen guns. So encouraging or passing a law requiring folks to report if their firearms are stolen. This both encourages safe storage practices, helps law enforcement in tracing stolen firearms, which present a huge public safety risk, and also provides important data on gun thefts in the state and trafficking. And finally, I want to briefly touch on the legal landscape in which we operate with gun violence prevention policies. Importantly, all of our priority policies have been found to comport with the Second Amendment, having overwhelmingly withstood Second Amendment challenges. To provide a very brief overview of the 2 defining Second Amendment Supreme Court cases currently, the first is Bruin in 2022. The Supreme Court established the new governing standard for evaluating the constitutionality of modern firearms laws under the Second Amendment. And it struck down New York's May issue public carry regime, basically requiring folks to show a need in order to receive a permit. And the new holding, the test for comporting with the Second Amendment, is whether the law is sufficiently analogous to a historical law regulating firearm use. So it doesn't require it to be identical, but similar in purpose and effect. And courts have interpreted this often as standards that operate to ensure that only law-abiding, responsible citizens are carrying firearms. And the second is U.S. v. Rahimi, in which the Supreme Court in 2024 upheld a federal statute prohibiting people that are subject to domestic violence protection orders, final orders from possessing firearms. And here was when the Supreme Court first really took the Bruin standard and held that temporarily disarming someone who is subject to one of these orders is consistent with the Second Amendment for the public safety concerns noted. And that is the conclusion of my presentation. I welcome your questions, and I would also be pleased to follow up with any additional resources.
Thank you very much, Ms. Walsh. We appreciate you being here and the detail provided in your presentation. Members, any questions? Thank you. Okay, seeing no questions.
Sorry, I do have one. I was waiting.
Senator Titus?
I was waiting my turn. Thank you. So thank you for the presentation. I am a very proud CCW holder, very absolutely believe in training and responsibility as a gun holder, and it is my responsibility to make sure that the guns that we have are out of reach of any of our grandchildren, and that comes with being a responsible gun owner. Having said that, however, I have a couple questions for you. In the state of Nevada, do you have any documentation of conflicts that occur because somebody we have an open carry law here in our state. Anybody, and especially my rural district, people carry guns all the time on their hip. And do you have any documentation where that actually increased a confrontation?
I don't have that data offhand. I'd be happy to look into it and see if our researchers have anything to that effect.
Right, great. I'd really appreciate that you sharing, and I'm sure the chair would like to see any of that. And do you have any of the, in our state, the Sheriffs and Chiefs Association sets the criteria and the training regarding our CCWs. And then we have reciprocity between, say, 20-some states because of that training. Does that differ? Does the training in our state, how is that different than the application to, as you mentioned, that you have to have a permit to even purchase any gun? And are you looking at long arms or are you looking at handguns? Exactly, where's the breakdown there?
Yeah, happy to address both questions. So I did a bit of digging prior to this, and so in the statute itself, the requirements for a concealed carry permit requires a firearm safety course, but the only difference between what that is and what we require, or what we recommend requiring, is that it doesn't specify in statute the live fire requirement. However, as you mentioned, and I'm not going to get this, the exact name right, but the chiefs of police, the agency responsible for promulgating those standards does require it to be live fire training, so that does comply with what we require. So to address your question overall, it does. I don't believe there are any differences beyond requiring live fire training in statute between what is currently required for a concealed carry permit and what would be required for a firearm purchase or licensing permit. And would you kindly remind me of your second question?
Well, I have a lot. I just wondering about, you've made a lot of comments about we should do this, but I'm not sure you have the supporting data to show the outcomes if we do that. I think Nevada, again, it's the sheriffs and chiefs, by the way, who set the regulations on, and they've been very good about making sure that we hold folks to a standard, and we don't just accept every other state. So, I mean, there's a push for everybody to have a concealed carry. But again, I'd like to see there's documentation that you're competent enough to use your firearms. And I'm just wondering if you have the data to show that this increased requirement for purchase in the states, and I'd like to know the states that do have those versus the states that do not have those. And maybe you could send that to the group. This is, we can do all of this offline. Next question, if I might, Madam Chair. I'm curious about if you follow the data of those who have a CCW that have stopped violence in certain situations, like an armed robbery. Do you follow any data that somebody that had the CCW was able to protect themselves or stopped a crime or any of the things that we all carry our CCWs for? Do you follow any of those outcomes?
Ms. Before Ms. Walsh, I'm sorry, 1 second, if you don't mind, before you answer. Thank you, Senator Titus, sincerely for the questions. I want to stay focused on the public health issues around guns and gun death. That's actually the reason that I invited Ms. Walsh to come and do this presentation. It's less about concealed carry permitting and what we have now, and more about addressing mental health issues that are resulting in suicide and violence on our roadways. There have been a number of incidents, one in particular that I'm aware of here in Southern Nevada, where a gun was used on a a highway and a young person lost their life. As we're seeing escalations in mental health concerns that and guns are being used or have been used, and at least that one incident, I thought it was important that we as an interim committee look at the public health effects. And I'd like to go on the record, Senator, as well, by stating that I also own a legal handgun and have been trained in how to use it with police officers, and my son is a police officer and does also carry a gun and has a lockbox and does all the things. I want us to be able to ensure that those people who do carry guns also have the mental health supports that they so need, in that they are experiencing situations throughout our community that are often high stress. And sometimes we're missing that in the mental health crisis. And unfortunately, we are losing them to suicide by gun. And so that was really the impetus for this presentation. And so I'm curious to know if we could just stay with the health effects and not debate a concealed carry permit here. I just was curious to know what the recommendations were from a public health perspective. And I would very much welcome all of the detail and the data relative to that. With that, Ms. Walsh, you're welcome to answer the senator's question.
Sure. Thank you very much, Senator, and thank you, Assemblywoman. I don't have that data on hand myself. I'd have to check with my colleagues who perform the research and the data analysis, but I'm happy to look into that and get back to you.
Yeah, and with all due respect, Madam Chair, thank you for your comments, but my purpose for bringing that up is I think sometimes it's easy to identify that guns are the problem and because we have X access to them. And I want to make sure, and you made it in your comment, which I really appreciate, it's the mental health aspects of communities. And the one thing that I appreciate you bringing forward is the whole community violence intervention. And I think that is something that we should really be focusing on, is the mental health overall of our society, behavioral health, and what John Hopkins has seen as an overall global thing about community violence. Guns are just the easy access, no question about it. They're fatal, they're deadly, they're quicker than a knife, quicker than running into you with a car, etc. They're there. But the real problem is the mental health of the communities themselves, and how we as a society are reacting to that. And I want to make sure we stay that global focus on the overall well-being of our citizens. And again, it's easy to narrow down on guns, but I want to make sure it's more of a global response to violence in general. So thank you, and thank you for your being here.
Thank you.
Thank you. Members, any other questions? Thank you. Thank you, Ms. Walsh. If you don't mind, it would be great if you would follow up relative to some of the detail and the data that you discussed in your presentation so that this committee has an opportunity to follow up with you. Thank you so much for being here. Thank you. Members, that leads us to the next item on our agenda. Overview of the Nevada Heat Lab and data pertaining to the use of cooling stations in Southern Nevada. And we will welcome representatives from Desert Research Institute to come forward and do their presentation. Welcome. Please state and spell your name for the record, and you may begin whenever you're ready.
Thank you, Madam Chair and Committee, for your time this afternoon. My name is Ariel Chenard. Last name is spelled C-H-O-I-N-A-R-D. And I am with the Desert Research Institute and the lead for the Nevada Heat Lab, for the record. So the Nevada Heat Lab is hosted at the Desert Research Institute. It is part of CNAP, which is the California Nevada Applications Program, which is funded through the NOAA RESA program, and that is housed in the Climate Center group at DRI. My team consists of Dr. Tamara Wall, our PI, Dr. Tom Albright, who is with UNR, Dr. Emma Bloomfield at UNLV, Dr. David Almanza here to my right, Kyan Engel, and myself, Ariel Chenard. We center the co-production of heat adaptation and resilience strategies with the people and the communities that are most impacted by heat. That means we center frontline communities so that we can better leverage local knowledge to develop and promote equitable and implementable heat adaptation approaches.
Our project, the Nevada Heat Lab, fills an existing gap in Southern Nevada. So prior to the creation of our project, there was no one entity that owned all of the work around extreme heat. So we provide collaboration, coordination, we elevate the voices of those most impacted by heat, and we are also researchers. So we provide high quality information to decision makers who need it. Why heat resilience? Heat is our deadliest natural hazard here in Nevada. It is the deadliest natural hazard in the United States and across the world. In 2024, there were a record 527 heat-related deaths in Clark County. Right now in 2025, it looks to be around somewhere between 260 and 280 deaths. Heat mortality is a lagging indicator, and it's dependent on reporting, case processing by the coroner's office, and medical coding. So, but another good measure for how much heat is impacting our communities is to take a look at the emergency department visits, both in 2024 and 2025. Our climate projections show that we will be expecting 20 to 18 days above 105 by 2035, between 46 to 32 days over 105 by 2055. However, nobody here has probably forgotten summer 2024 at this point. We had a record 112 days above 100 degrees, 74 above 105, and I'll let you guys read the rest of the numbers yourselves. It was a truly record-breaking summer, but we can expect more summers like that in the future. What we always like to say about heat is that here in Southern Nevada, everybody's exposed to extreme heat, but that experience is not equal. So how you experience heat very much depends on who you are, where you live, what you do for a living, whether or not you're experiencing poverty or homelessness. And heat here in Southern Nevada in particular can act as a chronic stressor or an acute shock. Our heat seasons are long, the heat is extreme, and that is a chronic stressor for many people in their day-to-day lives. Heat can act as an acute shock, like it did that week of July 7th in 2024 when we broke our record heat, our standing heat record with 120 degrees. And the other challenging thing about heat is that we often have to talk about heat and. So heat and access to affordable housing, or heat and dependence on public transportation. So here in Southern Nevada, because we are so exposed and because this is a regular occurrence every single year, heat is very much a systemic issue. So when you talk about heat, you end up talking about drought. You end up talking about food insecurity. You end up talking about health disparities. So heat is very much a systemic issue for us. We also have what we call heat vulnerable and heat burdened populations. So there are folks who, just by virtue of maybe having workplace exposure to heat or chronic conditions or other circumstances that make them more physically vulnerable to our extreme temperatures. And then we also have people who are heat burdened. So those are houses that spend a disproportionately large amount of their income on cooling their homes during the summer. Las Vegas is home to the worst urban heat island effect in the nation. Back in summer 2022, RTC worked with NIHIS and Kappa Strategies to do an urban heat island mapping campaign. And we found that our hottest neighborhoods are 11 degrees hotter than our coolest neighborhoods. So imagine what that would be like on a day that is 120 degrees. We also do a lot of public and community engagement. We held the first community listening sessions on extreme heat in neighborhoods that are the urban heat island neighborhoods. And what we found from those listening sessions was that when you ask community who should own heat, they will say we should all own heat, which is a very different sort of perspective from where our project grew out of. And that also establishes a space for these community members to articulate their needs and priorities for heat response and adaptation. And these are communities that were not previously a meaningful part of those discussions previously. And we also have the heat working group. So I started that in summer 2023 with about 8 people, and it has now grown to over 100 members. Although we are not emergency managers, we are researchers. We do hold heat response calls when the National Weather Service issues an extreme heat warning. So we open that information and resource sharing space for all the different practitioners who are involved in heat response. And then we also do after action calls. And that helps folks prioritize actions, share information, and share resources. We are also very engaged on local and state levels with planning initiatives. So the Nevada Heat Lab sits on the Southern Nevada Strong Steering Committee. We've participated in the Northern Nevada Heat Summit. We have upcoming work with RTC on a regional heat response plan. We worked very closely with Clark County Social Services on their cooling station usage study. And we are also working on tree canopy modeling and research. So like I said, in these community listening sessions, we heard from community that we should all own heat. And we should be a space that can make recommendations and encourage change around heat adaptation, resilience, and response. We also heard a lot about utility cost trade-offs. So most impacted communities articulated a need for programs to offset the cost of utilities, incentivizing landlords to weatherize, repair AC, and plant trees without increasing rent or displacement. There's a need for hands-on help in neighborhoods, multilingual, culturally relevant heat health information and messaging, shade equity. And we also learned that unhoused folks are the most likely to seek resources, whereas housed folks are the most likely to not seek cooling resources, even if their home is not at a safe and livable temperature. And I will now hand it over to Dr. David Almanza to talk through the cooling stations research.
Madam Chair, for the record, David Almanza, that's spelled A-L-M-A-N-Z-A, Desert Research Institute, Nevada Heat Lab. I am responsible for designing and leading the cooling station study of summer 2025. So the activation of cooling stations is Nevada's only official response to its deadliest threat of extreme heat. Cooling stations are public spaces where anyone can enter to cool off and shelter from the heat free of charge. These are spaces like libraries and recreational centers that operate regardless of activation. So not much actually changes when they're activated aside from increased water distribution and signage, and that was starting last year. This response functions on a volunteer basis, so a location will sign up to be listed on the county website to be listed as a cooling station where people can go. This response remains largely unfunded with no significant pool of money designated for it. And to the best of our knowledge, our study is the first and only evaluation of this resource so far. So we designed this study with the goal of understanding how this resource is used, the challenges and barriers people are experiencing, and just their general experiences with extreme heat. We collected paper surveys from people visiting cooling stations all throughout last summer. We collected a total of 439 surveys in both urban and rural locations, both in English and Spanish. And we managed to visit 37 out of the 42 cooling stations. The main finding that I want to highlight before I go on is that we found that nearly 50% of respondents were unaware of the existence of cooling stations as a resource, even though they were at cooling stations when polled. So even though people were at the cooling stations themselves, they reported not knowing that that was a resource that was available. And even when asked more directly, they reported never having visited a cooling station. So for the purposes of our study, we decided to focus our analysis on the 50% of people who had prior knowledge of cooling stations in order to understand how this is functioning as a cooling resource. Out of our sample, 68% of people reported feeling their health is at risk due to heat. 40% of people reported their home is too hot. 32% roughly reported struggling to pay their energy bills over the summer, and 43% of people reported having an unstable place to live or not having a stable place to live. The greatest barriers reported were awareness and transportation, with mainly not knowing where cooling stations are located as the #1 barrier for visiting a cooling station when they wanted to. And when asked how often people visit cooling stations, the most reported answer was 4 times a week or more. So that suggests that this isn't just occasionally used, but people are relying on this resource. In conclusion, we do have a few recommendations based off this data. We would suggest improving awareness and visibility, expanding access through extended hours and transportation, also formalizing cross-agency coordination through more structured governance structures, strengthen capacity for facilities, staff, and on-site resources, and continuing to use empirical evidence to guide future planning. In conclusion, all of our findings, not just the ones presented here, will be released in a report to the public in the following weeks. We are, as Ariel mentioned earlier, currently working with Clark County Social Services, who have expressed an interest in conducting a similar type of study for this upcoming summer. I'm happy to answer any questions, but in the meantime, I will pass it back to Ariel. Thank you.
Thank you, David. Ariel Chenard for the record with DRI. One of the things I mentioned earlier were challenges around shade. And access to shade is very important here in our really hot environment. Being in the shade can reduce the perceived temperature by sometimes more than 20 degrees, up to like 30 or 40 degrees. And the conversation around shade has largely focused on trees and the expansion of urban tree canopy. And while trees are a wonderful tool in our toolbox for mitigating both the urban heat island effect and the public health implications of our extremely hot summers, scale is very important when it comes to talking about the cooling benefits of trees. So one tree is very effective at cooling people in a park. On a neighborhood scale, we can help to reduce extreme heat exposure. But the tough news is that trees will never fully cool Las Vegas. The amount of trees that would take is somewhat out of our reach. And we also already have areas that are, gosh, they have what, 5% tree canopy. So some of our neighborhoods are very, very under treed. And it does tend towards the west side of the valley has more trees than the east side of the valley. And that's partly just a function of elevation and changes in altitude, but also in socioeconomic characteristics as well. So we can maximize the benefits of trees by planting the right tree in the right place where it is most needed. But trees are effective at cooling people, not the city. We also do a whole lot of media coverage. And these are some of our greatest hits. So if you've heard of us before, it might have been one of those places. And I do want to talk through just for a moment about our next steps and our outstanding questions. So right now, we have an understanding of some of the heat health impacts. So morbidity and mortality is related to heat. But we don't have a great idea of is what that means in healthcare dollars, what that means economically for our workplace, for employers. There are so many economic implications to heat impacts that haven't been unpacked yet. So we are working on doing that this summer, at least the initial steps. We also need to work more on heat health communication. Around 260 deaths in a relatively mild summer points to a need for better heat health messaging. Especially knowing that it is mostly men of working age who are disproportionately dying because of heat. Is there something about heat health messaging that isn't getting through to the audiences who need it most? We need a better understanding of heat impacts in our rural and our tribal communities. We have good data on what's happening here in the metro area. But once we get further afield, we don't have a great idea of how people are experiencing heat or how heat is changing their day-to-day lives or impacting their pocketbooks and their health. We are always preparing for the next heat season. So right now we are in
deep prep mode for summer 2026. We will be exploring heat and air quality connections going forward. And we are participating in the RTC Heat Summit in April 2026. And we will be holding a tabletop extreme heat scenario exercise in May. And with that, thank you very much to the committee. And if there are any questions, we are all ears.
Thank you for being here. Thank you for the subject matter and the data research. Members, questions? Senator Titus.
Thank you, Madam Chair. I appreciate the opportunity. So first and foremost, thank you very much for your presentation. I think it's critically important that we hear these numbers, and thank you for including on your one slide why heat resilience, and you have that documentation. The record shattered on July 7th. Death Valley was 129 degrees, Las Vegas 120 degrees, because I think there's a misconception that just urban sprawl and development, pavement, housing, etc., is what increases the heat, say, in Las Vegas. But in reality, the heat really is increasing across the spectrum of our environment. So thank you for including that. What I didn't hear you say in your presentation, and a huge concern, is the power outages that are happening across especially southern Nevada. In rural Nevada, we're used to power outages. The first storm or wind that happens, our power goes off, and we live with that, and we have backups, etc. But when the power goes out in Las Vegas, like it did 2 nights ago, my concern is it goes beyond your wealth, whether you're living on a street or a fancy home, your AC goes out. These misters don't work. Is there any backup along that line when the power goes out in Las Vegas? Where do folks go to help survive that heat? Because is there any is it part of your EMS program, your emergency managers? Is there some coordinated effort through the public health departments or whomever to give folks, regardless of where they are, some place to go to mitigate the heat?
Madam Chair, through you to Senator Titus, that is such an excellent question. Oh, Ariel Chenard for the record. I will remember that next time. We worry about power outages as well. And one of the challenges is our only response to extreme heat here in Clark County is the activation of these cooling stations that Dr. Almanza talked about just a few minutes ago. To my knowledge, none of those spaces have backup power. So there is a potential that if there were power interruption during our heat season, God forbid, during an extreme heat warning, we would be directing people to a resource that may not be functioning. Now, I do know that summer of last year, in June, there were some storms that moved through the metro area. And although it was not exceptionally hot, it is still hot here, the Red Cross worked with Clark County Office of Emergency Management to provide shelter and cooling for people who were displaced. And that was the first time there have been any overnight cooling resources in southern Nevada. And that's a huge challenge for folks. Like if your power goes out and it's 10 p.m., but it's the middle of July, you know full well it could still be 110 degrees out, right? Just because the sun is down doesn't mean it's cool out. Cooling stations work on business hours. So if your nearest cooling station closes at 8 p.m. and your AC goes out at 10, where's the resource? And I think one of the challenges is, because we have that heat working group and we have a really wonderful network of partners, none of them are adequately resourced to provide something like that.
Follow up, if I might, Madam Chair. So thank you for that, because that's a concern, and that's one of the things that I think you're missing. It's one of those low-hanging fruits that, okay, there's a problem here that we could actually solve and somewhat mitigate and get in front of through the Office of Emergency Management, where you apply for funding for backup generators at every single cooling station you have in southern Nevada so that they work 24/7. And those are the kind of asks and interventions that I think are reasonable and obtained, since we're not really necessarily going to change what this heat is doing, regardless of who you blame for it. It's happening, and I think we need to really jump in on some of the stuff immediately, because the power outages are happening. So thank you, Madam Chair, and thank you for being here.
Thank you, Senator. I appreciate that. I do also want to go on the record as stating that there is a very robust emergency management and planning divisions that work here and throughout our state. And while we're talking about heat mitigation, I think emergency responses and emergency management in certain situations might just be a little bit out of the scope of what this presentation was intended to do. I can tell you that the organization I work for during the day has a generator and emergency provisions to be able to house people in emergency situations. And so I know that Clark County does have that available, and there are a number of organizations around the Las Vegas Valley that do that. So should we end up in a crisis situation. Senator, I also don't know where you are staying in Southern Nevada that perhaps lost power, so maybe we could work on that too. Members, any other questions? Seeing none, thank you so much. Thank you for your presentation. I do appreciate you being here. That leads us to the last presentation on our agenda today. And we are going to review barriers for pharmacists to provide patient care in Nevada. We have a number of presenters, from what I understand, that are here today, and a number of folks here in Southern Nevada who have been here for this presentation. So I welcome you to the table. Please introduce yourselves, state and spell your name for the record. You may begin whenever you're ready.
Good afternoon. My name is Evan Williams. I am a professor at Roseman University. I've been a licensed pharmacist in Nevada for the last 10 years or so. I practice clinically at Valley Hospital Medical Center here in Las Vegas, and I'm also a reservist with the Commission Corps of the United States Public Health Service. And I'm here to talk a little bit about some of the legislative barriers that we've encountered in pharmacy practice here in the state of Nevada. So it'll come to no surprise to anybody here that there's a limited access to good primary care provision here in Nevada. Nevada ranks about 48 for primary care physicians per 100,000 residents, which is the third worst in the nation. And we would need somewhere in the neighborhood of 2,300 more physicians to meet the current national average. One of the proposed solutions here would be to try to leverage the pharmacists who are already highly qualified healthcare providers to help meet some of this gap. And we're here to kind of show today that pharmacists possess the training and expertise needed to help bridge that care gap based off their education, clinical training, additional training that they often are pursuing as well, and just their general skill set. I've been involved in pharmacy education as a faculty member for about the last 15 years. And I can attest to kind of the rigor and the quality of pharmacy training. The entry-level degree to practice as a pharmacist in the United States is a professional doctorate degree, the Doctor of Pharmacy degree. And then licensure at the state level requires graduation from an accredited university, an accredited program, a PharmD program, and then passage of a national licensure examination. In the didactic coursework, we are covering things including pharmacology, pathophysiology, pharmacotherapeutics, and a lot of our didactic courses. And then there's going to be skills-based courses related to patient assessment and the provision of patient care. This culminates with over 2,000 clinical practice hours that are required, largely conducted in the last year of pharmacy training. And once graduation has happened and licensure has occurred, many pharmacists choose to pursue residency post-licensure or fellowship to gain additional clinical expertise, and particularly within a specialty area. Pharmacy practice these days is rooted in evidence-based medicine and clinical guideline-directed care as we determine what's best to meet the needs of our patients. And this is encapsulated in something called the pharmacist patient care process, which is something that our academics try to follow here. Up front, you can kind of see that the collection of information and assessment of that data that's been collected includes interviewing the patient, gathering and conducting a quick reconciliation between the medications that the patient's on and the disease states they have, and checking and reviewing laboratory values to make sure that everything is safe and effective. Once a plan has been created and implemented for that patient, all of this is going to be documented. It might include referral to other providers, and there's going to be follow-up, which will also include the review of laboratory values to ensure that the proper amount of care is being provided and if any escalation is needed. The current administrator for the Center for Medicare and Medicaid Services has been on record stating that pharmacists didn't go to pharmacy school to dispense pills and that they're underutilized in the current healthcare landscape to try to help address these gaps in primary care. Generally, pharmacy has been regulated as a dispensing type of profession here, kind of focusing on that drug product, and the reimbursements process has been related to that dispensing function. But the training really encapsulates much more of clinical service provision and patient care provision. And that's going to require a slightly different model in order to be able to be fully embraced. There is considerable data supporting the use of pharmacists to provide clinical services. And this has been happening and gathering for decades. As far back as 2010, we have a meta-analysis that in 2010 could gather nearly 300 studies to come out and show that pharmacists provided direct patient care across various disease states, healthcare settings, has been proven to be a safe and effective solution to help improve the provision of healthcare in the United States. More recently, researchers in 2020 concluded that on the basis of all of the evidence that they reviewed, every dollar spent in pharmacist-provided care returns $4 back to the health system due to improved medication adherence, due to reducing emergency room visits and unnecessary use of the healthcare system, and improvement in disease state control through making sure we're hitting our quality measures and things like this. Nominally nonpartisan public policy groups have also come to this conclusion, reviewing all of these data, kind of concluding here that full practice authority, when it has been given to pharmacists and we are reviewing that in the data, results in a proven, safe, and effective evidence-based solution to helping address the primary care shortage that we're experiencing here, especially in Nevada. Here in Nevada, pharmacists already do a lot of these things and have been doing this for a long time. Within all our hospital systems, there's generally going to be protocols in place for pharmacists to help manage this care. That can be from antibiotic management to pain management, parenteral nutrition provision and adjustment. And those have been happening since the 1960s. As a federal pharmacist, I personally have had prescribing privileges back with VA and in the Indian Health Services. And this has been established for a very long time. In 1997, so nearly 30 years ago, nearly 2/3 of VA medical centers had pharmacists who had prescriptive authority. And a couple of decades before that, that had been well established within the Indian Health Service. In the PrEP Act, pharmacists were able to use test and treat using CLIA-waived tests, but that has a sunset date of December 2029. In Nevada, since 2011, pharmacists have been able to enter into collaborative practice agreements with other healthcare professionals to help provide care. And there's been other recently passed legislation, including things like hormonal contraception provision, HIV prevention, opioid use disorder treatments that have been passed in legislation. But there are some issues in fully implementing that here due to kind of the bright line regulatory model that Nevada uses to regulate pharmacy practice. Oftentimes people are kind of concerned, like, is this a safe thing to do? And again, the evidence overwhelmingly reports that this is safe and effective. Remember, pharmacists are very highly trained to provide evidence-based medicine to guide direct patient care. Any pharmacist that's practicing within a particular area, just like any other clinician, is going to gain clinical experience and develop expertise within that setting that they're practicing in. Employers are going to be another safeguard on that by establishing their own policies and protocols that are going to protect patient safety. And this is not done in a silo. When a physician needs something that's outside of their scope of expertise, they will provide a referral to maybe an endocrinologist or an oncologist or something like that if they are not that specialty. Pharmacists are going to do the same things. There's a particular scope that pharmacists know, and like any other professional, if something falls outside of that scope, we know where to refer those people to. So it's going to create a better habitat for providing patient care within the state. Nevada would be far from the first state to adopt anything like this. In other states, and again within the federal government, where these advanced pharmacist practice scope has been adopted, they've seen improvements in both patient safety and optimized medication use. Within Nevada, there are definitely still barriers here that we're going to highlight, and I'm going to turn this section over to Dr. Zach Roscoe to cover this next section.
Thank you. For the record, my name is Zachary Roscoe. That's R-O-S-K-O. I am currently the president of the Nevada Pharmacy Alliance, and I'm a licensed pharmacist in Nevada. As Evan already mentioned, pharmacists can and do provide a wide range of services in Nevada and throughout the country. Despite this, patient access to these services that are within a pharmacist's training, education, and scope remains drastically limited by a number of regulatory barriers. It is specifically those barriers that we hope to address and remove to allow patient access. The first barrier I'm going to discuss here is with laboratory testing. Many pharmacist-provided non-dispensing services require the ability to order, interpret, or perform laboratory tests. Presently in Nevada, pharmacists can offer to assist patients with selecting or performing over-the-counter tests that are often CLIA waived. We can collect samples by finger stick, oral, or nasal swabs. And we can order and perform lab tests if we're working under a collaborative practice agreement with another provider, or if the test directly relates to HIV prevention. This is an autonomous authority that we presently have. And we have some ability to bill for these services, specifically HIV testing and HIV prevention-related tests can be billed to Nevada Medicaid by pharmacists. And we can work with commercial insurers to establish agreements to have reimbursement for tests. But there's still quite a few barriers. We cannot directly bill Medicaid and be reimbursed for the broad spectrum of laboratory tests we need to perform or are performing for patients. We cannot order or perform laboratory tests independently beyond those related to HIV prevention services. And there are many scenarios in which a pharmacist would need to initiate a laboratory test or could improve a patient's care or delay harm or prevent harm if we could order in situations where we don't have a collaborative practice agreement. We also cannot serve as laboratory directors specifically for waived laboratories, for CLIA waived laboratories. And tests are defined as CLIA waived when they are simple tests that have limited risk of incorrect results. Presently, there are a select number of providers who are expressly called out in Nevada law who can be laboratory directors of these exempt labs. That includes physicians and NPs, as you would expect, but also chiropractors. These are often tests patients can buy and perform themselves, yet we cannot assist. The second barrier is in administering medications. Pharmacists are trained to provide medication administration, to teach patients and other providers how to administer medications. And granted, we do this pretty widely throughout Nevada. We administer immunizations, we administer long-acting injectable agents such as antipsychotics or medications for substance use disorder, but we can only do this within the confines of a pharmacy with present statutory language. The authority to administer medications is tied in the definition of dispensing, and this language limits us and pharmacists who are practicing in non-pharmacy settings, such as working with a care team of physicians and other providers in a clinic. The third barrier here is prescribing and adjusting medications. And as you heard, there are some authorities we have where we can independently prescribe medications, to prevent HIV, to treat opioid use disorder, dispensing birth control. However, other situations where a pharmacist might need to adjust or prescribe a medication, we can only do so under the confines of a collaborative practice agreement. And it's not truly pharmacist prescribing. This is a pharmacist issuing a prescription under the name of the supervising physician. This is the logistics of this create a shared liability for those prescriptions and also create regulatory burdens that make it difficult to have the right relationship with a provider to actually get that collaborative practice agreement in the settings where patients are accessing pharmacist care. So there are many situations in which a pharmacist might need to prescribe or adjust the medication. This could be issuing refills in transitional care settings. This could be treating minor conditions that don't require a diagnosis, or in treating acute conditions where the pharmacy is the most accessible area to access care. And the last barrier I'm going to address is getting paid for clinical services. We're not necessarily talking about commercial payment here. We do have the ability to try and negotiate with commercial payers. There's nothing that prohibits a commercial payer from contracting with the pharmacist for providing these services. But under Medicaid presently in Nevada, we can only be reimbursed for a select few services, and it's those more recent services that have been authorized for pharmacists to autonomously provide. And that's going to be HIV prevention, dispensing contraception, and treating of opioid use disorder. The majority of services that pharmacists are providing cannot be reimbursed by Medicaid. So we would have to either exclude Medicaid recipients from being patients if we're offering these services, or charge them our usual and customary cash rate to receive services that others could access at the pharmacy. And just a quick list here, I won't go through each one, but just as an example of the services that pharmacists can provide, whether in a clinic potentially or within a pharmacy. Right now, pharmacists can address acute conditions, chronic conditions, a lot of preventative conditions, but this is a number of services that we know our patients clearly need. Some of them are already coming to us in the settings where we are offering services, but these are the services that presently cannot be reimbursed under Medicaid. And I'll turn it over to Adam.
Good afternoon. For the record, my name is Adam Porath, P-O-R-A-T-H. I'm the Legislative Director for the Nevada Society of Health System Pharmacists. I've been a practicing pharmacist here in Nevada for 20 years now. My day job is I'm the Vice President of Pharmacy Services at Renown Health up in Reno. I've been doing direct patient care in a clinic setting for 15 years now. And have had the pleasure of coming before the legislature since 2009 to continue to see the practice of pharmacy evolve. So where do we need to go next with this? When we look at where Nevada is compared to other states, a really good reference came out of the Cicero Institute looking at where things stood as of last year. For the three barriers besides payment that were identified. So administering medications, ordering and performing lab tests, and independent prescriptive authority. They developed a scoring system from 0 to 10 and ranked all 50 states. As you can see by this graph, Nevada underperforms compared to the rest of the western states around us, with the exception of Arizona, both scoring 3 out of 10. When we talk about coverage of pharmacist services, there's two concepts. Coverage parity is really, will a service be paid for regardless of who provides the service? And payment parity means, are we going to pay a pharmacist, in this case, at the same rate that we would pay another provider to care for that service? When we look around the country, just like the majority of states, Nevada is paying for some services that were mentioned earlier. So HIV prevention services, dispensing of oral contraceptives, and medications for opioid use disorder can be paid by Medicaid. And what that looks like around the country is highly variable. So some states have laws that require coverage of Medicaid specifically for all pharmacist clinical services. Some are restricted, like we have here in Nevada, by disease state, and others require both payment at both the commercial and Medicaid. Maryland took a unique approach in 2022. They got a work group of really a lot of different stakeholders. So legislators, the Board of Pharmacy, University of Maryland, all the state pharmacy associations. And what came out of that and was passed in 2023 was comprehensive payment requirement for both Medicaid and commercial insurers for clinical pharmacy services. What can we do here specifically in Nevada? We had a bill in the 2025 session, AB 186, that would allow practice expansion to some of the things that have been mentioned earlier. So would allow pharmacists to prescribe medications for that have been previously diagnosed. Self-limiting diagnoses like cold sores are diagnosed after performing a CLIA wave test. So things like COVID, flu, et cetera. Or allow pharmacists to dispense a one-time refill of an existing prescription in an emergency situation. This bill would have also allowed pharmacists to order labs and perform those CLIA wave tests and serve as that lab director. You know, that's when we think about one of the real barriers here to implement this within community pharmacy practice. If you're going to do those lab tests within a pharmacy setting, you have to be licensed as a lab within that pharmacy. So that's one of the real barriers that we have in our state. And again, more broad authority for medication administration outside of a pharmacy itself. The other is payment parity bills. So when we look at, there was a bill in the 2023 session that would have provided payment parity for both Medicaid and commercial insurance plans. And then in the last session, we had a similar bill that would require payment for all clinical pharmacy services within the scope of practice of a pharmacist for Medicaid only.
So in summary here, you know, we believe that pharmacists providing these clinical services it is safe, it improves patient access, particularly in rural areas, it improves patient outcomes, and we have considerable data to try to support this, and it can reduce healthcare costs as well. Pharmacists are well qualified based off their education and training to provide these clinical services, but it's these legislative barriers that are really preventing pharmacists from really using this appropriately in Nevada, both due to scope, but also due to payment for services. People will not offer a service if they can't afford to do it. And so those won't get implemented, despite having fairly recent legislation passed here in Nevada to help try to support those outcomes. And so we're recommending the reintroduction and passing of our previous bills here, both the Assembly bill and the Senate bill, to allow pharmacists to better serve the healthcare needs of patients here in Nevada. Thank you. With that, we're happy to take any questions.
Thank you all for your presentation. Thank you for being here and for waiting for us throughout the day. We hope you enjoyed your lunch here in the Legislative Building. Members, questions? Go ahead.
Thank you, Chair. I'm a practicing physician. I'm not a pharmacist. I'm not calculating creatinine clearance or formulating parenteral, you know, I'm not doing the things a pharmacist do. What would you say to people who say that training as a pharmacist, which is very rigorous, would not be equivalent to the training that a physician gets clinically with hands-on care?
I would say that's accurate. Physicians are trained specifically in this and for longer and end up completing residency training prior to their board certifications, things like this. And generally, you're going to have physicians kind of leading that care team. But there are other mid-level providers that also have rigorous training and have the ability to do this effectively. Pharmacists have proven that they have the ability to operate at that level. And the real barrier here is that, you know, if everybody could be a physician, we had just, you know, so many of them coming out of the walls, like that would be really awesome. The reality is that's not there. What we do have is over 2,300 trained pharmacists here working in general very close to the communities that they're looking to serve, even in rural areas, that are able to provide a lot of these services at a high level and with a lot of care and understanding and expertise to really help address chronic care needs, acute care needs, and things that are necessary. Dr. Porath, if you had
Adam Porth for the record. Yeah, I think, when you look at how is medicine practice in the inpatient setting, the physician is the diagnostician, and then they turn to the pharmacist and they say, and how can we best treat this? When we have rounds interdisciplinary at both our hospitals here in Las Vegas and in Reno, that's really the model that we have. When you extend that into the community practice setting, we're not talking about a pharmacist diagnosing every issue here. We're talking about if you have a patient that comes into the pharmacy and their A1C is out of whack and they're not optimized on metformin, we should probably have the ability to increase their dose of metformin. And so I think that there is obviously concerns with scope creep within this, but the reality is that pharmacists are going to be staying in their lane here.
Thank you. Can I have a follow-up question? Thank you. I think that scope creep is maybe part of the conversation. I think it's simply safety. I should not be the person that's in the pharmacy doing medication dispensing, and clinical pharmacists are very, very important. I wonder if you've considered having a narrow scope, like some other states like Ohio, which have extremely narrow scope. There's a pathway to prescriptions, but they work within a specialty under a certain provider. I know you've mentioned that there are collaborative practice agreements that can be made with practitioners. It's my understanding that in the state of Nevada, that's been extremely underutilized. That's not what pharmacists have engaged in previously. Do you have any thoughts on narrowing the scope, working with a practitioner, and having a very narrow scope of what that prescribing would be?
Yes, this is Zach Roscoe for the record. So in my day job, I serve as the director of pharmacy for a technology solution provider that enables pharmacists and pharmacies to deliver non-dispensing services. We work nationwide. I'm familiar with Ohio's laws and those in many other states, and what we've seen is very similar to what we see in Nevada in situations where you kind of take away or limit the scope to just a few select services or only to being under a collaborative practice agreement or an additional type of licensure just for some express pharmacists. You see a very significant limitation in implementation, and it doesn't really increase access for patients. There are other states who are already functioning where pharmacists are fully autonomous in prescriptive authority, in diagnostic authority, and what we haven't seen are safety issues or concerns that are actually arising in those states, and we're talking after several years of implementation. And we also see slower uptake there, but there's broader reach for patient care. Those all come along with the expectations that pharmacists are practicing within the standard of care, which means they know the extent of their training, education, and experience and what they should be able to provide with that and within the regulatory authorities that are given to them by the state. So that doesn't mean that every pharmacist in a chain community pharmacy is now diagnosing or treating all of these conditions. What you see in community pharmacies typically is some preventative care that is not addressed elsewhere, where there are gaps, and it's not going to discoordinate care providing those services being delivered. You see some acute care services in communities, and sometimes some specialty and specialty or more primary care services in community pharmacies, but typically it just removes barriers for pharmacists going into more collaborative practices with physicians and other providers in clinics in those states that have the more broad authority. So we're not seeing pharmacies delivering all of this care that otherwise would normally be delivered by physicians and primary care providers. It's really addressing those gaps and freeing up the physicians and PCPs to see the more complicated cases that are more appropriate to go to them.
Thank you for your answers. I'm very excited to talk to you about other questions. I have so many questions, but thank you very much for your thorough answer.
Thank you. Any other questions, members?
Yes, Chair.
Go ahead, Assemblymember Nadeem.
Thank you so much, Madam Chair. Thank you for the presentation and thank you for the great work you are doing. So my question is, taking care of a patient, it's not only about medicine. when a patient comes to a clinic setting, the doctor takes a history, then they know why something is happening, what is the reason, and how long it's been happening. So in a pharmacy, when a patient will go, how you're gonna manage the history?
Yeah, so having full access to those things would be really great. If we had a fully integrated medical system, I think a lot of physicians would really appreciate that if they had every note that a patient had since birth. But the reality is, again, we don't have those, and healthcare providers are trained to work and take those patient histories, understand what the patients are on. We do have access to what charting there is. We definitely are trained in the pathophysiology of these diseases and how we would normally treat these. And so a lot of it comes down to a lot of the skills and training that those pharmacists are developing in interviewing patients, just like any other patient who walked into like an urgent care clinic would have to do. Those providers don't have all of the information either. They're gathering that information and making the clinical judgment as they would need to. Again, within the scope of what the pharmacist is trying to do, particularly, you think about somebody coming into a community pharmacy perhaps with uncontrolled blood pressure. Okay, well, pharmacists are trained to take blood pressures. They're trained to review the medications that people are on, understand how to increase or decrease those doses if that's necessary, and document that and refer them to a physician as needed. The current model here doesn't allow for any of the ancillary services to be provided, though, as far as making sure that the other labs kidney function that might be affected by some of these drugs. There's not the ability to look at any of these things to make sure that provision of care is safe. And so while a pharmacist is, trained to do this, there's not the ability to really do that in a safe manner without further regulatory changes here with the law.
Yeah, Adam Porth, just to expand on that. And I think the other piece that's really important, I think, to address some of these concerns is we're also trained to know what a hypertensive emergency is. And so that if something like that walks into the pharmacy, that patient's going to be referred to the emergency department. That referral piece, I think, just shouldn't be missed in this model of care of that pharmacists do know when a patient needs to be referred to someone other than the pharmacist.
Thank you. Any other questions? Senator Titus?
Thank you. And thank you guys for being here, because I think overall access to care is critically important, and we need to look at everybody who possibly can be a resource, and certainly the pharmacists are a great resource and a great team member. So I appreciate that. I have a couple questions. First, the three of you, it sounds like represent or have worked in larger systems. I'm hearing Renown there. I'm hearing other pharmacist groups. There are the big stores out there that offer these services. The pharmacists are there, as I have already said, that is where I go to get my vaccines. So I'm wondering if there's a disconnect in when you say the rural pharmacist. First and foremost, I was in a practice where I was literally the only provider for 30 miles in any direction. There's no pharmacy there. I was the pharmacist. I was everything that umbrellaed healthcare. So saying that you think it'll help in rural areas, I'm not sure what that definition is. Do you mean Gardnerville that have these big pharmacies? Or do you mean my rural community or out in Goldfield, Nevada, Esmeralda County that we brought up where there's no pharmacies? How will it help true rural or frontier Nevada that don't already, because if you have a Safeway, you tend to have a provider. So I'm just wondering if you've connected to extreme rural areas where maybe they don't have a pharmacist, or if they do have a pharmacist, it's a small little Rexall drug. So have you done that reach out?
Zach Roscoe for the record. I think you've identified some problems we have and that are recognized where we don't have a lot of pharmacies existing in a lot of our rural towns anymore. And right now that you're correct. If there's not a pharmacy there, that doesn't immediately address the issues for that population. However, expanding access to allow both open up reimbursement and to allow for easier provision of services. For example, right now, even if a pharmacy did open in that rural area, if there's no other provider there, they can't really build that relationship to get a CPA with a physician there. But if they could autonomously provide services, there's now an additional revenue stream that might be able to support the limited dispensing that small community could have that could not support a pharmacy previously. And again, going back to my day job, I work with pharmacists in Idaho and Colorado in very rural areas. Similar stories. These are towns that have 1, 2, sometimes no physicians within the boundaries. And those pharmacists are providing limited acute care services, sometimes some limited primary care. And they're working to connect and address their overall needs and find primary care they can access, but take on some of those things that are overburdening the limited access to other providers they have in those communities.
Quick follow-up.
I would also add that you mentioned, if you have a Safeway, you probably have a provider. I think most of the patients that pharmacies are going to see are going to have a provider. It's not trying to replace that. Oftentimes, it's maybe a little bit more accessible, though, than running into like an urgent care. Let's say it's a Friday evening. Primary care provider is probably already booked out, or maybe he's left for the weekend, and your kid has an ear infection or strep throat or something like that. Being able to go to your local pharmacy, even if it is at a Safeway, and have the ability to do a test and treat for something like that is going to improve the provision of care. It's just it's enfranchising another person that's nearby to try to provide that type of care where you can.
A quick follow-up on that, and it's really along the same line of questioning that my colleagues in the South did ask you regarding the history of a patient when they come to the pharmacist. One of the things, if you just fill out a questionnaire and then you make your diagnosis, you're missing one of the key components in healthcare when we as providers do a physical exam on a patient. And I would tell residents and students when they would rotate me, just because the pulse rate is 35, 38, or 40, that may seem critical. If you just fill out a questionnaire and you look at that blood pressure and the heart monitor, the most important thing you do is look at your patient and you examine the patient. Is the patient breathing? Is the patient healthy? Maybe this is a chronic condition. And so where do you do those things? Not only the patient interview where you ask them these questions, you look at them, you take their history, where do you do the patient physical exam?
Zach Roscoe for the record. Great question, and I think this goes back to, we said it a few times, standard of care. This is standards of professionalism. In delivering any services, whether they're already in scope through a CPA, autonomous, or if, let's say, we expanded this and allowed these same services to be delivered autonomously, you have to assess what resources you have and if you need to have more. And that means a pharmacy that has a setup that only has an immunization cubicle out front, that there's no sound dampening, there's no true supplies to even do, thorough vitals. That's not the location necessarily that can immediately implement these services, and they would have to have some structural changes done to properly deliver these services. And that's the expectation, is that you will assess what services your community needs, how to safely deliver these, and do it the right way so that you're getting the same care that would be delivered if you access this service at another provider. And for some locations, that may, again, take time to implement, or may mean that they're not choosing to implement services. So I think the expectation would be the same standard other providers have, and then we would rely on our boards to address those who, if anyone is not following those standards.
Well, thank you for that, and thank you, Madam Chair, for the questions.
Thank you. I appreciate the opportunity to have a conversation about this issue. If you don't mind, we're going to move on, as we're not in a bill hearing right now, just an idea presentation. But I do appreciate the questions and would encourage you to have the follow-up offline to learn more about what is being proposed here. As we wrap up this segment of the presentation, I do want to take just a moment of privilege as the chair to recognize the number of folks that we have here in Southern Nevada who have spent a long day with us today. They are pharmacists, pharmacy students, right? If you all would stand so this committee could recognize you for your attendance today and this issue that I know is very personal for each of you. Thank you so much. Thank you for being here. We appreciate your time and your attendance at today's meeting and bringing this issue forward for our consideration. Thank you. Okay, that concludes our presentations for the committee. So that moves us to the final item on our agenda, which is public comment. Public testimony under this item can be presented in person or by phone or by written comment. Again, 2 minutes for anyone who is here who would like to offer public comment in person. Thank you. I see you're coming forward. We'll start with those here in physical locations here in Las Vegas. You may begin when you're ready.
Thank you. For the record, I am Lee McAllister, Executive Director of the Nevada chapter of the American Academy of Pediatrics. I have 2 brief points regarding today's very informative presentations. First, gun violence is a public health concern. The Nevada AAP strongly supports the policy priorities presented by the Johns Hopkins Bloomberg School of Public Health. We recently had a member of the Nevada AAP report a parent entering a pediatric office visibly armed with 2 holstered handguns. Staff were too frightened to act, forcing the pediatrician to personally intervene to enforce the clinic's clearly posted no guns policy. The episode left the doctor and staff shaken. Second, vaccinations. In regard, the AAP asks that you prioritize the medically fragile children who rely on community immunity to survive. I will submit a follow-up letter to this committee with the data to support structural and communication solutions to improve our state's vaccine rates. Thank you.
Thank you so much. While we're waiting for our next presenter to come up, I would just like to remind those who want to provide testimony on the telephone to dial 888-475-4499, and then when prompted, provide the meeting ID 876-3092-0944, and then press the pound sign. And we'll go back here to Las Vegas.
Thank you so much. My name is Ken Kunke, and I serve as the Executive Director of the Nevada Pharmacy Alliance. Just 2 points that I wanted to make. The first one is that you talked about vaccine access and making sure that pharmacies were able to provide those vaccines. We would love to be in those discussions, and we could reach out to all the pharmacies in the state to try to figure out where the barriers are. And one of those barriers is would be solved by reintroducing AB 186. Currently, the state law says that pharmacies have to work through it's like a collaborative practice agreement. So each physician or whoever they're working through gets to set some of those stipulations of what vaccines or what ages those vaccines could go through. So if AB 186 was passed, that would open that up. The second thing is pharmacy benefit manager reform is one of our big topics. We weren't presenting on that here today, but we would love to be involved in any discussions about PBM reform also. Thank you so much.
Thank you. With that, we'll go up to Carson City.
Good afternoon, Madam Chair, members of the committee. Leah Cartwright, Leacartwright, here today on behalf of the Nevada Psychiatric Association. The NPA's president, Dr. Barry Cole, he did submit a letter to this committee. I didn't see it posted online to Nellis. I will make sure to resubmit that. We sent it in Thursday. I just want to briefly comment on item 10 and the possible reintroduction of AB 186 of the 2025 legislative session. The Nevada Psychiatric Association was opposed to that bill in the legislative session. I would urge the committee to take a deeper look at that bill. The verbiage is or in all of those different requirements that they had to meet, or a CLIA wave test, or a self-limiting diagnosis, or an emergency refund. So any one of those criteria could be met in order to give a prescription. That's an issue in mental health. Oftentimes there is not a lab that will tell you what someone's mental health is. We do see on the CLIA waived lab test list, there are over 1,400 tests on the CLIA wave test list. Tests for things like phenobarbital. Lithium is a concern for psychiatrists, the lithium level, if a patient is compliant or not with their bipolar medications. That is not something psychiatrists are comfortable with having others touch. I heard mention of, fixing your metformin limits. I think my grandma's nephrologist and cardiologist would have a cow. They're always fighting between each other if somebody else tried to make a change. So that kind of gets outside the scope of mental health here. I'm glad we're talking about this early. I know I heard some comments on, the self-limiting diagnosis, the CLIA-waived tests that we can do. If you look at that CLIA-waived test list, there are things like pregnancy tests, urine screenings, fecal tests, vaginal swabs. Like, it's a big list. So let's look at, yes, the tests themselves may be safe. They may not have a risk of an incorrect diagnosis, but the treatment provided based on the results of those tests could cause harm and could be detrimental to patient care and public health. So I appreciate that we're starting this conversation early, especially as it relates to AB 186 of the 2025 session, and we will be in touch. Thank you so much.
Thank you. Seeing no one else up at the table in Carson City and no one here in Las Vegas, ABH, is there anyone on the telephone line who would like to offer public comment at this time?
To provide public comment, please press *9 now to take your place in the queue. Again, if you would like to provide public comment, please press *9 to take your place in the queue. Chair, we have no callers to provide comment at this time.
Thank you, AVH. Appreciate that. Would you like to offer public comment?
Yes, my name is Evan Mullins. I'd like to offer public comment in response to the representative from the Psychiatric Association.
Thank you. We're not, I apologize. We're not going to debate. That's what public comment is for. If you could just get your comments on, and you just did a presentation. So
I would like to talk about CLIA-waived tests, the number of CLIA-waived tests that are there. The count includes individual test kits and manufacturers and not unique clinical tests. That same test for a COVID-19 test or a flu test might be counted dozens of times when you hear that 1,400 number. CLIA-waived tests have been designated by CMS as waived due to being considered simple. Like other healthcare providers, pharmacists practice within their scope of training and expertise to provide clinical services reflected with the degree of care, skill, and diligence a reasonably competent professional will provide under similar circumstances. That would include within mental health. Again, if it's outside of practice, outside of the ability to provide the standard of care, pharmacist is unlikely to provide that. Specifically, pharmacists may choose to pursue postgraduate residency training and fellowships in mental health and behavioral health conditions and qualify for board certification as a psychiatric pharmacist with from the Board of Pharmacy Specialties following such specialized training, which would be an indication of the attainment of their clinical expertise. And limiting pharmacists from serving a particular population at the highest level of their scope is a disservice to those patients who would benefit from their expertise. Thank you.
Thank you. That does officially conclude our public comment for today. Members, I want to say thank you for your time and attention today. I know that it was a long day and we covered a number of very difficult topics. Our next meeting will be held on Tuesday, April 28th at 9 a.m. and this meeting is now adjourned.